Good morning. Welcome to a somewhat different version of Cardiovascular Fellows Boot Camp, the vascular track. In the studio here, I'm joined with my friend and colleague, Dr. John Knight. He and I have run a lot of these courses together. And online, we have additional faculty. The ones I can see at the moment are Sarah Edikan. She's one of our partners. She's going to talk about retroperitoneal approach to doing an aorta bifem. Mark Matos has just joined us, and Kim Hodgson has joined us. And so the way this is working, obviously, this used to be a 2.5-day event. Clearly, we couldn't do that anymore. So what we did is thought about what can we be most impactful in bringing to you. And one of the things that we've also run is an open aortic training program. Now that also used to involve people coming down here and doing hands-on, but a lot of it was video-based. And over in the corner here is the famous John Knight whiteboard, because it's very interactive. And John is a master at actually breaking down these procedures into very easy to digest chunks. So John, you want to say something about what the game plan is?
Yeah, I think it'll be interesting trying to do this with video, but I think the main focus is on interaction. Use the chat function to be able to ask questions. That's a good way to do it. And then the second, to remind you that we know who's out there, so we're going to try to specifically interact with you and ask you questions to see if we can improve the interaction between us. Because the more we interact, the more you ask questions, the more we respond, the better the chances that you'll get what you want out of this.
So yeah, so what we're going to do is we're going to use what's called the spotlight function of Zoom. In other words, we're going to be choosing 5 of you at a time, putting the spotlight on you, and those are the ones that we're going to be asking questions of. So don't be intimidated by it. This is meant to be a learning experience. But we've really found that if we interact with you, if you're not asking us questions, well, we're going to ask you questions. And that's true both of us in the studio here, but also the faculty who are out there at large. Dr. Hodgson, who's the past president of the SVS, do you have any comments that you'd like to make?
No, Alan, just that this has been an outstanding contribution to the educational programming for our incoming residents and new vascular surgeons. You should be commended for the work you and John have done on this over the years.
Well, thank you. Mark, any comments? Mark Matos basically has really been instrumental in trying to put matrices around how we evaluate people, and spent a lot of time really in doing that. So Mark, we haven't done that for this, but we're going to be really interested in your feedback after the fact.
Yeah, thanks, Alan and John, and welcome everybody. Yeah, I mean, these are challenging times to try and see how we can educate people through another medium besides one-on-one, contact and one-on-one sort of hands-on discussion. And I've been to the boot camp now for 4 or 5 years, and it's always been the highlight of our fellows. And this year's fellow is very disappointed that he can't be there in person. And so I think part of what we're going to try and do today, at least my part, is to try and add whatever expertise is out there, and to get some of the fellows understanding about exposures and what they need to be looking for, and approaches to with their hands and their visualization 3D imaging wise to become better at the dissections and safer.
So Sarah, we'll get you on board shortly, because you're going to kind of moderate that entire session on retroperitoneal exposure. So what we essentially had to do was, we can do this for 2.5 days. My butt could not take sitting here for 2.5 days. And so, what we discussed was, where can we add the greatest amount of value? And I think in general across the board, the increasing concerns are open aortic exposure. So this is a means of trying to focus down on that and trying to do whatever we can do to improve your understanding of some of the complexities of treating aortic disease. So I'm going to share my screen. Just number one is to let you see. These are the people who are signing on. There's, interestingly, usually we only take about 40 because that's kind of what we can handle back around cadavers. But this time I'll just kind of give you a glimpse. You have people from around the world. We actually could expand this up. So there's about 72 people who have signed up for this. And if you don't know all your peers, these are some of the folks who are actually signing on to it. Now, I also want to thank you for the ones who actually filled out the survey. That is incredibly useful for us, actually. And let me just show that again. Am I sharing that? So what we did was we asked you for to list the things that you wanted us to cover. And, you know, about 58 of you responded. We can't cover all of these. We really have decided today to focus on open aortic surgery rather than endovascular surgery. We may do that at another time in a completely different session. So some of these things we can't cover, but mesenteric bypass came up. We're going to cover that. Renal visceral perfusion, we're going to try and cover that. We're not going to cover things like transcaval endoleak treatment at the moment or fenestrated grafts. But this was very helpful, and there's a number of these we're going to try and incorporate to answer this today. I'm going to give you one pitch, and that is for ISEVS. I'm still the president of ISEVS, International Society of Endovascular Specialists. It's a multidisciplinary society focusing on endovascular procedures. We have the Journal of Endovascular Therapy. It's got a very high impact factor. These are the officers: President-elect is Irani Provincia, the Secretary Palmer Shaw, CFO is Marv, past presidents Vonko Krazier, cardiologist, and the Executive Director Ashley Hepner. So hopefully you saw that.
No, you got to share on Zoom.
I did, and that's how I showed the first one. All right, let me do that one more time. Let's see if you got that one.
There you go.
All right. I'm not going to repeat the whole thing. ICVS, these are the officers who are present within that. And come and join us. Normally we have the annual meeting here, and it's all hands-on. We ran what we think is the biggest hands-on endovascular meeting that's ever been run. Unfortunately, we can't do that this year. We've pushed it back to February. That may be a little optimistic. But with that, any final comments, John, or we'll just go ahead and start the videos.
Get it.
Okay, so we're going to start with videos on some of the basics, and that's how to set up the Thompson retractor. I love the Thompson retractor. I used to be an Omni person, but we've shared this and we've changed this now, and now we're starting to use the Thompson retractor. I will say the greatest advance in open aortic surgery were self-retaining retractors. I'm old enough to know that, go ahead, to do a new open aortic aneurysm used to be two medical students hanging on hooks at the top end of the wound, and then you tried to make them get out of the way in order to be able to do this. That is not good. So just run the video. That's the video, yeah. But you need audio. All right, let's figure out the audio here. You gotta mute me. Bear with us. Or that'll drive you crazy. Yep. All right. Let me go back to see if this works.
Still getting feedback.
Josh Delecta with Thompson Surgical. I'm here to show you the setup and the features of a Thompson retractor.
Sound coming out of you,
We're going to add the crossbar. Then we're going to add the angled arms to the crossbar. And lastly, the handles and the blades. In order to lock the cam joints down, you'll stick the rod in the serrated joint and rotate the cam handle down to lock it. Some of the features of the Thompson retractor is the swivel lock technology for the blades. Press the plunger in on the handle. And the top groove allows you to swivel 360 degrees. Or you can press the plunger down and lock it in place. The first thing you're going to want to do before setup is to make sure that this jaw is open. You just rotate this knob and open the jaw completely so you can add it to the table. Once the rail clamp is tight, you can add these handles and tighten it down so it's very secure. Next, we're going to add the crossbar. You're going to want the crossbar to be about 4 fingers above the patient's chest. Lock that in place with the cam handle. Next, we're going to add the angled arms.
So Kim, what do you use?
Then we're going to add the blades and the handles. So you can pick out whichever retractor blade you like. Add it to the handle. Clip the handle onto the arm, retract, and lock in place.
So the black ones are actually radiolucent, which is kind of nice.
One of the features Thompson Surgical has are malleable blades, and they will say malleable right on them. That means we can form this blade into any shape we want, depending on the anatomy of the patient. So a trick for adding the cam handle to the arm is to place the cam clip directly over the arm and press straight down. Rotate the cam handle back to lock. To disassemble the Thompson retractor, you unlock each cam handle by flipping it forwards. In the slot of the clip joint and rotate off the arm.
That's key. Then you lock.
Unlock and twist the joint off. I'll try to do it left-handed.
These are subtle little movements, but you can't get them off if you don't know how to actually do that. Get the crossbars apart and take off the various different retractors actually. John, what do you use? Stop that.
Well, so it depends on the case. So I actually prefer a Bookwalter for the average open abdominal case. And we'll get a chance, I think, later in the day, we'll talk about sort of how to set it up. For the thoracoabdominals and for the anything where you really need flexibility, the Thompson is I think, far superior to Bookwalter because it is so adjustable and you can move things around so easily. So let's get started.
You can talk over this. You can keep talking.
So this is a
So for
camera
most aortic
demonstration.
exposures, you do need to do a full laparotomy.
Go ahead.
And what I'm going to show is sort of a way to set up the retractor with sort of what your goals are for exposure of the abdominal aorta. And again, the Thompson is a terrific retractor because you can do almost anything with it. So here we're sort of eviscerating this cadaver. We're going to move the bowels essentially all over to the right side of the abdomen so that you keep that sort of mesenteric band. This is freeing the duodenum. And exactly, I guess what we're about to take is the ligament of Treitz, but it isn't exactly like a ligament in your knee. You know, it's really more of a concept than it is a ligament. Yeah, we're sort of pointing out, I think, what you would call the ligament of Treitz. I've had people tell me you should leave a little bit of peritoneum on the duodenum so you can sew it back together when you finish the case, which is completely wrong. The idea is you want to turn that fourth portion of the duodenum that was retroperitoneal into an intra-abdominal structure. So you clearly don't want to sort of leave a little rim of peritoneum so you could sew it back, because that would just retroperitonealize the duodenum.
So I've heard you say that before, John, and it makes absolute sense. But that's kind of contrary to what traditional vascular surgery teaching is.
I think it truly is. You really don't want to put the duodenum back in the retroperitoneum. You know, when you think about how you build a human being, if you started with a carcass and you put in 2 kidneys and 2 garden hoses for the aorta and the vena cava, and then you'd take everything else and put it in a trash bag and put that on top of those structures. And when you think about how do you get to those structures, and when a transabdominal approach, you go through the front of the trash bag, and then you got to go out through the back of the trash bag to get to the aorta and to the ureters and kidneys. And the duodenum is partially intra-abdominal and partially it is through the back wall of that trash bag. When you finish an aortic case, you don't want anything back there against that Dacron graft or whatever the graft is made of, because you're much more likely to get erosion into the bowel. What we're pointing out here is the goal is to try to keep all of this small bowel from bothering you during the rest of this aortic exposure. So I like to put my first lap in actually behind the cecum, and you can see I've sort of tucked in a piece of that behind the cecum and then wrap that lap around. You could do this with a blue towel, or you could do it with a lap. I do it with 3 laps. So I put the first lap in around the cecum, and I'll show you on this drawing a minute from now how I prefer to do that. Then I take a second lap and I overlap the first, and this comes up around the top of the aorta, and then usually it takes a third lap to finish this, is what is eventually an S shape. You can see I'm sort of describing it with my hand, coming from the right paracolic gutter, around the cecum, up the small bowel mesentery. And then I usually do try to put my laps on first and then tuck them under the belly wall if at all possible. Now again, some people just don't have enough intra-abdominal space to keep the bowel in. I think this helps with post-op ileus, but I think it gives you the idea of what you're trying to accomplish. The places that will bother you when you're doing aortic exposure is if the duodenum starts to sneak out from under your retractor. You're halfway through your proximal anastomosis, the anesthetic gets a little bit light, abdominal wall tightens up, and the next thing you know, the duodenum is sticking out at you. Same thing is true when you're down in the pelvis and you're trying to do your distal aortoiliac anastomosis. If you don't have the cecum and the appendix really tucked away, those structures wind up kind of prolapsing or herniating out toward you. So I try to really make that S shape around.
Can I ask a question? So
consistently,
I'm having
yeah.
trouble seeing. What's the S shape that you're talking about? Can you describe that?
I can show you on the on this drawing in a minute, or you want to stop and we can do it however you want to
Yeah,
do
we
it.
can, let's stop and explain what you mean
Can
by
you
the
do
S
that?
shape.
Let's go back live and let's show this drawing board.
Yeah,
if
can
we
you
can.
cut to the drawing board?
This will give the control room a headache. So what I want to show you again is, I'm going to draw over here if we can get this screen up. Got it there? Okay. So if we take the colon, appendix there, see if we can get this live camera. I assume it's not live quite yet.
Are we live, George?
So, okay, so you can see this. So, again, here's cecum, here's appendix, right colon, transverse colon, descending colon, sigmoid colon, aorta's here. The small bowel mesentery sort of falls in a diagonal line across the aorta and down toward the ileocecum. So what I think of is my S shape is I actually start my laps back here behind the cecum and I wrap around like that and come across. So that's the S, that it completely seals the cecum, the small bowel mesentery, and then across this direction. And that I usually do, personally, I do it with 3 laps. One lap that comes to here, the second lap overlaps to here, and the third lap then goes around like that. You can do this with a blue towel. It's just sometimes a little harder to do it with a single blue towel just because it's hard to wrap it in. I do this with the bowel outside the belly first, and then once I get my laps in place, then I tuck all this bowel under the abdominal wall. Then my goals with retraction are to pull north, because I want to be as far north as what's the limiting factor going north? Basically the SMA. I can't really pull beyond that without avulsing the SMA, and you do have to be a little bit cautious in people who have significant calcification at the origin of the SMA, because if you pull this retraction too much, especially if you use a retractor that has a little lip on it, you can actually create a dissection at the origin of the SMA. So you have to be a little thoughtful. But basically, the SMA is coming up more or less straight off the aorta toward you and off to the right side. Then the second thing I'm trying to do is accomplish retraction in this direction. So I'm trying to pull the duodenum and all of this small bowel over to the right side. So I think of that retractor straight north and then this retractor straight west, and then I can come around with other retractors to fill in the small bowel mesentery and cecum. Once you've got that S done, then over here all you need is just something to kind of keep the kidney and keep the left colon out of the way. So I usually just take a couple of laps, what I call a cannonball, just a wad of rag, put that over on the left kidney and push down. Same thing on the sigmoid, kind of push down. And at that point, you've got complete exposure of the abdominal aorta. Now, people will do this different ways, but when I watch other people do it, it seems to me they're still essentially achieving the same thing. The goal is to get this S shape to control the whole right side, and then some retraction on the left side to fully expose the aorta. And we can watch as we set up this Thompson how we would do it here. So let's go back to that video, if we can. And then we'll continue with this Thompson retractor. So what we've done there is we've got that north retractor pulling straight north. Now some people like to do a V at the upper end between
A
the two
soft
upper
entry
retractors.
into the abdomen. So we don't want sharp shoulders so that we're creating
But I think,
overhangs and cylinder-shaped retraction. So again, now we can put this right on
Personally,
the,
I think it's better to have a right angle between that upper retractor and the north retractor essentially in the west. In other words, what's pulling the duodenum over. Because if you're trying to get to the origin of the right renal artery, having a right angle between those two retractors is better. Whereas if you do it as a V shape, you can't get quite as far north with the close to that right renal artery. You do have to be a little bit cautious to make sure you don't pinch small bowel between these retractors. I have seen people get full thickness necrosis of the small bowel with where you get a bowel pinched in between the retractors. So you have to be thoughtful about that. The other thing is if you push down with the retractors too much, what are you going to be doing? You're pushing down on the vena cava. So you're losing your venous flow from the legs, and sometimes that'll cause hypotension. So if in the middle of the case anesthesia says, we're having a little trouble with the pressure, just taking that, releasing the pressure on the vena cava sometimes will get you enough venous return that it will improve the return of the heart and improve blood pressure. So again, these are cases, this is another point I would really emphasize, that the so-called blood-brain barrier, this piece of drape that sits between you and the anesthesiologist, is not soundproof. The anesthesia team and the surgical team need to be able to talk to each other. And you got to communicate during these things. You don't want, for instance, you don't want to find out that you got, Levofed and Neo running at the end of the case when you really didn't need to. You could have taken and for instance, you could re-clamp a clamp if the blood pressure is low. You can take pressure off the vena cava. There's things that you can do to affect the hemodynamics. And sometimes if your anesthesia team is just not communicating effectively, it's just not a good situation. So again, let's look at the retraction. So this emulates exactly what I drew on the board. We had our north retraction, fully to the west, and then the two retractors to the right side. You try to keep those left side retractors as low as you can. You can see how easy you can get to the aorta and the IMA, and now you can see both iliacs here in this cadaver model. So I try to take those the left side retractors on the left side abdominal wall and push toward the floor so that I'm getting an easy access for my hand to sew. Does that make sense?
Yep. All right.
So I think you can see the S shape here. Now,
yep.
You can do this with Thompson or you can do it with the Bookwalter.
So can we go back to the whiteboard, please?
Yeah. So again, you can see this S shape. Again, the whole goal is keep the cecum locked in, small bowel mesenteries locked in, transverse mesocolons out. Your retraction essentially on the kidney here and the sigmoid colon there. Those are the sort of 5 main goals, I think, and that's essentially how many retractors you need to get this done.
So what all can you do through this? You can do infrarenal repair.
So this is basically infrarenal aorta. So aortoiliac endarterectomy, you could do, for instance, through this exposure perfectly. Open abdominal aneurysm, aortoiliac bypass, the proximal end of aortofemoral bypass. You could do aortorenal bypass to both proximal renal arteries. So for the person who's got bilateral renal occlusive disease, you want to put an infrarenal graft with extensions, limbs to both renal arteries, that can be done. You can't really do, this is not a transaortic endarterectomy of the SMA origin. It's not going to be good for really anything proximal to the SMA. This is all renal vein distal. So juxtarenal aorta, this works great, right? So if you want to put a clamp above the renal vessels and do a juxtarenal anastomosis, that works well.
So if you're going to do renal artery bypass, the same setup?
If you were going to do, so that's a good question. So if you're doing a left aortorenal bypass, this works really well. A right aortorenal bypass, it kind of depends on what your inflow source is, right? Oftentimes you need to get to the distal renal artery, meaning you have to be on the other side of the vena cava on the right side. So for most of the right-sided renal arteries, you may have to do a medial visceral rotation of the right colon and Coker maneuver of the duodenum to lift it up off of the renal artery to really see that distal renal artery. For the left side, though, for a straight left aorta renal bypass, this would work fine. If you're doing a hepatorenal or a splenorenal, you could use part of this, but this is really focused on infrarenal aorta.
One other question, John, is at what point in the dissection do you set up the retractor, the self-retaining retractor?
Yeah, that's a good question. So my thought is I want to have 2 hands to operate when I get into bleeding. So you don't want to be putting in retractors too early because it ties you up and it actually impedes your dissection. So for me personally, I'd usually open the belly, explore the belly, make sure there's not a reason just to go home. If I find a cancer, then I got the rest of the day off. So I try to find out early if I'm going to have to stop early. Once I've explored, I'll try to take the small bowel and the right colon over to the right side as early as I can. And taking those initial cuts into the retroperitoneum, I usually do that without a retractor, depending on the size of the patient and their anatomy and whatnot. But if I can do that, and you can get the duodenum free before you put in retraction, it saves you a lot of time because you don't want to be getting the retractor in place. Now you have to reset it. So I usually try to get at least that much done before I try to put in a mechanical retractor. The other thing mechanical retraction does, it's good and bad, right? Once it's fixed in place, it puts a lot of tension on things. And that's sort of good, but it may not be good because one of the things you're doing when you're doing dissection is you're constantly kind of reading the tissue, right? And if you get things too taut with too much tension, you can obscure little veins, for instance, that would otherwise fill with blood and you can see and then you avoid them. Whereas if you get things under too much tension, the veins that get distracted, the blood gets pushed out. Next thing you know, you've cut across them and now you got to deal with bleeding that you wouldn't have had to otherwise. So being able to do a little bit of dissection, put tension, create, you're really just cutting adhesions when you're doing dissection. Create some tension, then relax the tension, create tension and relax tension, I think is really critical in vascular surgery in order to be able to feel the tissue, because you're kind of looking at it and feeling it simultaneously.
So yeah, so I agree. I mean, I use a Balfour retractor when I open the abdomen, and then I pack the small bowel, the colon, and then I try to do the aortic exposure.
You need to stop for a second. I'll bet there's 50% of the audience never even heard of a Balfour. Has anybody, surely, some of you have heard this, it's a historical instrument. They used to use it in
I'll get out of here. Balfour is a great abdominal wall retractor initially when you start. I usually leave it in when I put my automatic retractor in. Just put it in right over the top of it. It just helps hold the abdominal wall open.
So Balfour is that old slider thing with the kind of U-shaped things on it. And
yeah, but you can also get, I can't remember if it's got a different name, but it's kind of a double-bladed Balfour. It's got 2 on each side. I can't do that, but
I call that the big Balfour. They never give it to me. I always say big Balfour, and they just hand me the regular Balfour.
Yeah.
But the point is, it's easy to put in and easy to take out. The self-retaining mechanical retractors are not easy to put in and not easy to take out. You want to have the basics of the exposure done. I mean, I think of it as, I use it to get me to the aorta, then I want to hold it in place. And you can do a little bit of extra dissection around the renal arteries, for example, or the renal vein. But it's a real pain if you have to move that entire frame. So you kind of want to have the operative field set up before you put your mechanical retractor in.
Again, the other thought that I have is that you want to have 2 hands to operate when things get complicated. So when you're getting around blood vessels and there's a potential for bleeding, it's nice to have 2 hands, and that's where it's nice to have mechanical retraction. Because when you're doing the initial dissection, you got 1 hand that's basically a retractor. So you're tied up and you've just got 1 hand, however you're doing it. If you're alone, you're probably doing it with a scissor. If you're with a partner and you're working with a right angle or some way where you're sort of presenting tissue to each other with a bovie, you still kind of have at least, somebody's got at least 1 hand tied up. And if you're working with a surgical assistant and you really want to make sure that you've got 2 hands if you get into you cut the renal vein or you get some kind of a significant venous injury. you'd be more likely to get a significant venous injury than an arterial injury in that initial exposure. But if you did, obviously your initial response would be to pack it, but then you got to figure out sort of how to retract. So again, I try to do as much dissection as I can that's in the part of the operation that is the safe part, where there's less likelihood of getting into significant bleeding. When I start getting close to big structures that have names, then I usually try to get my mechanical retractor in.
Hey, Alan or John?
Yep.
Hey, listen, part of it, I think Kim's point is well taken as yours. And I think for the younger fellows and residents is that you have to break down the case into steps. And when you break it down into discrete steps, and you have specific goals, and in terms of what you're dissecting, then you can decide whether or not you're going to do handheld retraction or retraction with the Thompson or the Omni. And by breaking that down, then you're much likely less to have complications. And for example, if you're taking down the ligament of trice, you don't need static retraction. It's going to be dynamic retraction, and until you get to a certain point. If I'm a young fellow, I should be looking at preparing for this case and say, can I do this case in 10 steps or less? And then in the first step, what is going to be my instruments? What's going to be my retraction? And then basically, what's the second step? And so you should know what your first assistant's doing, what you're doing, what the retraction is for every step of the case, which will then allow you to determine how best you're going to do this case, which may be different from any of us.
Yeah, I think those are good points. There was something we didn't mention a minute ago, that is, don't forget that you can also, the two most common mistakes I see people make, one is setting the retractor ring too high up off the patient, right? So if you add depth by putting the retractor ring too high, next thing you know, you're using these big, long instruments. Big, long instruments are harder to work with. They accentuate your tremor. And when you're doing an aortic case and you've been mostly doing SFA angioplasties in an outpatient lab, and the next thing you know, you got to do a ruptured aneurysm, and you haven't done a lot of open aortic surgery, there's no question you're going to be more nervous than you would be otherwise. So there's you know, these can be challenging cases. You don't want things that are going to make it harder. So you want it to be shallow. Short instruments are easier to work with. So don't put the retractor ring up too high. The second thing is, remember, you can always flex the table. If you flex the table, just like using a kidney bar, if you're doing a kidney approach from a lateral incision and you flex the table, you can bring the aorta up. In a skinny person, you can do an aortic aneurysm without any retraction. You can use a Balfour perfectly and do the whole case. So again, flexing the table a little bit is a great advantage when you want to bring the aorta up out of the depths. Now, you know, when you have the big patient with the big front belly, sometimes you're stuck. You have to create a deep hole, and there's nothing you can do about it. But anything you can do to shallow the hole by flexing the table and by putting your ring, whatever the secure part of your retractor is, whether it's a Bookwalter or a Thompson, want to bring that down as close to the patient as possible. Now, obviously, you don't want to create pressure necrosis and have the thing rubbing on things too tight. On the other hand, a little contact between the ring is not going to cause somebody's abdominal wall to die. Sometimes the nurses get a little excessive with shoving sponges and towels and things under the ring to try to protect things. I've never seen anybody, you know, I wear a belt almost every day and my stomach doesn't die. I mean, you can take a certain amount of, you know, tension against your skin without it dying. You don't want to put excessive pressure, especially over the bones, but a little bit of touching. I'd rather have the ring a little closer than not. I also will almost invariably have on the right side, I'll have the ring a little bit higher than on the left side. Because the left side, I think of it as like a batter's box, right? That's where you stand in there and you swing a bat. You don't want anybody standing behind you. The catcher doesn't want to reach up. He gets his hand knocked off if he gets up too close to you. You don't want anybody in that space that's where it's going to interfere with your access to the aorta. So on the left side, I try to have the ring a little bit lower, the right side a little higher to accommodate the bowel on that side.
Okay, so I'm just looking at the chat that's coming in. So they have heard of Balfour retractor. That's
There you go.
Very reassuring to me.
Yep.
What if you get, so let me just emphasize, the reason that we're spending this time, because this is the operation, okay? You can teach a monkey how to sew a graft onto a big blood vessel, but setting it up is the key to everything. So the other mistake I see being made is you don't put the crossbar high enough. Right. So remember, the aorta divides at the level of your umbilicus. So that means you got an aneurysm. It's between your umbilicus and your costal margins. Right. So you need that upward retraction to get exposure. So if you put a crossbar at the xiphoid process, you can't do this operation. Right. So and there's nothing worse than you put all these retractors in, you spend all this time doing it, and then you got to take the whole thing down and you got to move the superior crossbar a little bit higher. So put the crossbar high and put the sidebars low and wide. Now you can't put them too low because there is a certain depth to the retractor blades, and so you don't want them sticking like this. But the nice thing, one of the things that I've really gotten to like about the Thompson is there's a little range that you can put in it, and once you get it set, you can actually angle each of the blades to whatever degree that you actually want them. I don't know that exists in any of the other retractors, because I used to be an Omni guy, quite honestly, from running boot camp and getting used to it, because there's certainly a learning curve to the Thompson that's a little more challenging to use than any of the others. So what if you get into trouble in the renal vein, John, is one of the questions coming in here. Or maybe I'll ask Kim that, or Kim. Yeah. Is Kim still there? So I've got in trouble with the renal vein.
I guess the question would be, why would I get in trouble with the renal vein?
Yeah.
So the issues typically with the renal vein is not injury of the vein itself, but injury of some of the branches coming into the vein, particularly off the left-hand side. There is often a rather large branch that connects to the lumbar venous or vessels. It is often embedded in a fair amount of fat, and it's easy to miss it if you're not aware that it's going to be there. And it bleeds just as bad, if not worse, as if you just cut the renal vein itself. So that's the biggest thing to be aware of. And if you're moving out laterally one side to the other, particularly on the left-hand side, you are going to encounter other branches as well. But
So one other point about the renal vein. You should know, before you get in the operating room, where that renal vein is and whether there's a circumaortic renal vein or a retroaortic renal vein. That's something that's on the CAT scan. We don't always look at it, but you should know where that is. Second thing is, as soon as I've got the duodenum mobilized, I'm getting on the aorta as fast as I can. I put my finger in the front of the aorta and I get down on the aorta. The difference between a vascular surgeon and the other surgeons is we are more comfortable around blood vessels. They're afraid of blood vessels. And we get in trouble for not being on the blood vessel. Now, let me tell you a mistake I made early on. I was not on the front of the aorta. I was kind of in the fat, and I was dissecting superiorly, and I came across a big vein. And I thought, here's the renal vein. What was it, John? It wasn't the renal vein. It's the splenic vein. And because if it sounds like it's impossible to do this. I'm telling you, it's not impossible to do it. You elevate up the pancreas and you see this big-ass vein, and it's the splenic vein, and then you're going, well, where's the aorta? Oh, my Lord, the aorta's way down here. And so when you deviate from it's why attendings are so focused on doing it the same way again and again and again, because when you change it, the anatomy changes.
Yeah, I think it's true.
First thing you do is get on the vessel and then track it.
Yep, get on the front of the blood vessel.
So this is the vena cava renal vein. Where you get branch bleeding is typically, so the three big branches would be the adrenal is up here, and again, it's usually short and fat. Gonadal vein usually comes in a little bit, almost the same opposite side. It's a more narrow vein typically. And then this represents that lumbar branch that wraps around the aorta.
So it's on the back of the vein.
So that's going posterior away from the vein. And this is the only blood vessel that you have to ligate to do a thoracoabdominal exposure from the left common iliac artery all the way to the left subclavian. If you expose the lateral sidewall of the aorta, that posterior branch of the left renal vein is the only blood vessel you'd ever have to ligate to show the whole thing. Now, these veins, if you retract too much and you decide later, oh, I'm going to divide the renal vein, it's not a great idea to take this, and then divide the renal vein, because you really have limited the venous outflow from your left kidney. If you think you're likely to take the left renal vein because you need access in here, don't mess around with these tributaries. Go ahead and divide the renal vein early. Now, again, I don't divide the renal vein very often. Almost always, I would say 90% of the time, you can mobilize this. Usually, it's not a problem. There are oftentimes a couple of little small branches right here off the front wall of the renal vein. I don't know where the heck they're going. They're going into sort of peri-aortic tissue. Those things oftentimes get avulsed, and they need a little 5-0 suture to sort of repair them. Avulsion of the renal vein from the cava. If you do that, you probably should just quit surgery. I mean, there's a level of competence that if you demonstrate that if you pull the renal vein off the vena cava, that's probably bad. You might actually do that sometime. And where you would do it is in a ruptured aneurysm, where you're taking your hand and you're trying to dig into this hematoma around the aorta. You know, most people who die from ruptured aneurysms who get to the hospital die from a ruptured aneurysm because of an inadvertent venous injury. If you don't damage some big venous structure when you're repairing a ruptured aneurysm, you'll probably get through the case. But if you tear the renal vein, or you tear the liver, for instance, trying to get a supraceliac clamp on, or you rip the spleen, or you get some other bleeding going, that's where people die. If you can get to the aorta and get a clamp on, really, at that point, most people ought to get through the case. So anyway, that's renal vein. The other thing I would remind you of, the only other vein, again, if you wander way, way far north, you can get to the splenic vein. When you're first mobilizing the duodenum, any vein that you come across in here that's vertical, any longitudinal vein adjacent to the duodenum, what would that be? Somebody might know. What's Peter DeVito looks like he's awake.
Yeah.
If you were coming down, you're mobilizing the duodenum, you see some kind of vertical vein right in here, what would that be? It's kind of longitudinal vein, somewhere over in this kind of left colon mesentery.
Can we see who's being spotlighted at the moment?
Can you hear me? I'm sorry. Okay.
All right. I'll answer it.
Is it a big one or a little one?
Yeah,
we're trying.
We just haven't got
Can you hear me?
sound.
All right, Peter. Yeah, we can't hear you, Peter.
Okay, cool. All right.
Are you muted?
Doesn't look like he's muted.
Okay.
So can you hear me? Yes, no, maybe, possibly.
No.
Yeah.
I can hear him. What's
Good
wrong with
for
you
us
guys?
to,
Work through this.
Making this more
Yeah, I
dramatic.
can
than it
hear him
needs to be.
perfect.
Okay.
it's probably everybody
Peter,
hearing
made it
except
down.
us.
Yeah, it's probably just us.
Okay.
It's just you, Alan.
Peter, can you mime your question?
I'd have to get pretty creative.
American Sign Language.
Yeah. All right. We'll choose somebody else then.
No, we got him now.
Sorry.
All right, we got
We
him.
can hear you.
All right, Peter. Go ahead.
Okay, here we go. You know, long story short is I didn't get a great idea during that. You know, splenic vein could be here. You could have branches of the portal vein that could be here too.
Yeah, a little lower.
Yeah.
You're down around, you're mobilizing the duodenum to
Not-
do the infrarenal aorta, and you see
You could have FMV or IMV too.
IMV. It's always going to be IMV. And which way do you take the IMV? And I've made this mistake. That's the reason I'm pointing it out. You come in here, you see this big vein, and sometimes it's sitting right on the duodenum.
Yeah.
It always goes to the left. All
Yeah.
venous structures in exposure to the aorta go to the left. So when you're mobilizing that duodenum, stay on the duodenum. Anything that looks longitudinal and venous always goes to the left.
Well,
If
that's
you-
interesting. It always goes between two clamps and a tie.
Well,
when I
there
do
is
it.
that. Now, Alan's making a point about can you ligate the IMV and what are the consequences? Would there ever be a circumstance you couldn't ligate the IMV? And I would say no.
Probably not.
Right, there's probably never. But what can you screw up when you ligate the IMV that you don't want to do?
Yep.
So
Mm,
remember, but when you're doing an aortic procedure, 99% of the time, the inferior mesenteric artery is going to be ligated. If you're doing an open aneurysm, it's almost always going to get ligated. You might reimplant it in a rare case, but generally speaking, it's going to be ligated. For occlusive disease, you'll almost never have a patent IMA, either because it wasn't patent to begin with or because it was ligated as a part of the reconstruction. So, if you know the IMA is either occluded pre-op or it's going to be occluded post-op, those collaterals coming off the SMA may be traveling adjacent to the IMV. And if you take a big bolt clamp and just clamp up there around the IMV, you may be getting the sort of meandering mesenteric artery or branches that will eventually fill the left colon mesentery and the sigmoid. So it's fine to ligate the IMV, but it should be done discreetly and not as a bulk clamp. You have to be thoughtful. They're all pulsatile vessels up there. And those you don't really want to take. Those things are really important when you've taken your IMA. So again, discrete ligation of the IMV is fine, but you don't want to do bulk ligation.
All right, Sarah, you ready?
Excuse me.
All right, yeah.
All right, so this is narrated. Do you want to narrate it or do you want me to put the audio up?
You can put the audio up, and then, I have some other things probably that I can add after the effect, but.
Okay, and you can put your PowerPoint up when we're done if you want it. Okay, let's see how this goes.
See what's going on in the chat.
Question is, are you getting the audio?
Well, this, I guess I can narrate it since the audio is not working. So this was a patient that I actually did for aorto-occlusive disease, but he also had a concomitant 2.5 centimeter aneurysm. And this is just the CT.
Along with severe aortoiliac occlusive disease, as visualized here. He was also found to have severe disease in his bilateral femoral arteries, as demonstrated on this CT scan.
Sarah, I can stop this whenever you want.
The patient was placed in a lateral decubitus position with left side up. The hips were about at 30 degrees and shoulders at 60, using a bean bag. This picture is of a different patient. However, it is used here to demonstrate positioning of a patient for retroperitoneal approach for aortobifemoral bypass. After appropriate position was ensured, we began by making vertical incisions over the bilateral groin to expose the common femoral, superficial femoral, and profunda femoris arteries. Dissection was carried to the skin, subcutaneous tissue, superficial fascia, and deep fascia until these vessels were dissected free of the surrounding tissue. These vessels were then controlled with vessel loops. To expose the aorta, an oblique flank incision was made from the tip of the 11th rib, extending toward the lateral edge of the rectus about 1 centimeter above the midpoint between the umbilicus and the pubis. We continued our dissection through the skin's subcutaneous tissue and then divided the fibers of the external oblique, internal oblique, and the transverse abdominis muscle. Laterally, the fibers of the serratus anterior muscle were divided. The retroperitoneal space was then entered laterally at the level of the costal margin, and all abdominal contents were gently retracted medially by blunt sweeping of the peritoneal membrane.
Sarah, do you want to make any comments?
So yeah, the important parts here are you can always go higher in the intercostal space if you need more superior dissection of the aorta, but for an infrarenal or just barely suprarenal plan, go 10 through 11. And then what we're doing here is bluntly sweeping away the peritoneal contents, making sure we're staying extraperitoneal. And you want to stay kind of posterior on the rib and then sweep everything kind of very immediately.
Okay.
This part of the procedure is pretty much by feel.
It's pretty much what?
By feel.
By feel, okay. So you get your hand up under the dome of the diaphragm in order to sweep everything down?
Exactly. And you can actually, if you're doing this, you can reach up and you can actually feel the cruce of the diaphragm from this procedure. So if you get into a situation, not classically, you're going to use this for a rupture, but where I trained, we used it for everything. So you can actually get your finger up at this point under the cruce of the diaphragm. You can actually tear the cruce if you need to, and then cross clamp the aorta with your fingers, and then finish your exposure while you've got control of the aorta.
Okay, I'll let it run.
Membrane and its content were mobilized. We brought in an Omni retractor to aid in our retroperitoneal exposure. Visualize here is.
So Sarah, can you say a little bit about how you got the Omni setup? Because the setup obviously is completely different.
Yeah, so, I'm glad you showed that Thompson video because I'll try it again next time. I tried to use your Thompson retractor for this case and couldn't figure it out and reverted to the Omni. But essentially you're gonna set it up so that you've got your bars like basically parallel to your incisions, one above and one below. And as you're, setting this up, and as with everything, the exposure is key. So you're basically going to have swept all of those contents, including your kidney, like medial encephalad. And then you'll see us set up the retractors here. And you want to pull until you start to see that cruce of the diaphragm. And then you can then get distally as well. But the key for me was to
psoas muscle.
Go ahead. I'll mute Majib.
That's all right.
We then
Just to get
developed
those bars
a plane
really parallel
behind the
to your
left kidney, and the left kidney was brought anteriorly with the abdominal structures in front of the infra.
Go ahead.
This retractor that we're putting in here is pretty key because this is what we call the spleen buster move in Albany. So if you are not careful, that retractor there is where you're going to end up.
So let me just stop for a minute because that's what Dr. Ide was talking about. That vein.
Right. See, yeah, that's the lumbar branch of the renal vein there.
So that's probably testicular ovarian vein. That's probably suprarenal vein. That's that posterior branch. And it's very easy when because you're pulling on, if there's a big aneurysm there, it's kind of being, you're pulling on the viscera and you're pulling on the aneurysm to a certain extent. This gets really stretched out and it's very easy to divide this. It's just not a good start when you're doing a big operation like this.
Yeah, but that particular is the lumbar branch of the renal vein, which is always divided in a retroperitoneal exposure. Okay. And here we're just further dissecting out the proximal portion of the aorta. We're actually dividing, in this case, we divided the cruce a little bit. We did a suprarenal clamp, but we weren't quite sure based on the preoperative imaging if we might need a supraceliac clamp. But the nice thing about this exposure is you're not limited. So if you kind of longitudinally take the cruce with some scissors. So here you can see if you can pause it.
Yeah.
No?
Yeah, no, I'll pause it.
So right here it's a great place to pause it. So what you always want to see is that left renal is going to be up and completely perpendicular to the aorta. So, the operating surgeon is kind of on the other side from this view, but it'll be perpendicular. And that's what you want to see in every retroperitoneal exposure so that you know where it is. That's the left renal.
Can I make one other point too, is that this is an infrarenal aneurysm. But a lot of the time you're doing this is for a thoracoabdominal aneurysm, and so the aneurysm extends up and involves that left renal artery. I've seen that left renal artery, just like that posterior branch of the renal vein, divided during the aortic exposure. That's just a very bad start for a thoracoabdominal aneurysm repair where you're worried about kidney function. And so here it looks pretty obvious, but it's really easy to get that thing stretched out and rotated. Not only is it possible to divide it, you can also disrupt the intima of it by pulling on it too hard. Okay, you're running. So
at this point, we've heparinized here, and we're just clamping Again, this was an aorta bifem. If you're doing a tube graft, you know, you wouldn't have done the groin exposure.
Now, what kind of clamp is that you're using?
We were using some bulldog clamps because that's what they had. My actual preference is to use Yaspergills.
And what are you clamping the aorta with?
I clamp the aorta with a straight Fogarty.
Yeah, so these are Fogarty hydro grips. They have a little soft inset. Me, I generally don't use that unless I'm really worried about the aorta in particular. But it has these disposable insets you can take out and throw away. They come in different sizes. Yeah. So when would you not use this incision, Sarah?
Me personally, never. But we're all affected by our training, and I've actually never done a transabdominal at all. We use this for everything, including ruptures in Albany. But
Okay.
classically, the teaching is you wouldn't use this for a rupture.
What about right renal artery? Can you get to that?
It is difficult. You can, but it is difficult.
Now you're dissecting, doing an endarterectomy of that proximal aorta.
Correct.
Well, that can be a little shaky. Do you do that in every case, or do you just do it selectively?
Not in every case, but in this particular case, the patient, you know, had, if we were to go back to the CT, had a fair amount of mural thrombus right in this area, and some pretty calcified plaque. So I don't always do it for the plaque, but there was sort of a mix of like really soft plaque and thrombus, and we didn't want that to, you know, end up in the renal arteries. So we did a selective endarterectomy and removed that thrombus.
Mm-hmm. John, you look like you're poised to demonstrate something up there.
Yeah, I was going to show you something. If we can go back to this drawing board, tell me when it's.
Yeah, let us know when that's streaming out.
Yeah.
The problem we're having, guys, is knowing what you're showing.
Yeah.
Let me ask you while that's coming up, or you guys tell me when this is on. Not yet, because I'm looking live. We're still seeing that.
Yeah, I still see the video.
We're still seeing video because I'm looking at what the stream is here. Let me, Sarah, ask you a question. Every time I do this, my patients come back a month later and they have this big bulge out in their left flank. How do you deal with that? Or how have you ever seen that, number one? And if you haven't, I want to know what you're doing to avoid it, because that's the Achilles heel of the retroperitoneal incision.
One of the risks of this exposures is a diastasis of the muscle. So the nice thing about this exposure is you actually have less of a chance of a hernia or a dehiscence than you do over the midline abdominal incision. But they certainly will get a diastasis. I think the important part is to let them know that ahead of time, let them know that you're going to denervate some things in the retroperitoneal exposure, but actually most of them get better over time. So I think a lot of it is about expectation.
Yeah, I have seen some of these people. I don't know if you have, but I've seen them get quite a significant bulge. And it's not really a hernia. You can't stick a patch in behind it.
No, it's a diastasis.
Yeah, diastasis. I don't know exactly what that means, but it's a big old bulge. I can tell you that for sure. So it can be pretty unpleasant. And I know people that try to preserve intercostal nerves when they do this. They'll literally try not to chop across these things, but it can be a challenge. Alan, have you ever had a problem with a bulging flank?
Yeah, I always say, I mean, obviously, I'm not fixing them anymore, so send them to general surgeons, but they say they're one of the more difficult things for them to take on, actually.
Right, yeah. Because it's really denervated muscle is what's happened mostly. Anyway, but that's one of the challenges with it. Let me show you this whiteboard a second. So this upper part, what we've got here is we've got a cross-section of the belly. Here's the IVC. Here's the aorta, and here's the left renal vein in front of the aorta, and here's that lumbar branch coming down, okay? Now, when you do a retroperitoneal incision, and you're looking in from this side, here's your eyeball, if you rotate the kidney up, when you're looking in from this left side, you're seeing a single vein. This is that lumbar branch. This is the left renal vein that's been, angled north or forward. When you look in from this side, the diameter here and the diameter here may be quite similar. And if you drift forward off of this, in other words, our general guidance is stay back here. Stay back toward the psoas. Because if you slide forward a little bit, you know, the renal artery's here, but if you slide forward a little bit, next thing you know, you'll ligate right there. And I think Alan described doing that, and I know I have made this mistake in a thoracoabdominal, and what I actually ligated was the main renal vein, not this little lumbar branch. So again, to avoid that, you want to stay as posterior as possible when you divide that vessel, because looking in from that lateral side, it's very difficult sometimes to see a diameter difference between those vessels. And you can ligate the renal vein if you drift anteriorly.
These are all not good mistakes that you want to make.
I mean, generally that kidney will survive, but it's not something you'd prefer to do. And it's one of those things you find later in the case. You go, how did I ligate the renal vein? And you go, well, I guess I drifted a little far anteriorly. So again, generally when you're coming in laterally, whether it's a thoracoabdominal or just a pure infrarenal retroperitoneal incision, stay posterior when you divide that lumbar branch of the left renal vein. Kim, have you ever had Kim, he may be gone, but how about Mark? Have you ever run into that?
No, not yet, but I have to admit that I don't do many retroperitoneals.
Right.
Yeah. So
but I think
that actually is a good point.
Yeah, exactly. That's what I was going to say.
You know, the main thing on these things is just like Sarah said, she can do everything from this incision. It's true. You know, you can do almost anything through anything if you're used to doing it. You know, and if when you try to do something occasionally, it's a lot harder than when you consistently do it the same way, because you know, all about surgery is trying to figure out, is this a hard case or is this an easy case? Well, if it's the only case you've ever done, it's hard. And so trying to develop a little bit of a stack of experience where you can sort of say, this is on the harder end and this is on the easier end, you never know that until you have a few repetitions. So I tend to prefer transabdominal, and I will tell you why. Because I usually am standing on an assistance position, which means I'm usually on the right side of the patient. That means if I'm doing a retroperitoneal exposure with a fellow, they're getting a nice view of everything, and I'm having to bend over the table to try to look in this hole from the other side. And I don't like doing that because my back gets tired and trying to lean over the table. If I were doing this alone and I'm just looking at the left side of the table, then the retroperitoneal incision is a much more appealing option for me. So I think developing do what you like to do, because if you're not happy, you ain't going to enjoy the operation. If you don't enjoy the operation, you're not going to get a good result most of the time. At least one person should benefit from every operation. That's a surgeon. So, you know, enjoy it a little bit, for God's sake. So if you like doing retroperitoneal, repeat it. You know, rinse and repeat. If you don't like doing it, do something different. But doing what you know how to do is much more important than trying to take on, you know, doing a novel approach every time you do it.
So
I think.
Yeah.
Go ahead.
No, I was going to say, yeah, I mean, I completely agree. I mean, it's sort of one of these, we're all products of our individual experience and training. And if you train at Albany, you're going to get real comfortable with the retroperitoneal approach. But I would never tell a resident who's only done one or two of these that that's how they should fix a rupture. You know, I'm comfortable in this space, but so I would do it there. But obviously, class teaching is not to. But you need to, especially if you treat every aorta that you do as if it is a rupture, and so you know exactly when it's going in, you'll be much more prepared in that situation, no matter what exposure you.
So Sarah, so what do you do with the criticism that most aortic aneurysms rupture to the left side posteriorly, which is kind of exactly where you're going to make that incision? So how do you handle getting control without getting into the rupture?
So so the caveat here being, anytime I say this is the way I do it, I want people to be understand that this is the way Clem Darling does it. Okay, so I didn't invent this. This is how I was trained. But when you get that retroperitoneal incision, you immediately can get your hand up and under all of those contents and sweep them with your hand, anterior medial encephalad, and you can actually get up and feel the crus. And now this is something you have to do ahead of time in all of your elective procedures, so you know what it feels like. But you can get up and feel the crus diaphragm, and you can actually tear that with your finger, and then you can get a cross clamp with your finger across it and get control of the aorta in a second. And then your assistant can then help you put in your retractors, and you've got control until you can get an actual clamp on. But that's the way it's done in Albany.
Yep.
But you have to have done it in an elective situation.
Yeah, there's silence here because again, when you've done it a million times, probably a piece of cake. I wouldn't recommend doing that for the first time. You'd probably stick that clamp straight through the aorta.
To be clear,
all right, we're both thinking the same thing. We're always looking for the disasters that can actually happen.
I only got my finger inside the aorta one time, fully inside.
Well, there's a great story about one fellow in Albany who made this maneuver and managed to tear the renal artery.
Yeah.
But again, this is one of those things that in your elective situations, do it the same way every time, and then you'll do it that way in a rupture.
But the point I would make is
you have to be very comfortable with it.
But for the fellows who are listening to this, you gotta know both. Okay, there are certain circumstances it ain't going to work going straight transabdominal, and you're going to have to go retroperitoneal. And so what we're trying to do is impart to you what are the bad things that can happen. So, for example, when I'm coming down the front of the aorta and starting to go onto the iliac arteries, what's the first thing that's flashing across my mind? I'm down across the aorta, I'm starting to dissect down the common iliac arteries, and I'm visualizing the ureters. It just automatically happens. And it's the same thing when you're doing this retroperitoneal exposure and you're coming up the aorta. What am I visualizing? And visualization is actually the right word. I'm thinking automatically, that posterior branch of the renal vein, and don't tear the artery off the side of a thoracoabdominal aneurysm, for example. And that's kind of what we're trying to impart to you. There's not a lot of things you got to worry about. There's really only left renal artery and that posterior branch, but those are the things that need to be front and center of your mind as you're coming up. And so you stay pretty posterior when you're doing a dissection of a thoracoabdominal through a retroperitoneal approach. You want to go, I'm almost on the front of the spine, basically, when I'm coming up. And that's the way I try to stay away from cutting the renal artery off the side of the aorta. You still got to deal with a vein.
I mean, you may be doing a inadvertent sympathectomy, but it probably doesn't hurt
Good for the blood
anybody.
supply.
The left foot will be warm at the end of the case if you accidentally cut some. There's not a lot you can harm over there.
Yeah.
So
it's
much better to be posterior than it is to be anterior.
Correct. And so the ureter is obviously something in the retroperitoneal you have to be aware of. One of the things that you do is you also flex the left hip, the left leg a little bit, and that actually relaxes the psoas and helps the ureter relax. Now you have to identify it and protect it, but that's one of the things that and also where you're breaking the table should be right at the iliac crest, and that'll help with that situation as well.
Now, one of
the only caveat to the anterior medial sweeping of the kidney is in a retroperitoneal approach if you have a retroaortic vein, and in that case you actually want to drop your kidney down.
Yeah.
Yeah. So actually, that's a good point. So the kidney can either go up or down in any of these retroperitoneal approaches, and there are situations where you're going to preferentially leave the kidney down. Sometimes with a transaortic endarterectomy, you may prefer to leave it down because you can follow the SMA out more distally. If you're trying to do a transaortic SMA endarterectomy, you may need to get a little distance on the SMA. If your kidney is up, the kidney now is obscuring your access to the more distal SMA, where if the kidney's down, you can follow the SMA out. And again, we're getting deep into the weeds, but again, you can take the kidney down or you can leave it up. One of the questions on the chat has to do with how do you keep from putting holes in the peritoneum? It's
carefully.
Carefully is one. One thing's for sure, the peritoneum is much more solid out laterally than it is in the midline. So
Correct.
the closer you get to the midline, sometimes you just can't do it. When you're up close to the linea alba, there are times where you just can't stay retroperitoneal. It's just impossible to try to peel the thing off. So you almost always want to start more laterally as you develop this plane and work anteriorly, as opposed to trying to start anteriorly and work laterally. Because once you're back by the aorta, you can get to it easily.
Right. I mean, we would always recommend that you kind of get your hand in and sweep and stay in that sort of posterior lateral position, and then sort of work and bluntly dissect.
So do you do it all with your hands? I mean, I tend to use sponge sticks, but you can push back there. Now, there are often bridging veins that bridge between the peritoneum and the retroperitoneal space, and they can bleed moderately. So if you can identify them, you're better off just clipping and dividing them and then continue to mobilize up the peritoneal cavity.
On the other
I do the majority of it. I mean, again, we do the majority of it bluntly, with a kind of a blunt dissection. And then you do want to keep the dissection fairly dry in a retroperitoneal approach, or else it gets a little messy.
That's a good point. So it needs to be dry going in, and it needs to be dry coming out, where you create this massive space back there. And you can put a hell of a lot of blood back there if there's bleeding that goes back, because you've essentially opened up a continuous space from the diaphragm to the left lower quadrant. And so it needs to be dry when you're coming out of it. Okay, do you want me to keep going on this video? Can we go back to the video, guys? I'll shoot it again.
Maybe.
Well, we're trying. Hold on. It's interesting. You gotta. Okay. There you go. It's a lot of work for me. Okay, Sarah, you're up.
Yeah, so one of the important parts here is the retroperitoneal exposure.
Anastomosis
you find
is
a lot
performed
Sorry. It's hard to
using suture.
Usually you're going to start sewing in the 9 o'clock position relative to, considering the angle of the operator. You want to sew around to 12 o'clock, and then you want to complete your posterior.
So do you do all of these with a parachute technique?
Say that again?
You parachute them all?
A parachute everything, but again, that's Albany parachutes everything.
What do you do, John?
I go back and forth.
Yeah.
If I leave the back wall intact, as you would for a typical abdominal aneurysm,
right,
I almost always parachute.
So here we're just removing
just the thrombus.
You might want to pause the video.
Yeah, I'm pausing it. It's interesting. There's a little delay when you pause them. Okay. So
sorry, Dr. Wright, please continue.
No, I was just going to say, if I leave the back wall intact, then I almost always parachute. So for a typical aneurysm, I would parachute. If I've transected the aorta, say for occlusive disease, and you've got an easy anastomosis, I usually go ahead and put a stitch in at 6 o'clock and then just sew around to 12. But we'll probably take a few minutes actually and kind of think about that. Where do you start your sutures, and what's the most efficient way to do that? We could talk about that now if you wanted to. It's not a bad
sure,
idea.
Might as well. I mean, we've got a nice example here.
Yeah. So, Sarah, when you said 9 o'clock, I assume you mean you're looking toward the head on a clock face. So
correct.
So here's the aorta, that's 12, this is 3, that's 6, and that's 9. So the vena cava is over here?
Correct.
Okay. And you're looking in from over here, right? You're looking in from the left side.
At this point, kind of, but you've transected the aorta, so you actually can look straight on it.
You're kind of looking at it. So you start over here.
Right. And then sew around to 12.
So around to 12.
And then swap and come around and finish your anastomosis. But it's all, again, parachuted.
And this comes all the way around like that?
Correct.
So that's interesting. I think that's interesting. It wouldn't be intuitive to me to go from 9 to 12, but that's certainly a way to do it. Yeah. So
How
are
would
you
do it?
sewing?
You would start at 7 or 8 o'clock?
Well, if I were coming in from over here, I would typically do my backside first. So I would be starting with, around 9 o'clock, which is a backhand bite if I'm standing on the left side of the patient and I'm going to right-handed surgeon, I would be sewing inside out across the back wall like that. And I would get over here close to where my left renal artery is, and then I'd switch to the other suture personally, and I'd sew outside in across the front wall and come back over here and I'd tie it off there. That's what I would do.
Yeah.
I'd go
Hey, John.
inside
Kim?
out across
Who's
the
that?
back
Is that
wall,
Mark or
outside
Kim?
in front wall, and then I'd be
Mark.
on opposite sides and I'd tie off.
Mark?
Yeah. Hey, John, I think that's great. One of the things for the fellows is that I think it's important. I know in boot camp in the past when we did it individually, is that you should really understand what each of those different sutures, what direction you're going to be throwing the stitch and how you're going to be handling the needle driver. And you should understand what that next throw is ahead of time so that you're able to complete that anastomosis really in 10 minutes or less if you really want to be efficient, right? You shouldn't be thinking about what the stitch direction or angle of approach or whether or not it's backhand, forehand, full hand grip, partial palm, full palm. You should already know what each of those throws is ahead of time. And that's how you should practice. And actually you need to be practicing in your simulation lab in a dry model so that you can actually understand what hand grip for every throw.
So the Albany dogma reasoning for doing this is when you start from the 9 and go to the 12 and then finish posterior, is that you're going to be able to visualize right renal orifice best in the initial sutures, and it also stabilizes your graph. You can then reflect it up, and it's connected there for the remainder of the anatomy.
Yeah. No, I mean, it's perfectly rational. Again, we're all, Mark's point, I think, is really important, is you can think about these things in advance. You really don't want to let the operation control you. You'd like to control the operation. Don't let your needle driver drive you. You should be able to put the needle where you want it to go. If you were, there's a surgical simulation tool that we use. It's a clock face that you sew some Gore-Tex, and the skill is to start at 6 o'clock, and so with you standing in this position, you sew at 6 o'clock, 7 o'clock, 8 o'clock, 9 o'clock, 10 o'clock. Most people who are right-handed surgeons, by the time you get to about 11 o'clock, you have to go backhand. Right? So at 11 o'clock, you usually backhand. 12 o'clock, meaning straight away from you, would invariably be backhand. Usually 1 o'clock is backhand, 2 o'clock, and probably 3 o'clock. By the time you get to 4 o'clock, you usually come back forehand. 5 o'clock is forehand, 6 o'clock is forehand. So you kind of have this mental picture knowing, for instance, so let's go back again to this aorta. So here's again, whether you're doing this, if you're sewing the aorta, here's aorta, renal artery, 12 o'clock, 6 o'clock. And if you were going to sew across the back wall, for instance, if you're standing here, this is basically, this is straight away from you. So you know this is going to be a backhand. It would have to be. You couldn't go straight away from you without being a backhand. And probably somewhere in here is backhand. This then shifts at about somewhere in here where all of this is a forehand bite, right, across that back wall. And that's why most people that are, I think they do aortas from the left side of the table. It's a left-sided organ. Certainly thoracoabdominals you do from the left side. But it allows a right-handed surgeon to be forehand mostly across that back wall. Now, Sarah, when you sew from here to 12, are you sewing outside in or are you doing this backhand?
No, I'm doing it backhand.
So you're going backhand inside out. Yeah. So that's one of the questions.
I can show, I've got a picture up here of sort of the angle of like what you're looking at from the operator. The video is not quite great, but this actual still picture is a good example.
Can we share
of the
Dr.
9 to
Radican's
12
screen?
position. do I have to do that?
You're going to have to do that.
All right.
And
we
I think
figure
you
it
need
out.
to
Hang on.
unshare me to let you share. So while you're doing that, I mean, one of the things when you're working with a resident, I basically usually start at 6 o'clock.
Okay.
And then I give them the needle holder.
They're
and
on the left side.
I'm on the left side of the patient.
You're on the left?
I'm on the left side. I stand on the left side.
Okay.
And
Resident's on the right.
Yeah, and they run it from 6 to about 11.
Yeah.
And then I take the needle holder.
Yeah.
And I run it 6 to, probably a little, not quite that far around, but probably 3 o'clock.
Yeah.
And then I hand them the needle holder, and they
And
run
they
the whole
finish it
front
up.
wall, and it's forehand the entire way. And they
Right.
sew 3/4 of the anastomosis.
Right.
I sew a quarter of it.
Yeah.
And what I always tell them is, I said, all you really need to know is where the last stitch is and the next stitch is going. And if you're sewing in a circle, hopefully they actually come back and meet. But you want to see where the last stitch is so you can judge how far you're going to move the next stitch that you're going to put in there. And so they follow and suck.
So I see Lauren Beliveau. She's one of our fellows in Baylor and Dallas. And she's heard me say this till she's sick of it. Well, she's heard me say a lot of stuff till she's sick of it. But that point of see your previous bite, I think is, any of y'all play tennis, ideally you actually see the ball hit your racket. And when you hit the ball, usually it's because you're looking about 5 feet ahead of where your racket is. You kind of watch the ball up to here, and then you blindly actually struck the ball. If you actually see the ball hit your racket, you almost always hit it right in the middle of the racket, and it goes where it's supposed to. Same thing happens when you're sewing. I see people think they see the previous bite, but they really didn't see it. And it's why sometimes you'll look at the final suture line, and you've got some sutures that are placed right on top of the previous bite. Then you'll have other areas, particularly in the middle of the back wall, where there's little pleats. And you'll think you saw your previous bite, but you really didn't stretch things out, and you've left a large gap or pleat, and then you'll get bleeding. So if you just see your previous bite and keep your distance consistent by seeing the previous bite, I think that's the key to the whole shooting match on, aortic, particularly aortic sewing.
But it's one of the advantages of a parachute is you can see it. I mean, the problem is when you tie it down, is it's a little more difficult to expose it. You parachute it down, you see exactly where your sutures are. Now, clearly, there's a secondary set of consequences. If you get a knot in it or you basically cross them up, then it may not pull down the way you want it to do.
Now,
do you tighten all parachute anastomoses before, with a nerve hook, for example, before you tie it?
Yeah, so that's a good question. And I think there's two things that are important there. One is, when you're following somebody and you're creating tension on a suture, you're really pulling up tension to tighten the suture prior to the one that you just put in. So you pull up a little bit of tension, that tightens the rest of the suture line. You have to relax a little bit on the suture that's about to get put in, otherwise your surgeon will tear the tissue because they're trying to separate the tissue a little bit to be able to see where the needle goes. It's hard to do that perfectly, especially if you've left the back wall intact. If you have a transected vessel, I think it's a little bit easier. But it's almost always simpler and safer just to go ahead and use a nerve hook. Two things about a nerve hook that I always try to emphasize. One is some of these nerve hooks get little burrs on them. They'll have been used for some other purpose or whatever. So I always test my nerve hook on a piece of suture that's not going to be part of the suture line. So test it out near the needle, just pull on it and make sure it doesn't cut it. Because if you've spent time doing a long anastomosis and then you go with the nerve hook and you pull a little bit and bang, you cut it, that's not good. I've also seen there is a thing called a leather valvulotome. Some of you may have used it for when you do an in situ vein graft. It looks like a little nerve hook. And I've seen people get a valvulotome in the nerve hook box, and they hand you that thing instead saying, oh, this is a nerve hook, when it's designed to cut suture. So that won't work at all.
The modified Mills valvulotome. The leather one is actually you hook to a catheter and pull it through.
Okay, well, the Mills valvulotome for sure. But the little hook
and there's a push version and there's a pull version, but make sure you haven't gotten a valvulotome instead of a nerve hook. The other is if you have placed, and many times you have to do it, is put a put a Wheatlander or a Weitlander, put a self-retaining retractor in to stretch the aorta. And sometimes it's even with just using a Thompson or a Bookwalter. You've stretched the aorta open so you can get a nice view of your sewing ring. But when you get ready to tighten your suture line, you ought to take some of that tension off of the retraction so that you allow the aortic wall to purse string as you pull up on it with your nerve hook. Guarantee, if you leave a self-retaining retractor in and you've got a lot of tension on the aortic wall, even if you pull it up with a nerve hook, when you take your retractors out, your suture line is going to be loose and it will bleed. So always loosen up those retractors as you pull up with your nerve hook.
Okay, Sarah, can we show Dr. Idicken's screen?
I mean, I've got it. It says I'm sharing it, but I don't know if I have to be given permission rather than my camera or.
I think we're seeing
No,
it.
I think we're seeing it. We're just not streaming it out yet. So you want to go full screen, Sarah?
That should be what the participants are seeing, right?
Yeah.
Let's see what's on chat.
Go to slideshow. Yeah, that's it.
Yeah. Well, I've got 3 screens, so sorry. Let me
They must be paying you too much
switch
money.
these.
Not paying me anyhow.
Just a second. Let me switch it around.
So there's one question that came up on, it says, how do you find the plane between the peritoneum and Gerota's fascia when you're leaving the kidney down? That's a kind of an interesting question. One is the fat around the kidney is a little bit different color. And if you do enough of it, you sort of can see that difference.
And it feels different.
Yeah, it feels different. I'm not sure it's that critical. I mean, the main thing is to stay out of the kidney itself.
Yeah, I mean, I think that's the key issue. You're not really looking when you start doing it. You're starting to develop this plane by feel. And basically the back of your fingers should be on the kidney. And so you just start developing that plane in front of it, and then you can roll up the peritoneum. So I'm not sure, it's not like, for example, a clean plane like there is in the true retroperitoneum. It's a little messier than that.
Yeah, so if you're essentially taking up the left colon mesentery, leaving the kidney down, your 2 errors would be to get too superficial and get into the left colon mesentery, and then you're going to get bleeding. So you don't really want to do that. You don't want to wind up with a window in the left colon mesentery by being too superficial as you make that plane. If you had a choice, I think you'd rather be in Gerota's fascia. If you saw the capsule of the kidney, it wouldn't be a harm. You'd much rather be deep at that level rather than tearing through the left colon mesentery if you're leaving the left kidney down.
Oh.
Hey, Alan.
Yeah,
John,
go ahead, Mark.
Yeah, quick comment. So, I mean, these are wonderful comments by everybody, but from the fellow's point of view, you have to understand that the number of open aneurysms being performed by trainees these years is not very high. And so this is so important to understand. It's not like we're doing 50, 60, 70 open aneurysms for most fellows this year. We're talking 8 to 10, maybe 15 during your training. And I would argue that this is where the simulation lab is so important. You should be practicing your parachute technique in a basic model. You should be learning how to sew the aneurysm from the left side and the right side because the view is different. And your needle driver is on the different sides, and you have to be able to accommodate both. And I just think in today's world, you have to be better prepared in the OR than you ever were before, because you're not going to get 60 chances to do this. You might get 10, you might get 12 as a fellow, and then you're going to be expected to know that when you graduated or in 5 years after you're arrested.
Yeah, so Mark, it's a great point in that there are certain things that you can practice. There's certain things you can't practice. You can practice the anastomosis. Not quite the same, obviously, but you should have your technical aspect of that in your mind. Now, the problem is the attendant is going to want you to do it their way. But what you can't practice very easily is the exposure and the kind of things that we're talking about today. We can't generate these complications. We've generated them, And that's why we're talking about them. And so it's this combination of the pure mechanics of sewing anastomosis you should practice. The rest of it, you're just going to have to be able to do it. And the best we can come to teaching this is to show you some of these videos and discuss it. Okay, Sarah.
Can we go back full screen to the picture real quick? Is it showing?
We see you.
I know you see me. Can you put up the image I'm sharing?
Can you? Are you sharing it?
It says I'm sharing it.
Yeah. Try unshare and then share it one more time. See if we get it.
Let's try sharing.
Yeah. Now it's coming. You got it. We got
How
it.
about now?
Okay.
So this is just
And
a
then
picture from the
put
surgeon's
it on full
perspective.
screen, Sarah, if you would. Put it on show.
Well, every time I do that, it switches to another screen. Let's see if that'll work.
Yeah. Keep it there. All right. Don't change it. Bad advice for me. Again.
No, it's just, here,
I
try
see.
this
So she's
one.
gone from 9
There.
to 12.
Yeah.
I see, with the transect of the
So-
aorta. Yeah.
I don't know if you
Yeah.
can see here, but so basically we've started at the 9 o'clock position and gone around to the 12. And what this does is it really gives you, because you're starting here, a good view of the entirety of the rest of the aorta. So you can actually really get good bites going around.
Yeah.
And also you can see the right renal here. In this particular picture, we're clamped, infrarenal. But if you are clamped suprarenal, then you will get a really good view of the right renal orifice going off this way.
Mm-hmm.
Sarah, something else that's noticeable here is that you've selected a piece of PTFE instead of Dacron. Was that an error? And how did you correct it?
No, I actually, we use PTFE preferentially in Albany.
Is that right?
Yeah.
Interesting.
So,
Yeah, actually, I didn't realize that was different. In my last case, I used Dacron because that's all that was downtown. But for my next case coming up, my next aorta bifem, I have some PTFE.
So let me ask you, what do you think the advantages and disadvantages are of the two materials for aortic reconstruction? Why do you like PTFE?
So here, let me end this show. We do, I would say, we'll preferentially use PTFE. Obviously, in an affected case where you want to cramp it so such, then you're going to, okay, then you will, you'll use Dacron. I find it easy. A lot of it is I find it easier to sew with, but I think that has to do with I have more experience with PTFE than the Dacron. And I think it's a little more resistant to purse stringing.
Yeah, it probably is a little bit so. I would guess that most people, most of the fellows, if they've done an aortic case, they've probably used polyester rather than PTFE. And I think that my gut feeling is if I had to ask people, why don't you use PTFE in the belly? It's for needle hole bleeding. I think that's the primary reason. What suture do you use for this?
That's a 3-0 rolling.
Using a 3-0 on an SH or an MH, or which needle?
Either the MH is a little can be a little big, so but I've used So it depends. Kind of depends on the quality of the aorta.
Yeah.
But the SH can be a little too small, so you have to make that decision frequently.
Alan, you use what?
I'm pretty traditional. Dacron and proline. Usually 3-0 proline and SH needle if the aorta is really bad and I want to take massive bites to incorporate the periaortic tissue, then I'll ask for an MH needle. The downside of that is a little flimsier than the SH needle. SH needle is not that easy to bend. The MH needle is very easy to bend.
Right.
So why do you ask about which suture in relation to PTFE specifically?
Yeah, so the issue with PTFE is needle hole bleeding, right? So if your suture is smaller in diameter than your needle, then you're going to have more needle hole bleeding. And that's the concept. Some of you may use PTFE suture. Gore-Tex makes their own suture, and it's a big fat suture that really fills the hole so you don't get any needle hole bleeding. The other problem with PTFE is if you take your needle and go through PTFE diagonally and don't follow the curve of your needle, you create an oval hole. If you create an oval hole with a round suture, you're going to have bleeding around it. So it's not like it's life or death. Well, it is life or death, come to think of it.
it's not like it's going to make a huge difference, but there will be some needle hole bleeding, and you got to figure out how to solve that. You know, there's different ways to do it, and some people like to use glue, for instance. I know people that use glue every time they use PTFE just because of needle hole bleeding. PTFE is nice in a lot of ways, but I think its Achilles heel is needle hole bleeding, and I think following the curve of the needle probably is the most important point. Most people don't love PTFE suture because it has a lot of drag. It doesn't tend to slide easily. So you wind up with, you really do have to use a nerve hook to get it to pull up tight. But if you do that, it works very well. And again, this is, you know, I have used this expression before. Alan's heard me say it. You know, we're, as vascular surgeons, and I see Lauren's she's gonna screw up her nose when she hears this. We are cobblers, you know, we're little cobblers working in the back of these little shops. And we try to make one really great pair of shoes at a time. And we go in, we feel your foot, and we kind of count your toes. And we ask you, what are you going to do with these shoes? Are you going to be a ballerina, or are you going to be playing football? And we say, how tall are you, and how much do you weigh? And then we try to design a shoe for that foot, and we make one perfect shoe at a time. Well, we don't knock out 10,000 shoes like Nike's. And that's kind of one of the problems with trying to teach this is you're making decisions that are subtle between cases. And there are reasons you choose to do things at one time or another because this works better in this setting than another. And each of us kind of develops our own little quirks to solve different problems. And it's not as though PTFE is good and Dacron's bad, or Gore-Tex suture is good or not, or starting at 9 o'clock and going to 12 is good or bad. We're solving the same set of problems, and we've all come to different ways of solving that problem. If you don't know what the questions are, though, then you don't have an opportunity to try to solve the question. And that, I think, is the main focus of a meeting, a talk like this, is try to identify what the questions are. How you solve it is going to be up to your creativity, and y'all are going to come up with better solutions than we have. You know, we're not pretending this is the right way and the wrong way to do it. It's just different ways.
So there's a couple of questions about, specifically for Sarah, and it's about when do you start sewing inside out, outside in? Does it matter?
So I would say that is based on, you know, where your flexibility and your comfort level. If something's difficult, then do it the other way. So generally start inside out, you know, the way around, and then switch. And so there's you know, one of the things that the residents and always wanting to do with me is, you know, they want to make a U-stitch back through the graft or come the other way. And so it's not classic surgical teaching, but unless you train at certain institutions, but you can actually switch one of those sutures. And so I try to come, you know, inside out the entire time. Just because you have your suture maybe on the outside and you now need of the aorta, but you need to switch it around, you can just switch it.
So it's pretty interesting because at Emory, we were strictly inside out guys. Here, on the aorta, I would say you can sew an old sock in the aorta and probably get 90% 5-year patency out of it. It doesn't matter. I don't think it matters a damn. You sew it whatever is the easiest way of sewing it. Now that's totally different if you're talking about a tibial artery. But for the aorta, I don't think it makes any difference.
Again, really, the question is, why sew inside out? You're sewing inside out to prevent an intimal flap. You're trying to go inside out so you catch the intima, the plaque, whatever's there, trap it up inside the anastomosis. If the wall is basically monolithic, if it's not fragmented, and you can support it a little bit and sew outside in, it doesn't make any difference. And so the idea that outside in is bad, inside out is good, again, what's the problem I'm trying to solve? The problem is I'm trying to get these two things stuck together and not bleed, and I'm trying to do it as efficiently as I can. And if sewing outside in isn't going to lead to intimal flaps, there's no good reason not to do it. So now, I don't like to tie on the inside of a vessel, and that is also a Houston thing. That sometimes you put, I know some famous surgeons down here would take their back wall stitch inside aorta to outside and outside in on the graft and tie on the inside of the aorta. That seems like an excessive challenge, but if you compare how much that little knot inside the vessel probably doesn't make a bit of difference inside
Well, in their
a great big
defense,
blood vessel.
if you looked at the aortic valve,
Yeah, exactly.
I mean, they put about 100 knots
Right.
and sitting on top of the
Right.
aortic valve. So I think it's
Right.
kind of partly the cardiac influence. Okay, Sarah, we probably should. There's a bunch of questions we'll deal with, but how about we finish off your video? So I think you need to unshare so that I can share.
I'm unshared, I
You
think.
like to share?
One of the questions was about, can you do an end to side anastomosis? I think
Yes.
it was either end to side or end to end.
Yeah, this is end to end, but you certainly can do an end to side. It's very similar.
Okay,
You don't have to be straight on the aorta.
let's finish off your operation, and I'll see if I can keep Dr. Mujib muted. Oh, you.
So here we're actually we had trouble oversewing the iliacs here, so we actually did a little localized endorectomy due to the calcific disease, just so we could actually oversew those because the aorta-iliac disease was so severe. So that's what we're doing here. You can see the left and the right renal. We're oversewing lumbar branches, lumbar arteries from the inside of the sac here. Be standard for no matter what approach you're doing it from. And then we've already created tunnels here, but this is where we're actually tunneling the graft. Basically, you want to stay anterior to the artery. The
All right, how
biggest
do you do
risk
that?
in this when
That's
you're
probably worthwhile talking about for a minute. You've already
Yeah.
got the femorals exposed here.
correct. Well, you do that first before you open the abdomen. Correct.
So you got the femorals that are exposed, and the abdomen's open. We're about to heparinize, and we go, oh, we got to make the tunnel.
Right. And so at this point, you want to stay, basically, it's a combination of blunt dissection and you staying with your finger and staying right on top of the iliac arteries. The biggest danger here is when tunneling on the right side. If you damage the right iliac vein, that can be sort of a fraught situation. So I recommend that you avoid doing it, if at all possible.
And the key to that is staying right in front of the artery. So by and large,
Correct.
these arteries are calcified. So you essentially put your finger up the tunnel. We'll diagram this in a minute.
Yeah,
and you
from
should
both
be feeling
sides,
that artery
correct.
in the back of your finger the entire way, and then you basically start from the abdomen. But you can't have long enough fingers. You got to meet in the middle somewhere.
Correct. And then I use a big, either a Surratt or a big DeBakey aneurysm clamp, and you sort of slide that from the femoral up into the retroperitoneal cavity. You grab your graft and pull it through.
Ian
But,
asked what glue, when we talked about if you ever do use glue, I think they use just bio glue. And I've seen people use dermaglue.
Back bleeding, lumbar arteries.
All right, see if I can shut the jib up again.
Well, we have to give credit to Mujib. He really helped edit this video,
Oh,
and
yeah,
he
I know.
wasn't even the resident in the case.
Yeah.
So I would like we don't
Yeah.
necessarily want to set him up, but
Y'all
we
really
appreciate.
must drink a lot of coffee up there, though.
We're
As
fast.
fast as you sew, I think it's.
Well, we're just that slick.
I believe
No,
it.
so
I believe it. That's why you squirt your hands so they don't smoke, right? Let me ask a question. Okay, this is some of you have heard me go through this before, but there's 4 causes of suture line bleeding in the proximal aorta. Suture line bleeding, number 1.
So are we back on Kim here? Can we show him?
Kim or
Yeah.
John?
we're seeing the video.
Kim or John? Yeah,
Either
sorry.
one.
I just waking Kim up pretty good there.
There we go. All right, so we've
Suture
got
line bleeding.
there's 4 causes of suture line bleeding, as far as I can tell.
Yep.
Let's see. Are we on?
Okay,
Let's
Kim
do the
thinks
white.
this is a test. So
Yeah.
why don't
Oh,
you let him
good. Okay,
answer?
good.
It's a test. What are the 4 causes of suture line bleeding?
Are we
And
pimping
Hodgson,
Dr.
Hodgson, and Hodgson is not the answer.
Well, I mean, there's the obvious thing if you take in inadequate spacing or, something
Okay,
like that. Probably the
inadequate
most common
spacing.
thing would
Another
be
term for that is a pleat.
Travel.
Okay, I call it a pleat.
Inadequate tension on your suture line. It's not at all uncommon to have a loose suture line, and if you don't pull it up tight, particularly around the back wall before you do your final sutures, you can have that issue.
Okay, loose suture.
sometimes you have a a large chunk of plaque or something, particularly posteriorly, and you kind of got to figure out whether to work around it or yank it out of there or something. It kind of creates a little bit of a wall apposition
So
problem.
there's 5 causes of suture line
That's
bleeding.
number 5 we just got. Okay, that's good.
Number
All right.
5.
That's why it's
okay.
dynamic education here.
Yeah.
Well, I guess in the old days, maybe you forgot to pre-clot your graft, but I guess we won't talk about that. So what are your other 2?
I got needle hole bleeding.
Well, but nobody uses Gore-Tex in the abdomen, and you have to deal with it.
Except in Albany.
Okay. Needle hole, and 5 would be suturing to plaque. And this is a little different than the other thing. So let me just make sure everybody understands what I'm talking about. So a pleat is where you put your bites too far apart. So you got a pleat that's bleeding. How do you fix a pleat if it's bleeding? So you've put your suture's too far apart, you've got a gap, in other words. How do you fix that?
We put a stitch in it.
You put a stitch
You
in
asking
the
me?
apex of the pleat. You don't typically need, as Dr. Lumsden unfortunately does, uses a felt pledget. You've already got half of this is synthetic. You don't need felt on felt. You don't need felt on Dacron ever. The Dacron is solid. The only place you need a pleat is when the structure of the aortic wall is insufficient to hold tension. So for most pleats, the aorta's fine. The gap was too big. So a single pleat, a pleat is a single bite in the apex of the pleat. How do you fix a
Either
loose
that or
suture?
you can put a horizontal mattress across it, depending upon the situation.
That's, yeah, if you really had a gigantic pleat. But most pleats can be fixed with a single stitch in the apex of the pleat. And generally, it's easier to drive from the Dacron up through the pleat. And because just is easier, right? It's simpler to do it.
Do you use the same size needle and proline, or do you? A lot of
So it's
people
a good question.
downsize it.
Yeah, so that's a good question. So Alan is asking, should you stay with your 3.0 proline or switch over to, let's say, a 5.0 on an RB1 or a 4.0? And it kind of depends on, depends on the size. Occasionally I'll use a 5. Usually I just go back to the same thing I've got. I'll just use a 3.0. But you could easily use a downsized suture for a pleat. But generally, if I consider that part of the structural part of the anastomosis, I'll usually use the same structural suture that I'm using, which is usually a 3.0. The other thing I should make a point of, 3.0 suture comes in a variety of lengths. You don't want to do an aortic anastomosis with 36-inch suture. Use 48 or longer. We used to get 54-inch sutures cut for big aortic stuff. It means you can follow from enough distance where your hands are not down in the wound. So don't get started with a 36-inch because you can't parachute but a couple of loops and you've run out of suture. Your assistant can't really follow you without getting in the way. So take the time in advance. Almost everybody uses a 3.0 proline on an SH needle with a 48-inch cut. So kind of, think about that before you start. Okay. Everybody knows how to fix a loose suture. You take a nerve hook, you pull up on the suture till you have a loop. I did not learn, I will tell you, I'm going to admit this in public, I didn't learn that you put a little silk through that loop until I was an attending for about 15 years. I kept trying to tie to that damn thing with a little, with a machine tie, with an instrument tie down in a hole. And one of my residents said, oh, just put a silk through that and pull up on it and use it for a tag. So for any of you who haven't seen that trick, don't be as stupid as I was. Take a little silk, put it through the loop, and tie to it with a separate stitch.
You're using it as a long handle.
Yeah,
correct.
Can you show them that?
I'm sorry?
Can you show them that? I'm not sure everybody knows what you're talking about.
Yeah, actually, it is a good point. I assume all of you know that. But basically, again, you pull up your suture with your nerve hook until you have a little loop sticking out. And then instead of trying to tie to that with an instrument tie, take a silk and put it through to create a handle on that loop.
So I'll tell you what we'll do. There's a break coming up. We'll get
Yeah.
some proline and some silk.
Probably
And
a good
we
idea to do
can
that.
actually demonstrate that.
All right, so the pleat we have single stitch, loose stitch. Now calcium, I think this is a really good point, Kim. If you have a big rock of calcium in the middle of your suture line, 2 things are problematic. One is you just can't get the suture to pull down tight, and you'll have bleeding around that rock. The second thing is you'll shear your proline occasionally. When you start putting a little tension on it, the calcium is sharp enough, it'll cut through the proline. So I usually will try to take substantial chunks of calcium out of the anastomosis. The strength of the aortic wall is in the adventitia. And you can do a full thickness endarterectomy of the aorta and still do an end-to-end anastomosis, and it'll hold water. It's structurally strong enough. So don't worry that it's going to fall apart. You know, we do endarterectomies of the carotid artery lots, and none of those people get aneurysms, or very rarely do they get aneurysms. So it's something to think about. Needle hole bleeding, and by this is needle hole not in the graft, but in the aorta. And how do you get needle hole bleeding? Needle hole bleeding occurs because you lever the needle as you go through the aorta. You're trying to hit the aorta and then reach for the graft. And as you lever against that aorta, you may get little longitudinal tears in the aorta. So how do you fix needle hole bleeding in the aorta? What you don't do is put another vertical bite in. The goal is to close that longitudinal tear from side to side. So in this case, I almost always use like a 5/0 suture, something small, and just put a little figure of 8 around the suture hole, around the needle hole. So you're pulling the needle hole from side to side around the suture, just tucking it up, and don't put another vertical bite. And I've seen people put more vertical bites, and all you do is put more longitudinal tears, and it just makes the bleeding worse.
Does that need to be full thickness? Where you just grab the...
No, it's a great point. Alan made the point. This does not need to be full thickness. This could easily be just an adventitial bite, a little Z-stitch around the needle hole. Boom, stops the bleeding. Now, so we've been through 4 of these things: pleats, loose sutures, calcium, and needle holes. None of those things do you need a pledget on, right? Pledgets are little pieces of felt, and they're designed to create some structure when the aorta is just falling apart. Now again, some of your attendings are going to use pledgets all the time. They'll sometimes use felt strips. I think Alan likes to use a felt strip around the back of the aorta. There's nothing wrong with it. It's just not necessary most of the time. But at any rate, all of these things, what I would caution you is this. You got known causes of suture line bleeding. Some people have a reflex. As soon as they have suture line bleeding, they grab a pledget. That's not a great thought, because you don't need a pledget in most of these things. And the second thing that happens is once you put a pledget down and you still have bleeding, the pledget has now obscured your access to what the heck is bleeding. So you wind up with a Teflon mountain. You wind up with a pledget on top of a pledget on top of a pledget, and you still haven't really fixed the problem. You're much better off to find the cause of the bleeding and fix that. Now, the last thing is plaque. Now, what I mean by this is this. Okay, particularly when you're doing an end-to-end anastomosis on the aorta for occlusive disease. I'm going to draw, this is going to be a horizontal view of the aorta. You've transected the aorta. Here's the distal part of the aorta down here. So this is proximal, this is distal. Let's say that's a renal artery coming out at you. There's little pairs of lumbar vessels that are back here behind that. You've transected this vessel. You're trying to kind of pull this up and look at it, kind of like Sarah's shown in that picture. One of the things that can happen is that the lumbar branches can act as a tether on the adventitia, and you wind up with a the plaque kind of sticks out from the adventitia. And it's worse on the back wall because you've lifted up, and the front wall, the adventitia is in line with the plaque, but on the back wall, the adventitia is sort of receded. And your whole stitch across the back wall sometimes will be just through plaque and not full thickness. You won't have gotten any adventitia. That won't work. And it'll start to look like it'll work. You'll take your clamps off, you'll have sort of hemostasis, but you won't have adequate hemostasis. And you may, if you've got the reflex to grab a pledget, you'll throw another pledget and then another pledget, and all you're really doing is throwing pledget to plaque, and it doesn't solve it. If you have managed to sew plaque on the back wall, you need to cut out your suture line and start over. And it's one of the reasons that I usually try to divide the lumbars that are adjacent to my anastomosis so that so the aorta can come up and I can easily get a full thickness bite in that back wall without struggling. You don't want to make it hard, and if you'll divide the first couple of pairs of lumbars, it makes it easier to lift that up so you don't get that kind of retraction.
Okay, we're kind of about 15 minutes behind. We need to take a break. Sarah, you got any final words?
I think I'm kind of responding to it in the comments now, but there was one additional question about, if you have a very angulated neck with like a strange takeoff of the right renal, how do you go about figuring out where everything is? We've sort of addressed it, but I think the importance is to stay on the aorta, and take everything little by little. If you get off the aorta and get into the peri-aortic tissue, then you can get a little lost and you can end up ligating things you don't want to. But if you stay on the aorta and take your detection that way, then usually retroperitoneal approach actually very good for complex neck morphology.
All right, so let's take a break. Kim, I'm not sure how you are for time. Don't worry about it if you can't stay on. We'll come back about 10:25, okay? All right, thank you. Okay, welcome back. We're a little earlier than planned, but we're going to go ahead and see if we can catch up a little bit of time. So let me share my screen. Hey, Kim, are you still on? Dr. Hodgson's got a bunch of other meetings this morning, so he may or may not be joining back. So let me go to full screen. We're going to start this. We're going to talk about left visceral rotation. Let me see whether I can go full screen on. Here we go. Okay, so now the question is, are we going to have narration?
Hiatus all the way down the left external iliac artery. You can make a decision of whether you want to take the kidney up or you want to take the kidney down. So for thoracoabdominals, typically take the kidney up. If it's for occlusive disease, again, may keep it down. You can actually divide the left renal vein if need be. And typically if we're doing the left-sided medial visceral rotation, we'll make the kind of decision that you see in the top right-hand quadrant as you see it here. Again, for us, the use of the omni retractor is absolutely key. Just you need to get into your habit of how you're going to actually set these up, and we'll show you, how we use it, in some of the following diagrams. And again, this is just the kind of exposure that you can get. You don't really need to enter the chest with self-retaining retractors and pulling up in a costal margin. You can get remarkably good exposure in all but the largest of patients. And once you get down there are a variety of decisions we can actually potentially make in the aorta for occlusive disease of the celiac, the SMA, or combined celiac and SMA disease. So now let's move on. This is a woman who actually had occlusive disease of her visceral segment. You can see head is inferiorly. The legs are to the top right-hand corner. You can see where we're going to deviate the incision away from the midline up really to the costal margin. Again, like those things, we make the incision with the scalpel only through the dermis, and everything else is done with the bovie. You open the abdomen basically in fairly standard fashion. We're not going to dwell on this, although we'd say, the retraction on the left costal margin is the most important thing, and you can see that we've got an abdominal wall blade pulling up hard on this. And so what you're looking straight down now is the left lobe of the liver. Hand is going in there to free up basically the left triangular ligament. And so we're going to divide this, and this is going to allow us to help retract the liver really back to the midline. This is fairly easily done. An NG tube, of course, is usually in place in this patient, so we can feel basically where the NG tube is. We fold the liver back, and what we're going to do now is start mobilizing the left paracolic gutter. And you can see I've started making the decision parallel with the colon here. Again, once you can actually get into it, you can see the white line there. You get your finger in there, and a lot of this dissection can actually be done basically with a combination of fingers or right angle retraction, as you can see here. Again, the biggest challenge, of course, is going to be the spleen and making sure we don't, when we take the spleen down, we don't tear any of the attachments to it. And we have a very low threshold. If we're going to do a big vascular operation, if there are any tears which occur in the spleen, then typically we're going to actually just go ahead and actually take the spleen out. So we're going up the left side of the colon. Hand will go over the top of the spleen. You can see the lat pad is on top of the spleen. We're looking straight down behind the spleen here. And we're starting to take down the splenic attachments to the undersurface of the diaphragm. Again, gently pulling on the spleen. And again, just continue to take down all these peritoneal attachments. We've decided that we're going to actually leave the left kidney inferiorly. That's so you're now looking at the anterior aspect of the left kidney. There are sometimes some little bridging veins in there, and you want to kind of develop that space towards the aorta. Once you get to this level, you can actually feel the aorta, and your dissection is going to go in front of the kidney towards the aorta. And you got to remember that the renal vein is going to tether run across the front of the aorta, tethering the kidney. Again, just developing that space, you can start seeing the aorta. If you let it all go, the spleen drops back into that left upper quadrant. We almost always basically cover this up with a towel to try and avoid avulsing any of these little attachments that you can see here. So you're looking at stomach, the greater omentum, and the spleen. And you got to mobilize this all as much as you can, all the way to the diaphragmatic hiatus. And you can see our fingers are behind that, all the way to the diaphragmatic hiatus of the esophagus, because that's the only way you're really going to get the kind of exposure at the diaphragm that you actually need. What we're now doing is open down so we can get out the, again, thinking of ureter. Anytime you go down the iliac artery, you're thinking about the ureter, but what we're now looking for is the left ureter. And here we've decided to change the plan, that we're now actually going to take the kidney up. So we're entering the renal capsule, and these are the two options: kidney down, kidney up. And you're going to divide that up, the perirenal fascia, so we take the kidney all the way anteriorly. Now, you got to be careful you don't stretch the renal artery too much as you're doing this, and there's sometimes posterior veins which come down from the renal vein along the side of the aorta that you just got to be careful with. So now that's the psoas major you're starting to look at, taking the kidney up. And kidney is underneath the hand, which you can see here. That's the psoas major muscle, with the psoas minor tendon. General femoral nerve lies in the front of it. And a lot of this is just areolar tissue. It can be done with finger dissection. Now you're starting to see there's a tiny iliac artery in this lady, because she had coronal reef aorta, in that segment now that you've got here. It's worthwhile just boving this, because it's just pesky bleeding if it continues to bleed. So taking the kidney up, now you can see the kidney's been completely mobilized. Spleen is still trying to get back in here, spleen and liver. And now we're going to be a set of retractors. The retractor that was just put in is called a splanchnick retractor. It's got that little hook on the bottom end. I really like that because it locks everything in place. And you incrementally dissect, move the retraction, dissect, move the retraction, dissect, move the retraction, until you get the exposure that you need. Now you're actually starting to look at the fact that we've got the right common iliac, left all the way down to the external iliac, tiny arteries in this lady. And then you can see we're starting to get tapes in the celiac and the SMA, and at the 7 o'clock position, that is actually the thoracic aorta as it emerges from the chest. So there's a variety of different modifications of this. If you want to stay away from midline, you can go oblique, you can go basic into the 10th, 11th intercostal spaces. It can give you exposure. I like midline followed by a little deviation, because it depends how high up the aorta you really actually have to get. But to get up to the hiatus, the further away you make the incision from the midline, the harder it is to actually do that. And you're really hauling on these retractors in order to be able to get more proximal control. Another situation is a patient with two different stomas. And again, trying to stay away from the stoma, you got to go a little more lateral. And here you're probably going into the just below the costal margin, try and stay out of the chest, basically, if possible. So this just shows you the way that the left visceral rotation can be developed and how it can be modified for a variety of different approaches. Thank you.
Hiatus. We had to clamp at the hiatus, and I'll show you how to do that. We had to get to the level of the celiac and the SMA and the renal arteries, and she had a tiny distal aorta. So, Kim, are you on? Let me see if he's on.
I think he's not.
Yeah, okay. So, John, anybody got any comments? John and Mark? I would make the point, this is exactly the same exposure as Dr. Redican showed, but we did it through a midline incision. It was actually a midline that deviated a little bit superiorly towards the left costal margin, but it's basically the same exposure that you can achieve.
Yeah, it's interesting. Typically, if I was doing a medial visceral rotation, for instance, for trauma, I actually usually start more distally. So I would go down to I sort of start down in the left colon someplace where it's sort of safe. And then I work my way north because I'm using my right hand. So I like to have my right hand working up behind the left colon, get up behind the spleen, roll the whole thing toward me medially. The trick there is to make sure you're not pulling on the left colon and tearing the splenocolic or lenorenal and lenocolic or whatever the heck it is. The ligament connects the splenic flexure to the spleen. You don't want to avulse that, because then as soon as you avulse it and then you're going to heparinize somebody, you're going to regret it. And I know Alan sort of said it quickly, that if you get bleeding in a vascular case from the spleen, just take the spleen out. it's probably true most of the time. Occasionally you can salvage it with some kind of hemostatic agent like Everest, but you know, it's almost not worth the headache if you've really done a big case to be worrying post-op, could I be bleeding from the spleen? So again, if you can avoid that splenic capsule tear, you're going to be way better off. But like I said, I usually start more distally down by the iliac and then work my way north. Again, it's, you know, 2 ways to skin a cat, but I usually approach it that way. Mark, how do you do a medial visceral rotation?
Let me introduce Charo Bavari. It's one of our partners here, actually. Charo, feel free to join in whenever you want. Yeah. Go ahead, Mark.
Marvin's on too.
Yeah, I
Marvin's
think- I mean,
on. Where's him?
Thank you.
That's Marvin. There he is, yeah.
Oh, okay. You know, I'm a little bit like John. I like to start a little more distally and then come up. Just seems that it's my right hand is better than my left. And, you know, again, it's sort of understanding what you do well and what you don't. And it seems like for me, it's just was easier to do it that way and to bring it up. I had better control and I could actually work with my assistant better, which is typically the fellow. And I'm able to better utilize him, and he's better to utilize, or her utilize me. Or so I think that's pretty much what I do. I mean, nothing out of the ordinary.
Now, were you going to show that trap door?
Yeah, let me just introduce 2 other people. Ahmed Mohammed is one of our new attendings. He was a fellow who just joined us. And Marvin Atkins is the craziest guy in the group because he was a fully trained vascular surgeon, decided he wanted to be a cardiac surgeon, so he's double boarded in both. So the video we'll show this afternoon is him doing the thoracoabdominal exposure. So welcome, guys. So yeah, I was going to show this trap door. It's a presentation, actually. Do you want to show the infrarenal endarterectomy that you've got? Can we switch over to Dr. Ide's computer, and the faculty please feel to join in? And if you look at the chats, we can see the questions that are coming in.
Let's see what happens here. Share. Let's see what happens here. Oh, probably. I don't know. Let's see what happens. I think I hit all the share things. It's probably got Zoom on here.
Yep. Good time to ask questions.
Let me go back here. Share screen.
Yeah, share screen, and then pick the screen you want to share.
I'll just do that one right there, and then I won't be doing full screen. It'll just be that piece.
I think you're there, John.
I got to get that turned on somehow. So this is just looking at the infrarenal aorta. I don't know if we can. It's a little bright. I don't know how you change that brightness on it, but it is what it is.
Mm-hmm.
The head is to the left of the screen. The bifurcation is to the right. This is for somebody who's had, again, previous kissing stents and how you would approach doing an aortoiliac endarterectomy. We good?
Yeah, good.
You have to hit the green button.
No, there is no green button. That's what it says we're seeing. He's seeing it.
Mm-hmm. We're seeing it.
Are we good?
It's going. Yeah, it's good. Yep.
Okay, we're good. I think he wants you to full screen it, is what it is. You can keep going, we're good.
So basically, you can see these old wall stents in the aorta. The main point I was going to make here for aortoiliac endarterectomy, not a common operation. This is actually a pretty good place to do it in the setting of the failed kissing stents. You can see how kissing stents look. This is an aortic stent with wall stents inside it. Most people will do, I don't know about most people, I don't know what most lay people do, but surgeons tend to take your aortic incision down into the common iliac, and then, I think that's the end of it, yeah, and then down into the right common iliac. Don't make a V. In other words, don't cut into the left common iliac with the same aortotomy. We usually
do this separately. So take your single bite down into the right common iliac, get that done, close the aorta, and then make a separate arteriotomy in the left common iliac. The common point, those V points are not stable, that they're vulnerable to bleeding, so most people don't like to have the common iliac suture lines come up and meet the aortic suture line. Try to separate those. But that's just, excuse me, just a picture of sort of how you'd get, this would be a good, that retraction we showed earlier, this would be a good example of how we would approach that. There was one other thing I was going to show you here, if I can get this thing down. I can figure out how to do it, is this. Let's see, are you seeing that?
No.
Is that coming through? I've got a separate video up.
No, that's got, you're showing my...
The previous video.
You have to stop sharing.
Yeah.
Yeah. Okay, you are sharing, stop share, okay. Now I've got 1 million shares. Share screen, okay, and this
Choose the one you want.
This one. Share that, let's try that.
You got it.
Okay. All I want to show you here is, this is a kind of vertical shot. The head is at the top of the screen. I guess I can do that. The head's at the top of the screen, the feet are at the bottom. Again, you can see the retractors set up the same way we talked about before. One straight north. You've got these retractors down the right side of the screen where you're getting the small bowel pulled over to the right, and then those two basically on the kidney and the sigmoid on the left. Again, it's going to be the same pattern on all these exposures. This is a sort of a transaortic procedure, but I'm popping out this clot in an aortic occlusion, and you can see the meniscus, I think.
Can you move the controls?
Oh, is the control showing up?
Yeah, yeah, there you go.
Okay.
Yeah.
I didn't know if it showed
Yeah,
up. So you can see the meniscus on that, and that is the top of an aortic occlusion. I haven't had to clamp above the renals. We haven't had to control the renals. We just opened the aorta and popped that clot out. You're not doing an aortic endarterectomy for most of these aortic occlusions. We get quite a few people get fouled up on board exams with how do you handle juxtarenal aortic occlusion. Generally speaking, now this one we're doing an end-to-side anastomosis because the external iliacs were occluded. So the one absolute requirement for an aortofemoral bypass, for instance, with an end-to-side proximal anastomosis is in the setting of external iliac occlusion where you have no retrograde pelvic flow. So in this setting, we've got an aortic occlusion, and we want to make sure we've got some kind of antegrade flow. And so we're going to do an end-to-side anastomosis. But the main thing I wanted to show you is how you can take out the thrombus.
How did you get it out?
Let's show it again.
Did you just squeeze it? You don't use it?
We used a very fancy instrument here. My index finger. There it is. Out it came. The point is, I didn't have to do an endarterectomy. I didn't get a Freer dissector.
Yep.
I didn't have to take any kind of sharp instrument to get that out. You're not dividing the aortic wall. And you could do this whether it's a transection or, again, in most situations you're going to be doing this with a transected aorta. But in this particular case, it was not. The main thing I wanted to show you was the meniscus. If you get the meniscus, you've gotten all the thrombus out. Okay, I'm going to stop sharing and go back to you.
Okay, so let me then share. So this is that same patient that we started showing. Let's go full screen. So now you're kind of looking heads towards the 12 o'clock, 6 o'clock position. And those are controls of the supraceliac aorta, right renal, SMA. That's the patient with 2 left renals, if I remember rightly. And what we're going to do is, oops, didn't mean to do that. So, okay, stop for a minute. Show you this one. And so, again, the same kind of Fogarty hydrogrip clamps. We've actually divided the infrarenal aorta because we're going to replace it. And then we stay in lateral, postural lateral again, staying away from those orifices. All the vessels are up, and you can see that coral reef aorta inside it. But you're exposed here all the way up to the aortic hiatus, essentially.
John, this is Marvin. Can you hear me?
Yep, we got you, Marvin. That's the transected stump of the distal aorta, by the way. Okay, go ahead, Marvin. Yep.
Great. So question on the aortoiliac endarterectomy, since that's such an unusual operation these days. When do you decide to do that versus an aortofemoral or aortobiliac operation in the setting of the stents that you showed?
Great. So generally speaking, aortoiliac endarterectomy is useful for disease that's confined to the distal aorta and common iliac arteries. So the first question is, if the plaque extends into the external any substantial amount, I would not do an endarterectomy. So it's the typical patient is the 45-year-old woman with the tapered distal aorta that's about 12 millimeters, 10 millimeters in diameter. Common iliac arteries are about 6 millimeters. She's got 4 or 5 millimeter external iliac arteries, but that are free of disease, and her runoff is completely normal. They're not optimal for aortofemoral grafting because the common femorals are so small, so you'd be putting in a 12x6 graft. In that setting, if you can essentially focus your treatment on the distal aorta and the common iliac arteries, then that would be the person that I would typically do a aortoiliac endarterectomy. And it's, again, that woman that's got the distal aorta that's about 10 millimeters and common iliacs that are 6 isn't going to be, those are challenging people to do with endovascular because you're sort of limited in how big of a common iliac stent you can put. So the idea, well, you put an aortic stent and then try to put iliac stents in, it's a lot of material in a little small bifurcation. And so and a lot of those people will have had failed kissing stents. But still, all the disease is confined to distal aorta. So that's the person that I would prefer a transaortic endarterectomy. And again, we would expose it the same way we talked about before. Same retraction, exposed down to the external iliacs. I make a single arteriotomy from somewhere between the IMA and the renals down into the common iliac artery. I usually extend that just onto the external iliac. I close the aorta primarily with a running suture. I don't put a patch on it. I do patch just the distal part of the common iliac extending onto the external with a little short patch that's usually not more than 2 centimeters in length. It's really just designed to kind of patch the origin of the external, so you make sure you've got a good clean external and there's no flap or anything there. It's hard to close that distal common iliac without getting a stenosis if you try to close it primarily. I have used patches on the aorta before, and it usually just makes it too big. By the time you've done the endarterectomy, a primary closure works great. You don't have an aneurysmal segment, and it works great. The left common iliac, I usually do a kind of a pluck out endarterectomy. In other words, I reach into the left common iliac from the aortotomy and pull out plaque because I'm not going to worry about the end point because I'm going to make a separate common iliac arterotomy. So I go ahead and pluck out the origin of the left common iliac, close the aorta and the right common iliac, patch the origin of the right external. So that's all done and running. Then I clamp the origin of the left common iliac, the left external and the left internal, open the left common iliac and complete that endarterectomy. So you've sort of separated the two endarterectomies, but you've got a good clean inflow to the left common because you already did that while the aorta was open. Does that make any sense?
It does.
Okay. It's a great operation. I mean, I really do think it's a really good operation. We did a lot of them at one time because, you know, we didn't have very good stents. And I still think for that situation where you've got a relatively small aorta and your alternative is a 12x6 bifurcation graft, the patency for 12x6 bifurcation grafts in an aortofemoral configuration is not very good. In fact, you know, the guys over at Parkland, you know, Valentine and Claggett, they talked about using the NACE in that setting, if you're going to do aortofemoral grafting, was use deep vein for your conduit, because the synthetic graft just doesn't work. The patency that drops off between a 16/8 to a 14/7 to a 12/6 is pretty dramatic. And I don't know if it's because of the size of the graft, or it's just you're talking about these little small femoral arteries where a little bit of intimal hyperplasia, the graft goes down. So that's what you're trying to avoid, is the femoral anastomosis with small vessels, in my mind. Still a good operation to think about, having your armamentarium, and a simple operation and very sort of satisfying in terms of its results.
So in this situation, you can see what he did that, and I've not done many of these. I can tell you, visceral segment endarterectomy, they're few and far between were the indication for this. But this patient also needed an aorta biliac, and so what we're doing here is we did the endarterectomy. We essentially took the bifurcated graft off and tapered the proximal anastomosis to fit where we'd opened the aorta to do the endarterectomy, and that was basically what we did.
This is a really hard thing to do, what you've done here, in my opinion. This is really hard to get right.
You mean what? Taper the proximal anastomosis?
Trying to do an endarterectomy. So you're where are the what's the red loop on here?
The renals.
That's renal. So you're just below the renals.
No. This is across the SMA orifice archway.
Yeah, that's
right
what I
up
was
to
afraid
just below the celiac. I mean, we're right. That's the reason. This is the same patient. We took the left lobe down. Was because you really needed it to be able to get that high, and it was a big left lobe of the liver. All right. I'm going to stop screen sharing. Any questions or comments? Cam, are you still there?
I would just tell you, I would try not to do that operation if I could avoid it.
I think that's probably the only one I've ever done.
And the reason I would try to avoid it is because you're tying a lot of stuff together, and you're asking for a lot of things to go well simultaneously. I like to separate things so that I don't have a domino drop, you know, where if one thing goes bad, if that endarterectomy of the aorta doesn't have a good end point in the SMA, the next thing you know, now you're chasing the SMA and you're trying to do an aortofemoral graft. It's just a lot at once. I'm not saying it's a bad operation. I'm just saying everything's got to go right to make it functional, and it's challenging.
Yeah.
Hey, John.
Hey, Mark.
Mark here.
Mark, yeah.
Hey, two questions for John. Alan, that was a nice anastomosis. That's difficult, but on your endarterectomy of the distal aorta, show that again, sort of what your final configuration looks like, and then tell me again why you don't patch the distal aorta.
Can we go to the camera?
You're on.
Okay, can you see that?
Mm-hmm.
Yeah.
Got it. Okay. So so the plaque is almost always, this is your plaque, really. You know, that's your disease. If the disease extends into the externals, I wouldn't do it. Okay, so that's step one. So I'm usually clamped here, 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 and here. So both externals, both internals, and the aorta at that level. IMA is sort of irrelevant. It almost always is going to be looped. It may or may not be patent. I make my arteriotomy down the right common iliac. I do a complete aortic and right iliac endarterectomy. I pull this plaque out from inside out of the left. So then we close this with a...
So you reach down inside the common iliac to try and clean that orifice.
Right, just like you would do a profunda. You're doing a common femoral endarterectomy. Some of them, right, we don't feel good about it, but sometimes you can reach in and get a good pluck out, and you get a tapered
but the
endpoint.
alternative is just to do a transverse arteriotomy on it more distally, and you can get an endpoint there. But in your diagram, John, you indicated that you wouldn't do this if it extended into the externals.
Correct.
I probably wouldn't do it if it even extended more than halfway into the commons, to be honest with you. If that's the case,
and I think basically that's right. You really don't want it in the externals. my closure is a primary closure like that, and then I put a patch right here, just a patch at the origin of the external. Then I come back and clamp here, here, and here, and do the same thing, and put a patch onto the external. I think you can see that. A little patch onto the external. The problem if you patch this is you make the aorta so big. By the time you've done the endarterectomy, again, I think the question is, and we can, I don't know, we all have different opinions about it. My concept is that a patch is really designed to replace the circumference that you're losing with your suture line. You're not really trying to create an aneurysm. And I can recall years ago, Pat Claggett, who was the chief over at Parkland, presented a series at the SVS looking at carotid endarterectomy. But they had these big centimeter-wide Dacron patches, and the post-op arteriograms looked like these big spinnakers. So you're creating basically an aneurysm. So I don't want to create an aneurysm. I don't want to create more shear stress in the aortic wall. All I'm trying to do is replace the diameter of the suture line. So by the time you've done the endarterectomy, you have such an improvement in the diameter that with a I usually use a 5.0 on an RB1 suture. With a primary closure, it looks great. It looks like a normal closure. So I don't know, that's just the way I've done it. Again, there's a lot of different ways to make a pair of shoes, but that's what I've typically done.
Excellent.
Hey, Alan, I wanted to jump back to the pledget thing to make sure, because when you need pledgets, you really need to understand how to use them.
Yep.
And I think that when he was talking about repairing a suture line, you know, those are often, just so that everybody understands, simple little single pieces, probably 5 millimeters by 10 millimeters or something like that of 2 millimeter thick felt or something. But if you're actually proactively incorporating them into a suture line, if you're going to use the little pieces, you would be doing interrupted sutures. Most people try and incorporate a strip. And if you're incorporating a strip, now you're aligning 3 things instead of 2 things. And there's opportunities for misalignment and leak. And as we discussed before, if it does leak, sometimes it's hard to know where it's leaking from. So those are just things to keep in mind.
Alan, you use a felt strip quite often, right?
So if the aorta's tenuous or if it's a dissection, then yeah, I mean, I use felt. Tom Miguel, our chief of cardiac surgery, he reinforces every thoracic dissection anastomosis. He does it with a strip of Dacron. He just cuts a circle off the Dacron, splits it open, and uses that to reinforce the wound. But Kim's right, is you then basically go, say it's outside in on the graft, inside out on the aorta, and then you go through the Dacron, because you want the felt or the Dacron to lay on the aorta. You don't want it to lay down on top of the Dacron graft. Right. And so John basically mentioned earlier, if you're going to felt at some point that's bleeding, you only need 1 pledget in that situation. So you take horizontal mattress through the Dacron, horizontal mattress coming out through the aorta, and then you have your nurse who's got a mosquito hopefully in the middle of the felt pledget holding it, and you put both the sutures up through it, and you run that pledget down. You don't need to put felt on top of the Dacron. I agree with that completely. Right. The other thing, and where I think I've gone more and more and more to dividing the aorta, rather than, I was taught to leave the back wall intact. I don't think that makes any sense, actually. And I can tell you more often that the nice thing is if you have a problem with the back wall and it's divided, you can see it. If you've got this double layer of aorta you're sewing through, then you can't see where the bleeding is. And the second thing is, I'm pretty fast to take a long felt strip. So you probably take it 5 or 6 centimeters long and about 1.5 centimeters thick. You cut it off a patch, you wrap the anastomosis completely, you put a right angle clamp on the front of it, and it will stop a lot of aortic bleeding. And if that stops the bleeding, I don't take it off. I just take 2 big orange clips and put the clips right across the front of the aorta, and I'll leave it there.
So Alan, this is Marvin. I've got a different, just like John was saying, everybody's got a different way to make shoes. So the Penn way in terms of aortic surgery. So if we had a aortic dissection or if you had an aneurysm, we do what's called an inlay anastomosis. So if I have a dissection, I'll take a piece of felt and I'll actually put it in between the layers of a dissection. So not on the inside, not on the outside of the aorta, but in between the layers. We'll take a little tiny bit of bioglue just to get it to stick. We'll take a pair of forceps and hold it there till it sticks. Sometimes we'll run a little quick 5-0 around. And then basically we do something called an inlay anastomosis. So we go 3 rings back on any type of Dacron graft, and then actually a big bite on the inside of the aorta, and you're getting that graft to sit on the inside. So not end to end, but you're actually taking your graft and you're bringing it on the inside. So you have a good 3 or 4 rings of overlap between the two. And that seems to dry up things pretty well.
Marvin, that's really a technique that's mostly used for ascending aortic dissections, right? This is your type A dissection repair where you're putting an inlay felt with bioglue to reinforce that.
But even for aneurysmal disease, we'll do an inlay where it sits in there like that. Just take big bites on the graft and big bites on the inside of the aorta and get the graft to come and sit on the inside rather than just end to end. And it's more hemostatic.
That advancing the graft, another technique you can use in for renal. I'm always grabbing the aorta, and before you pull up in your suture, advance the Dacron up inside the aorta on that back wall and then pull it up, and it helps, again, stop some of that bleeding.
There's 2 questions on line. One is, do you patch the left iliac incision on an aortoiliac endarterectomy? Like I said, personally, I put 2 little small patches at the origin of both external iliac arteries. Next question is, what material do you use for the patch? Any experience with polyester urethane? Not in surgery. I used to wear polyester suits, but I don't know. Polyurethane was there was a lot of experimentation with polyurethane for a while.
Well, the urethane endografts dissolved. That didn't work too well.
The idea was to create a compliant synthetic graft, because obviously one of the issues with the stiff grafts is compliance mismatch at the artery. Honestly, I usually just use the same thing we patch everything with now is pericardium, bovine pericardium. As I've said before, if you can find something that someone else is throwing away and turn it into a medical product, you will make money. So if you go down to the packing plant and they're throwing away a bunch of pericardium because you can't make sausage out of it, and tell somebody, I'll give you $5 for that bucket and then make 50,000 carotid patches, that's a good model. So those of you who want to make a living, go find something that someone else is throwing away and turn it into either an aviation or a medical product, and your profitability is going to be high. But I use pericardial patch.
So John, let me ask you, what's the advantage of your endarterectomy and patch over just doing a aortobiliac bypass graft?
Well, I don't know. I mean, in other words, aortobiliac is always a bailout. And in fact, some of the time you can't do an endarterectomy. You do, for instance, particularly in the setting of these failed kissing stents, sometimes the stents are so embedded in the wall, by the time you get the stents out, the surface is really not worth trying to salvage. And in that setting, I would do exactly that, is do an aortobiliac bypass. So the one doesn't preclude the other. You can always have the aortoiliac bypass as a bailout. It's, again, we don't have enough numbers to say one's better than the other, and I certainly wouldn't argue that. And what Kim's point is the most important one is, we typically don't do aortoiliac bypass for occlusive disease, right? Historically, that was the operation that when bifurcation graft first came out in the 60s, people did aortoiliac bypass for occlusive disease. The problem was a lot of patients had recurrent disease under the inguinal ligament in the distal externum.
But that's, okay, so what he's done is he's taken a lot of these videos.
And so you would wind up needing to treat that distal disease. So people kind of shifted to do aortofemoral grafting because that got you through all of that proximal common femoral disease. But in this setting, what we've described is the person who has disease that's mostly confined to the distal aorta and common iliac arteries, and therefore an aortoiliac bypass is probably reasonable. If you just said, in general though, aortofemoral grafting is what we tend to do for occlusive disease, and for aneurysmal disease, you tend to bypass to the next good vessel. So don't in other words, generally for aneurysmal disease, if you can do a tube, do a tube. If you got to do aortocommon iliac, do aortocommon iliac. If you got to go to the externals, you go to the externals, but you go to the next good vessel. For occlusive disease, most people have enough external disease that we tend to do aortofemoral grafting. But in this particular setting where you really have disease confined to the distal aorta and common iliacs, aortoiliac bypass is certainly rational and very effective.
Okay, so let me share this screen. I think that we presented this to SVS. It generated all sorts of discussion. So let's kind of focus on the visceral rotation part, not the indications. The patient who had IVC filter penetrating into the aorta, which resulted in aortic dissection. So the principles we're going to show here are right visceral rotation primarily, the development of aortic dissection and open filter removal, repair of inferior vena cava, and aorta biiliac bypass graft. Here's a little bit of the history. 77-year-old man, had history of DVT, filter placed prior to spine surgery over 5 years ago. Filter was not removed postoperatively. He presented with back and intermittent abdominal pain. He was referred to us because he had a CT scan which showed the filter leg, which you can see here, penetrating into the aorta. And when you look at it longitudinally, you can see that filter leg sticks straight into the infrarenal aorta with a dissection which extends distally from that. We had talked to him about various different options of trying to move this endovascularly, potentially having to place a stent graft inside his abdominal aorta. He really was not interested and wanted to go ahead and have an open repair. The abdomen is open through a long midline abdominal incision, and the first thing that's been done here is that we have retracted the ascending colon and the cecum to the patient's left. We're then opening the paracolic retroperitoneum by elevating the peritoneum and incising this. This allows us to get into that space. I do a lot of this now with finger dissection. Again, we're pulling the colon medial, as you can see. What we've essentially done is opened up that space. That allows us to mobilize, and we extend that peritoneal incision down the bottom of the cecum. And then you have to come superiorly all the way up to the right, the colon and the hepatic flexure. Take the hepatic flexure down. When you do that, basically it takes you down onto the duodenum. The duodenum then has to be reflected medially. And once you've reflected the duodenum medially, you can actually open down straight down the inferior vena cava. So what you're looking at here, of course, is the right kidney. Here's the inferior vena cava, and you're going to start to see stent struts, basically, which are appearing through this. You've got to be very careful with these struts because they're pretty apparent. And as you can see, we extend that down. Now we're starting to get the aorta immediately. It's actually stuck to the cava where the filter actually penetrates into this. So we've elevated and dissected this. You can see we've got proximal control of the aorta. So you really can get excellent control of the aorta. You can get control of the aorta from the renal arteries all the way down to the bifurcation and beyond. And as with the left visceral rotation, it's easy to get the ipsilateral iliac artery a little more difficult. You can usually get down to the bifurcation of the contralateral iliac artery. And at this point, we've actually got the inferior vena cava. Everything is controlled and clamped. You want to divide as many of the lumbar veins as is possible. We then open the inferior vena cava. Typically what we do is we cut all the filter legs that are sticking outside the inferior vena cava. It makes it a little bit easier to actually retrieve it through the cava. And even though these conical shaped filters don't have as much wall contact as, for example, an optes or trapeze, you almost always got to cut them out. And here you can see that the hook is actually attached to the wall. You've got to dissect it out with a knife. The more of the filter legs that you can trim off, the easier it is to actually retrieve these. You just got to be careful that you don't, as you dissect this out here, we're doing it with an 11 blade, you don't actually come through the entire cava wall. In this case, the cava was repaired primarily with a running suture. And again, perhaps this was slightly controversial. We went ahead to go ahead and open the aorta. We've got infrarenal proximal control, distal control in the iliac arteries, and you'll actually see the septum of the dissection. We're actually opening along this. And again, the principles of this is you've got to identify the true lumen, and you got to extend this distally. We did a short interposition graft here where trimming this circumferentially, and then we went on to put in a short bifurcation graft to the iliac arteries from the distal aorta. And that's really what's going on here. Is this is an end-to-end anastomosis, as I say, a relatively short segment, pretty easy to sew this. Relatively normal aorta above the level of the dissection. We extend these distally and do end-to-end anastomosis in the left common iliac artery, and then we essentially did the same thing on the right common iliac artery. So this is, we opted to go ahead and rotate some peritoneum down. A mental flap down. On top of this, we'll show a little more detail basically about a mental flap. So in the future, we did that really because this patient was remarkably thin, and that graft was going to be sitting with the duodenum right on top of it. And we'll talk about that in a little bit more detail later. So essentially what we're showing here is, let me just stop it. Any comments? Kim, are you going to attack me for replacing that aorta? Marvin, what would you done?
I'm sorry, I had to get
all
off for a bit there about this transplant. Sorry.
No, Alan, I don't have any issues with just putting a short little interposition graft in that situation. My question is, other than the dissection, did the patient's symptoms get any better? Their back pain go away?
Yeah, I tell you, we have a lot of experience in taking out inferior vena cava filters. And, you always go through the agony of, is the back pain related to their filter? And when they've gone through the workup and no other reason has been identified, I would say that 90% of the time they're better. And in fact, we did one recently. This woman, despite the fact that they have a laparotomy incision and pain, they will tell you immediately whether or not the pain is better. And so it's very real that they get back pain related to these filters.
Yeah.
And I think you can see the kind of exposure you can get there from a right visceral rotation is pretty good.
Hey, Alan, Mark here.
Hey, Mark.
What was some of the key for the fellows when they're trying to pull out the filter once you've got the exposure and you've moved everything to medial left lateral? And to what clamps did you use on the IBC? 'Cause it's obviously different than the aorta in terms of thickness and compliance. And then once you've opened up longitudinally, what's the trick for getting the attachments out of the filter?
Okay, so a couple of issues. Number one is you got to spend time mobilizing the inferior vena cava. There is an ungodly amount of blood can come back through these lumbar veins. And so you try to mobilize this thing circumferentially. You don't necessarily need to divide the lumbar veins, but you got to ligate them. It makes it easier if you can divide them because the cava comes up a little bit, but you really need to get as many of those as you can. In terms of clamps, no, to be honest with you, I just kind of use regular vascular clamps. Angled DeBakeys or an aortic clamp I may have used, or the only other clamp we ever use is the DeBakey, and not the DeBakey clamps, the Fogarty clamps actually. Now, once you get the cava open, so before we get to opening the cava, you almost always see these, the cava is diaphanous, and so you always see the filter legs protruding from it with the little hooks on it. So we just cut those off individually so that there's no hooks. And so when you retrieve it, it just comes, by and large, kind of pulls right out. The apex is, in this case, you always look at the CT scan to see if you can retrieve these endovascularly. In this case, we never even tried that. But when the filter is eccentric and it's up against the wall of the cava, it's never free. You're always going to have to cut it out. And with these conical shaped filters, that's not a big deal. I don't know how many of you have tried to take out a trapeze. That is a nightmare scenario to try and get those out. And the only thing that's actually worse than that is the bird's nest filter. It's like there's yards. You're in there pulling on these, on this wire, and it just keeps coming and coming and coming and coming. So those are really pretty challenging cases. I got personally in trouble with a patient recently because one of the filter legs was sticking down the left common iliac vein, and we tore the vein, and I was stuck really with my fingers in the dike trying to control the bleeding. There was a lot of bleeding. Charo actually came in and helped out and kind of helped mobilize it so we could get control of it actually. So these are not for the faint heart. I'd rather fix an aorta than be dealing with inferior vena cava.
So, Alan, I've been trying to figure out the right time to ask this question. The case you just presented presents an interesting example for it. Tell me about your anchoring suture. Is it a single simple stitch? Is it a horizontal mattress? And what is the placement, the needle placement? How do you do that?
Well, I'm not sorry, what do you mean by an anchoring suture? What are we talking about?
When you sew an end-to-end graft into an aorta.
Okay. All right, again, obviously it's always the ways that you've been trained. What I've typically done, and this is the way Bob Smith taught me at Emory. Bob Smith got the Lifetime Achievement Award this year from the Society of Vascular Surgery. Thank you, Kim. You were probably heavily involved in that. He certainly deserves it. And Bob's first stitch was a horizontal mattress right in the middle at the 6 o'clock position in the back of the aorta. And it was outside in the aorta, second stitch outside in the aorta, inside out in the graft, inside out in the graft, pledge it. John just fell off his seat here. And tie that down in the middle of the back wall. And that's what we refer to as an anchoring suture. So that's basically what that was.
Okay. So whether you do that as a horizontal mattress or a simple single doesn't really much matter for the point I'm trying to make. What you did is you went outside in on the aorta, outside in on the aorta. And, you know, we spend our whole lives telling everybody they got to go inside out on the vessel, inside out on the vessel, you know, to avoid lifting plaque and all that stuff. And so, hell, I did that for the first 10, 15 years of my practice. But it's much harder to get a good angle on the needle, especially if you're in a short neck dealing with calcium and you're trying to start up in that narrow tube. It's much better to come from the outside in. So it took me a long time to learn that. Maybe others people can benefit.
Yep, we agree. Whatever is the easiest way. We made that a little bit of that point earlier. It's a different thing when you're talking about the profunda or a tibial artery. It doesn't matter in the aorta. Marvin, got any comments?
Yeah, so, you know, Rich Cambria, where I trained at MGH, basically the aortic surgeon's on the left side of the patient. You take a bite through the graft, and then you're going inside out on the aorta. And so we would start at the 3 o'clock position. If you're looking at the face, so you'd start over here and you'd work your way around, probably put 4 or 5 stitches, and then you'd bring the graft down and then complete the rest. Run the back wall.
Okay. But I think the point is that if the aortic stitches are coming from the inside out, you're sticking a big needle, because we're using a big needle on these cases, inside a relatively narrow tube, because now we got a normal aorta, maybe 20 millimeters, and you just can't get as good needle placement or leverage or that kind of stuff, in my experience at least. So try it both ways, see what you like.
Hey Marvin, since you're with us leading up to lunchtime, how about we cover thoracoabdominal exposure?
Great, good? Perfect.
Are you going to do a case?
Guys, before you start, can I chime in for the IVC filter question? I think Mark had the question of how do you take the filter out, right?
Yeah.
Yeah, I think, you know, one thing that has helped me, and I learned it from the cardiac guys, is use a wire cutter to cut the tine of the filter so that the thing that's protruding out with a hook on it will not engage and cut through the cable wall when we pull it out. So I actually use wire cutters to cut part of the filter and then take the protruding tines out from the outside.
Yeah, so one of the interesting things that we do with all of these filters, because a lot of them are broken, is we actually reconstruct them. We've been doing CT, cone beam CT on the removed filter to make sure we've got all of the pieces there. We're actually scanning medical devices to see if you can build an algorithm that'll tell you automatically whether there's something wrong with the device. Okay, let me pull up Marvin's. This is fairly long, Marvin. I may skip forward in certain parts of it, but
yeah, definitely.
And just tell me if you need me to pause it.
Today we're here in Mighty, which is our training institute here at DeBakey Institute for Education.
It's really hard to hear.
Okay. You need me to turn up?
Our setup for thoracoabdominal
that better?
exposure on a cadaver.
Yep.
Okay, hold on.
So whenever we position patients for thoracoabdominal...
Let me go back and reshare here, Marvin. Yep.
Aortic aneurysm surgery.
Better?
The position of the patient really depends upon the extent of the aneurysm. So if you have a patient that has a type 4 thoracoabdominal aneurysm, which is a total abdominal aortic aneurysm, the aneurysm is all in the abdomen. You may need a little bit of exposure to the chest. And so in those instances, you really need the patient more supine rather than in a lateral position. The converse of that would be a patient with a type 1 or 2 thoracoabdominal aortic aneurysm, where they have a large component of their aneurysm extends all the way into the chest. In those patients where you really need to be able to get to the distal arch, you really need the chest vertical and then some of the abdomen and the hips flex back. And so typically what we'll do with patients, once they're asleep, we'll have the anesthesiologist place a dual lumen tube or a bronchial blocker so that you can collapse the left lung so that you can have adequate exposure. Once we've got that secured, then we'll typically place the patient completely lateral. We will put an axillary roll under their chest. We will then position the left arm in a neutral position such that it's not one way out or the other, or way across their body, or way flexed out in an abnormal position that could cause a neuropraxia of their arm. And once we have that position, then typically what we'll do is we'll take a bean bag that's on the patient and we'll place the bean bag as low as possible, inflate the bean bag for positioning, and then typically what I'll do is I'll have a sheet that goes underneath the hips and I'll pull that sheet to allow the hips to roll back. And so the ideal position, if you had a patient, for instance, with a large extent 2 thoracoabdominal aneurysm extending all the way from the distal arch to all the way down to the aortic bifurcation, you need access to both places. So you want the chest vertical, but you really need the hips to be rocked back so that you can have access to the femoral arteries if you need to go all the way down there, or at least to the iliac bifurcation. One of the things that happens in many of these patients is they end up with a lumbar cerebral spinal fluid drain. And one of the pitfalls is your anesthesia colleagues can sometimes not take your surgical incision site into consideration when they're taping and positioning the lumbar drain. So just make sure that the lumbar drain is always taped to the right side of the spine on the patient, out of your way, so that once you have the patient positioned, you don't have to retape their sterile lumbar drain. So what we're going to start out with is just some general anatomic landmarks of the skin and where we're going to make our incision, depending upon what type of thoracoabdominal aneurysm we're going to repair. So the first thing I do with all these patients is externally, once they're positioned and we're happy with positioning, we're happy with the bronchial blocker or dual lumen tube that's in, what we'll do is we'll go ahead and mark on the surface anatomy where we're going to make our incision. So the first thing I do is I find the scapula. Obviously this is a cadaver, so things are a little bit stiff, but it looks like to me that this is the tip of the scapula right here. And so we'll kind of mark with a pen where the tip of the scapula is here. The spine, and I can feel it here, but we'll mark it here so that you can see on the camera. The spine runs along here. And then I like to feel for the ribs. So typically, you know, there's 12 ribs. 11 and 12 are free-floating ribs. And so sometimes in patients, it's a little harder to feel here in a cadaver with rigor mortis. But generally, the 12th rib is one that you can kind of push in, and I can feel that here. 11, obviously, is the next one. And then usually the 10th rib is the first rib that's attached to the rib cage here. So the rib cage comes around. I think this one is still kind of floating, and so I bet you this one here is the first rib that's attached to the rib cage. So I think that's 10 here. So I'll usually kind of mark 12, 11, 10 on these patients. Typically, once we have our incision done, your rib counting really begins once you have your hand on the chest wall, and you can take your hand and you can go underneath the scapula with a scapular retractor lifting it up, take your hand all the way up to the top, and the first rib that you're going to feel is typically the second rib. It's really hard to get all the way up there and feel the first rib. So you'll feel the second rib, and that's generally where I count down from. If you are doing an extent 1 or 2 or even 3 thoracoabdominal aneurysm and you really need to be way up high in the chest, in those patients, usually we'll go into the 5th interspace, so on top of the 6th rib. And so I usually don't make where I'm going to make that incision on the chest wall until I've counted on the inside. So I have a typical skin incision that I use for most of the thoracoabdominal aneurysms, and then the actual space that I entered into the ribs is not until I've gone through all the way skin down to the chest wall and then counted from the second rib down. And so we'll start off here pretending this patient has a large extent 2 thoracoabdominal aortic aneurysm, and we're going to make our original kind of skin incision here. So now we're going to start with our skin incision, where we're going to make that. So I've marked where the tip of the scapula is. I've marked where the spine is. And so typically for a thoracotomy, you want to end up halfway in between, extending up that high. And then typically your incision will come down just underneath the tip of the scapula here. And then you need to come across the costal margin. So we'll extend our skin incision down here, being mindful this is the breast, and so we'll kind of probably come a little lower here than where I initially marked. And then as we come across here, sometimes in some centers they will go more paramedian and go all the way to the midline of the patient here. So here's the umbilicus here. They'll come all the way to the midline and go down the midline. Other times, if this is your rectus sheath, theoretically, that's kind of in here, you can come lateral to the rectus sheath and stay that way, especially if you're planning on staying retroperitoneal the entire time. So we'll plan on doing that. So in this patient, we'll come across the costal margin, and we'll plan on just coming straight down here, paramedian to the rectus sheath, anterolateral to the rectus sheath. And that looks like a reasonable incision here.
So I think we could probably skip through some of this part through the skin and into the...
All right, so we'll start off with our skin incision here. Usually there's several people that are helping out with this.
There you go.
Some of our lights.
Now I can mute it here, Marvin, if you want to talk over it, and then we can skip forward.
Okay, great.
So what
Let me just
muscle's
kinda
that
get
you're
to-
dividing?
So that should be latissimus, I believe.
Little Miss Dorsey.
So this is obviously not a muscle-sparing incision whatsoever. So the latissimus in the back there, serratus in the front, and then when you start dividing into the chest and you get in the back there, you start dividing some of the rhomboids. And so again, we'll stick our finger underneath the scapula, usually put some type of retractor in. Here's a dever lifting up, and then I'll stick my hand up there and feel for the second rib. There's usually some loose areolar tissue there that you'll take down, and then stick your paw all the way up at the top there, and usually the first rib you feel is the second rib, and then count down
you're
from there.
on the ribs with the scapula elevated under that dever.
Correct. Lifting up subscapularis and some of the other muscles. So I'm just taking all that loose filmy stuff off, and then I'll be able to reach my hand all the way up to the top, and the highest one you feel is 2.
Why do you need to count them? Does it matter what interspace you go through? Whether it's, really, you're going to go through wherever you're going to go through. Do you need to count them? This is
yeah, so you don't want to be too high, you don't want to be too low, and generally the 5th interspace is good for an extensive aneurysm. Yeah. You can be lower, obviously, if it's a type 4. If you end up dividing it much higher than the 5th interspace, then you really have to divide 2 or 3 costal margins. And so the 5th seems to be the kind of the optimal spot to get to it.
Now, I've seen Mike Reardon, when the exposure wasn't really very good, just take a rib cutter and shear the rib below the incision and just flap that intercostal pedicle down.
Yeah, so many times I'll do that. So that's called shingling a rib. So basically we'll cut a 1 centimeter segment of rib posteriorly, and that allows almost like a shade where one rib will go behind the other, and that allows you to open the interspace up even further without breaking ribs. And many times during these operations, despite your best efforts, you're going to fracture a rib. It's much more, it's much less painful for the patients if you cut a segment out in a controlled fashion than fracture a bunch of ribs. Because what they feel pain afterwards is those edges of the broken rib rubbing against each other, but if you cut a rib out, they don't feel that. So we'll kind of.
So you're saying the anesthesiologist lungs down at this point in time? Do you care?
Yeah, usually I just make a little bit of an incision to be able to get a finger in there, and then I usually will just stick my finger and just cautery, use the finger to sweep the lung out of the way, and then do that. Yeah, usually we'll you want some type of either bronchial blocker or double lung isolation. It's not mandatory for these aortic operations to completely isolate both lungs. It is nice sometimes. It just depends upon your anesthesia folks. Sometimes the dual lung can be a little harder to do, and sometimes if they don't get a good seal, then you'll start inflating that lung. And,
so
that's the biggest trouble that people run into these operations. Is,
yeah, we surveyed the participants about experience, and thoracoabdominal was one that was pretty low down there in terms of their exposure to it.
Right. Yeah, I would imagine probably most places don't get too much open experience these days. I'll skip through some of this.
Okay, I'll wind forward a little bit. A little bit more.
So the costal margin, I guess we could talk about that. So that's always the pain in the ass afterwards with these cases. So one of the issues that patients complain about is rib clicking. So when they come back, the ribs, you can put a paracostal stitch around that, a Vicryl. The cartilage, though, doesn't really heal, and so you have to basically take a permanent suture like a Prolene and use that through the two edges of the cartilage that you've divided. So the least amount of cartilage that you can divide is always better. And that's one of the reasons to go through that fifth interspace. Many patients, if it seems like it's not really well put back together or it's real flimsy, I'll sometimes just not put the cartilage back together, but I make sure that I cut it back so that the two ends aren't next to each other, because one of the things that the patients complain about is with every movement, sometimes even with just deep breathing, they'll feel those two edges of the costal margin banging over each other because they never really healed. And so it's better to just cut them away and let them independently move.
So one of the
I've tried
questions
to plate them before. I tried to plate them before, and same kind of thing. Not a great experience with that either.
One of the questions we got from the participants was, could we explain a little bit about left heart bypass? So can you tell them what you're doing now?
Yep. So whenever you're going to do an extent 1, 2, or 3 thoracoabdominal aneurysm, you want to be able to perfuse the viscera, perfuse the lower extremities while you're doing your proximal anastomosis. So the great way to do that is left heart bypass. So left heart bypass is where you basically now, through this incision here, we're mobilizing the left inferior pulmonary ligament, which is what we're dividing here. You're lifting the left lung up, the lower lobe, and at the base of that left inferior pulmonary ligament is the left inferior pulmonary vein. So that's going back into the left atrium, so that's oxygenated blood. And so we'll usually put a purse string in that, and then we'll put a cannula in that. So that's going to be your oxygenated blood that's going to be coming out of the patient. It then goes to a roller pump, and then
Marvin,
you
can you
will...
tell us what that cannula, it's not just any old cannula, is it?
Yeah, so it's usually got multiple holes in it. Usually we use 18, 19, 20, whatever brand. They come in different French sizes, but you really don't need anything huge. But 18, 19, 20 French, depending upon the size of the left inferior pulmonary vein. And just put a purse string in that, and then we'll take a Ramel tourniquet around the purse string suture. We'll make a incision with an 11 blade, take a serrade, open that up, stick your cannula in so it's sitting in the middle of the left atrium, and then you'll snare down around that, and then you'll tie your cannula to your purse string Ramel tourniquet so that it doesn't move. Obviously, you have to be completely de-aired when you connect it to your circuit. You can't have any air in the circuit here. It goes back to a roller pump. And then that connects through the circuit there. It'll have a reservoir on it. And then you can go back in through either the groin into the femoral artery, You can go into the distal aorta. Some people will go directly into the aneurysm, the lower part. So that's your return. And so basically what you're doing is you're pumping the blood around, but you're allowing the body to be the oxygenator. So you don't need full pump dose heparin for that. So you're giving 1 milligram per kilogram. So if you got a 70 kilogram person, you're giving, 7 to 10,000 units of heparin, trying to keep your ACT maybe 250 or so. And you're allowing that to do, what that allows you to do is what's called sequential clamping. So as you're doing your proximal anastomosis, you'll have a clamp when you're divided the aorta up by the subclavian, you've got a clamp up high below where you've divided it, and now you're flowing distal to all of that somewhere, whether it's the groin, through the femoral artery, or through the abdominal aorta, or through the aneurysm, depending upon the extent. And now you're perfusing your gut, you're perfusing your spinal cord, all your intercostals, and that allows you to sequentially kind of march down.
So what kind of flow rates do you use?
So generally you want so usually I'll put, if I'm going to go to the groin, I'll usually put a right femoral arterial line on these patients beforehand. And so what we're looking at is really more of not necessarily flow, but we're looking more at a distal aortic pressure. So ideally you want to have a mean pressure of about 60. So I have a right femoral arterial line, and then the patient's put in the right lateral decubitus, which means the left side's up. And so when I'm measuring my distal, when I'm clamped and I'm now trying to figure out what my distal pressure is, it's that femoral arterial line on the right side that helps you decide whether you need to go up on flow or not.
Great, thank you. So what you doing here?
So I think here we've done a left-sided medial visceral rotation. I think we're digging out the visceral segment. I can't.
Well, I think
we're still in the chest, aren't we? Yeah, we're still in the chest, aren't we? Yeah. So speed through this. I think I'm digging out. Yeah. So that's actually don't speed through this. So that is the descending thoracic aorta. Up at the top of the scissors, at the top of the screen, is the left subclavian coming off, and now we're going proximal on the arch. Just at the tip of my forceps there is the left recurrent laryngeal nerve. And so that's one of the key parts of the proximal dissection that you have to be careful of is watching out for the nerve. So ideally you don't want to make these patients hoarse by taking out that nerve and they get a paralyzed vocal cord. So many times what I'll do is I'll either loop it carefully or just take one of those little handheld vein retractors and just gently pull over the recurrent laryngeal nerve and try and stay on top of the aorta and come around to the arch there.
So how far proximal can you get? Can you get proximal to the left common carotid through this incision?
You can. It's harder. You're going to be on the other side. You're going to be medial to the nerve. And as long as you can identify the nerve and mobilize it, you can get to the left common carotid, but it gets pretty far deep in a hole there at that point.
Yeah.
You're not going to be able to get to the innominate from this incision. If you had a patient that they had a big, huge arch aneurysm as well as a big descending aneurysm, and maybe you needed to treat the descending because it was ruptured or symptomatic, but they still had a big, massive arch aneurysm. One other option, rather than the thoracoabdominal incision, would be to do it through a clamshell incision. And then you can, some people have written about that, doing the arch, ascending arch, and proximal descending thoracic aneurysm all through the same incision. But I've personally never done that.
Can you talk a little bit about the diaphragm and what you did with the diaphragm?
Yeah, so whenever I get to the costal margin and divide the costal margin, then you've just got the diaphragm. So there's two schools of thought. So one is just going straight down to the aorta and not worried about diaphragmatic function afterwards. The other thing that a lot of people will do is radial division of the diaphragm. So remember, you got a muscular portion and a tendinous portion to your diaphragm. So it's the tendinous portion that has all the branches from the phrenic that supply. So if you can leave a 1 or 2 or 3 centimeter radial incision dividing the muscular portion, but leaving the tendinous portion intact, people theorize that that you'll have better diaphragmatic function afterwards. I've seen people do it both ways. I couldn't really tell a difference. I don't recall in my fellowship, because at MGH we would just go straight down to the aorta. I don't recall seeing a whole bunch of just paralyzed diaphragms on that side.
Do you tag the diaphragm as you cut it?
Yeah, so that's one thing I'll do. So it's always a pain at the end of the case. So these cases are kind of like three cases. So one is the dissection part, which is extensive. The next is the sewing in all the grafts. And then the third is the closure. And they're all big operations in and of themselves and
Hey,
take
Marvin,
time.
you're going quiet on us.
Can you hear me now?
Barely.
Yeah, barely. It's just you were.
Yeah, I'm not sure what's going on.
Okay.
Let me speak a little bit louder then. So one of the things that we'll sometimes do or always do is we're dividing the diaphragm is once I divide it for maybe about 2 or 3 centimeters, I'll put a marking stitch of a certain color suture to mark it so that at the end of the case, when I bring it back together, it makes it much easier. So then I'll divide another 2 or 3 centimeters, and then I'll put a different colored marking stitch. And so that helps me at the end when I try and put Humpty Dumpty back together here, that it's much easier to do at the end of a long case. And so here's the sequential clamping technique. So we've clamped the subclavian, we've clamped the distal arch there, just proximal to subclavian, we've clamped the distal or the mid part of the descending thoracic aorta, and now we're opening up our area for proximal anastomosis. So one of the key things here is what lives right underneath the aorta, right there at the left subclavian artery. So that is the esophagus that lives underneath there. So one of the key parts of this operation for the proximal anastomosis is to completely mobilize the proximal descending thoracic aorta there just past the subclavian and make sure that you're able to completely lift the aorta up and look at the bottom side there and separate that esophagus, because the esophagus comes right underneath that area there. What you don't want to do is to put stitches on the back wall of the proximal descending thoracic aorta there and tag the esophagus and essentially creating an aortoesophageal fistula right at your anastomosis. That's a death sentence. So really a key thing is to lift up that back wall and make sure you're watching every needle stitch come through on the back wall of the aorta there. So here we're radially dividing the diaphragm and we'll put our marking stitches. So there we're into the abdomen. And so I would probably stop there, put a marking stitch, dissect a little bit more, put a marking stitch. In this cadaver, obviously, that wasn't necessary.
You didn't put it back together again?
Like, we'll have it out 37 days. I was like, okay. What?
All right, I think we can skip through some of this in the interest of time.
I just forgot to hit order.
We got somebody needs to mute the microphone in the background, please.
When we drive.
Anything else?
I don't think so. I've got level 3s.
Sounds like one of our folks.
Sounds like Miss Smith.
Yeah.
All right, so for these cases, I like to use the Omni retractor. You can use a Thompson. Some people use a Balfour. I just found that having a finichetto up in the chest and then using the Omni is easy for me, allows a lot of versatility of retraction.
So is that the real name for a rib spreader? It's Pinochet?
Finichetto is one of them. Yeah. So I think this is the, that's a Thompson retractor.
I'm going to wind forward a little bit.
Yep.
Got about 10 minutes left before we got a hard break for lunch.
Okay, so usually at this point, as soon as I divide the diaphragm, that'll put you back there in the retroperitoneal space. And so we'll start doing left-sided medial visceral rotation, taking your colon and bringing that over back around, just staying on top of the psoas and bringing everything medially here. And so obviously in these cases, you're taking kidney up, ureter up.
Whoever devised this operation was the MACC DeSade School of Medicine, I think they went to.
You know, that issue of the costal margin, I think, is the Achilles heel of this whole shooting match, and it's one of those things that kind of, I'm not sure anybody has a great solution for it. I was taught to cut a notch, like a V-shaped notch.
Can you draw it? Why don't you draw it and we'll come back to it.
I don't know, we can...
I don't want to interrupt it, but we'll show them at the end, actually, what you mean, because that's exactly how I was taught too.
Yeah, these days, for the most part, I'll try and cut the two ends so that they're not anywhere near each other. I just got tired of patients complaining about it post-op.
Well, and that, I guess that was, so the thought would be either you figure out a way to secure that cartilage margin, costochondral, whatever the hell it's called, the cartilage, secure it more effectively. And I have thought, why isn't there some type of a
device,
some kind of a bracket that you would clamp on there that would kind of fit and hold this thing together in some kind of secure way? Or is there really any harm to just, like you say, just cut out a segment and forget about it? That's question one. And then the second is, I also thought that people had drifted away from what I would call a perichondral, or in other words, sutures that go around two ribs. That some of the thoracic guys I've worked with had just quit doing that because you're creating compression on the nerves, intercostal nerves under the rib, and that's where some of the pain came from, and they had just eliminated that whole. We used to use these big, gigantic, several interrupted sutures that would encircle two separate ribs. And I thought that was kind of, I don't know whether there's any thought about that, or is it just that because this is always being done by some, foreign fellow, and that the real doctors have left the room by now, or what? That we just don't even think about it. I don't know what the right answer is. How do you close these incisions?
Yeah, so a couple things. So one about the costal margin, the first question. So, people have tried to plate them. I've tried to do that. Yeah. The problem is you've got nerves underneath that as well. I had one patient where I had to go back and take the plate out because of all the chronic pain that he was having. And I basically took the plate out, cut the cartilage back, and he was fine after that. I don't think there's a great closure device. We used to use just big Proline #1 or O Proline sutures through the cartilage. Again, you get all the clicking if it's not really well put together. And then in terms of the second question you had, which one was that? That was
how do you get the ribs?
How do I close the chest? Yeah, so
space. Do you just
I still just go around two ribs. Are the people that you're working with, are they plating everybody then?
No, you're just saying they're basically just kind of sewing the intercostal muscles together, which is basically like sewing moonbeams to flatus, and then closing the skin. And you figure, what's going to happen? I mean, it can't really. What's the worst that happens? Do you really need to pull the ribs together?
The worst thing that can happen is you can get a lung herniation. So that happens. So that's one reason to close the chest, is that, or that is the reason why we close the chest, is that you can have lung herniate through an area that's large like that. So, I'm not sure just closing muscle is adequate enough.
Can you tell us what we're looking at here, Marvin? This is nice.
Yep. So now we've done a medial visceral rotation. Now we're getting out the visceral segments. So kind of at the upper portion, right where your cursor is there, that's probably celiac in there. That's SMA. That's SMA right there. That's left renal. And so the way that
branch of the left renal vein we keep talking
about. Left renal vein. Yeah. So usually what we'll do is as you're coming around the descending thoracic aorta, you divided the diaphragm, you've gotten down to it. I'll stay on the left side of the aorta and dissect that down. And then I'll usually dissect then on the anterior surface, almost where the middle of the scissors are there. And the first branch, obviously, that you come down to is the celiac. As we come lateral along the aorta, the first thing you're going to find is the left renal artery. And so we usually use that as our landmark. Many times there's the renal lumbar vein that comes into that area that you'll have to divide. And so usually using that left renal artery as your first anatomic landmark to help you figure out where everything else is.
All right.
And then some people, depending upon what's aneurysmal, some people will dig out and encircle the visceral vessels with vessel loops. Other people will wait till you're clamped and that segment's open to control them. What I used to like to do is if I was doing left atrial femoral artery bypass in these cases, I like to have a octopus cannula come off of the bypass line. And so basically it's a 3/8 line that'll have a little stopcock on it that you can connect. You just basically divide the 3/8 line, have the two ends, and it has a lure lock on it. I'll connect then, it has 3 or 4 little plastic tubes that you can then connect perfusion cannulas to. So LeMaitre makes a 9 French Pruitt perfusion occlusion cannula that allows you not only to inflate the balloon to stop flow, but it allows you to perfuse through the distal lumen. And so many times what I would do is I would take 4 of those, 2 of them would go into the celiac and the SMA, and I would connect that to my left atrial femoral artery bypass. And then I usually had cold saline, ice cold saline with mannitol and steroids that I would put into both of the renals and do renal cold solution into those.
Now, Marvin, so make a few comments about the concept of the aortic patch that involves the celiac, SMA, and right renal versus individual branch grafts. And when do you use individual branch grafts versus a patch?
Right. So I think the most important thing is the pathology. So if you have a patient that is on the young side, that this could be a connective tissue disease, could be Marfan syndrome, you don't know they have a connective tissue, but you're suspecting it, or they've got a family history. In those patients, I think it's very important to use a branch graft for all 4 of the branches and totally get rid of the aorta. And what that allows you to do is not to get a visceral patch aneurysm because of the connective tissue issue. If you have a patient that they're 70s or 80s, and this is atherosclerotic occlusive disease and all the smoking and all the other usual reasons for aneurysms, in those patients, sometimes you can, since the celiac, SMA, and right renal are all typically in a line, you can take a graft, cut a big bevel up the backside there, and then run a suture line around the back, around those visceral vessels, and then around the front. And it's faster than doing individual vessels. I, for the most part, used a 4-vessel branch graft on all patients because I like to use those perfusion cannulas and have flow going to the bowel and to the renals the entire time and just do each individual anastomosis. And
so what I was getting at, Marvin, though, is when you do segmental clamping and you're using individual branches, you don't actually, the technique doesn't require perfusion cannulas. In other words, any old vascular surgeon that can find a cardiac surgeon somewhere who will do left heart bypass and then go on break and go play golf for a while, the vascular surgeon, the simple option is just to have the clamp above the celiac on the aorta. So you're perfusing all your visceral vessels now with your left heart bypass, either through the femoral, or what I usually would prefer myself is I sew a conduit on the left common iliac. So I've got bidirectional flow into the legs. I don't have to worry about my arterial cannula resulting in obstruction like with ECMO in the extremity. I'm perfusing all the visceral arteries, so I don't have to mess around with the Spencer cannulas or some other kind of perfusion cannula. And you just individually, sequentially bypass the 4 visceral arteries. And it takes a lot of that urgency out of the operation because you never have, the only amount of ischemia time is the time it takes you to do a single end-to-end arterial anastomosis, which is less than 15 minutes unless you're really, challenged. And so you really, it makes it simpler in some ways because you don't have to do the visceral perfusion with cannulas. You just do your simple anastomoses and everything's running.
So the celiac, the SMA,
Yeah,
and
so
left
you
renal.
can,
Looks
yeah,
easy.
so you can do that for the celiac, SMA, and left renal. You're not going to be able to do that for the right, obviously.
Actually,
that's down in a hole.
believe it or not, a good fraction of the time, just with commitment to this, some fraction of the time you can get the right renal, but it doesn't matter because you still have the same deal. If you have the left renal, the SMA, and celiac running, then it's time to move your clamp down below the IMA. Well, you open the aorta anyway, and you've got access to the right renal. So you never really have prolonged visceral ischemia using this sequential bypass technique. That's all I'm saying. So for a vascular surgeon that's not doing this very often, you can do this. You don't have to be Houston to do aortic work. And all of you are going to be in situations where not all of your patients can fly to Houston. And you may be not doing a lot of aortic work, but this is not technically beyond any competent vascular surgeon's skill set. Again, I'm not encouraging you to do one thoracoabdominal a year, but there are situations where patients don't have insurance to travel, they don't have the capacity to travel, or they've got an urgent case like an infection where you just simply can't get people out of your institution. Any of you that can do a fem-pop bypass can do this operation if you're thoughtful and have, and you've prepared in advance. You can't do this without thinking about it, but these are all doable operations for all of you.
So
yeah, the one thing that's nice about using the perfusion cannulas, though, is that you can, once you open up the aorta, now you stick those perfusion cannulas in, you don't have to dig out as far on the celiac or the SMA, and you can cut them out as buttons, and then when you sew, you can put it right at the origin of the vessel there. You won't have to dig it out as far. I mean, if you're on LAFA bypass anyway, it's so easy to just put those cannulas in. But many ways to do it.
So talk about the right renal, because the right renal is the hardest of the vessels to find, but you often can, even in the presence of an aneurysm. And even if you don't find it, when you've dissected circumferentially around it, it kind of localizes where you're going to be looking for the renal artery when you open the aneurysm. It's not easy. When you open the aneurysm, there's bleeding, there's a bunch of atheroma, and there's thrombus. It's sometimes very difficult to find some of these orifices. So the more of them I think you've got control of before you get into it, the better off you are.
So I typically will loop the vessels beforehand, do the dissection to the outside there, loop all of the 3 vessels that I can get to. You're not usually able to get to the right renal, I found. And then when I decide to size my graft, typically what I'll do is I'll open the visceral segment, I'll have the infrarenal clamp above, I've done my proximal, I'll clamp the graft up above there. I will take the graft and I'll actually take the branch that should go to the right renal, and that's the one I put down first, and that's how I'm going to size my graft.
The other thing I would make a point about is you don't have to have a custom-built graft. In fact, I prefer not to have a graft that's got pre-sewn arms on it. You can buy them, and they've got 4 branches, but I will size my branches based on my CT scan. And so you may want to have, 2 6s, a 7, and an 8 for a celiac and SMA in both renals. And I'll try to, and I like to actually have them come off with a little bit of bevel. Then often the commercial grafts, the side branches come off at 90 degrees, and so that you wind up with a little bit of a kink underneath the bypass. I actually think I can make a better graft just doing it myself, and I don't have to have pre-ordered it. So I can, while the exposure, this is always going to be a team case, while the exposure is getting done, I can sit on the back table and create a graft. So you can, and again, it doesn't really matter where these grafts originate, it's just a bunch of spaghetti. As long as they're proximal to where they're going to distally implant, you can create your own custom graft, branch graft, just as well in a few minutes. It doesn't take long to put a few of these grafts on the side. So this technique of individual branch grafting, I'm trying to remember, there was a guy out at Loma Linda that I can remember, what was the guy's name, but he was one of the first guys that really wrote it up, as opposed to using this kind of clamp and sew patch technique that it's very dramatic, but it also puts the liver into a lot of jeopardy. And you don't know, I mean, you know, Marvin's talking about these perfusion cannulas like it's a simple technique, but there's two problems with perfusion cannulas. One, they pop back out, even if you have a balloon on them. Some of them don't stay in, and while you're messing around, one of them will pop back out. The second is these are passive perfusions, so they're all coming off a manifold. And if you have high resistance downstream, you may not have any substantial perfusion through that limb. You're just basically having these little plastic tubes coming off a common channel, but each of them don't have a pump. So you don't know for sure exactly how much flow is going through each of those cannulas. So it's a good technique. You have the opportunity, like Dr. Adkins talked about, of having special fluids, right? If you want to put, God knows, you know, steroids and all this, you know, transplant solution, these preservatives, that I'm not sure we know for sure what the best mix of stuff is to keep the kidneys and the liver alive. But the best thing is if you keep blood flowing to these vessels the whole time until you do your anastomosis, you can finish these cases with no bump in creatinine, no bump in LFTs, no cytokine storm from having visceral ischemia over substantial periods of time. So again, I think,
and that's why I looped the vessels on the outside, and especially that Pruitt perfusion ones, they just don't pop out.
Right, right.
All right, we're at the bewitching hour for 12 o'clock. So Mariana's going to take over, and I do believe we sent you vouchers for lunch. And Cook is going to
when are we back?
Have an End the Warrior challenge. We used to do this in person. People would kind of come and they would compete. They've done the best they can to try and be able to do this remotely with you to get you involved. And we'll be back here at 1 o'clock, I believe.
1 o'clock.
At 1 o'clock. I get that right?
Thanks, Alan. Thanks, John.
Hey, thank you very much.
Marvin. That was beautiful.
Thank you. 1 o'clock.
Thank you very much.
All righty. Thank you for a great morning.
All right, everybody split. Lunch.
yourself, and we will engage in the Endo Warrior Challenge. So we want you to get a little bit of relaxation in the break of the day and enjoy this experience. We'll briefly just pass this back to Cook so we can go over some housekeeping issues and make sure that you can interface properly to participate throughout the meeting. Oh.
All right, instead of muting myself, I slid the slides. Good afternoon, everybody. So just a quick housekeeping here. We remind you, we don't want you to miss a minute of the action. So for the full Endo Warrior experience, we recommend you have 2 devices. One would be the Zoom on your laptop or desktop, and then your smartphone for the Kahoot app. Now, if you do want to do it on one device, we recommend you have a laptop where you've got the Zoom desktop application on one screen, and then on the other side, sitting side by side, you have your browser. Navigate it to www.kahoot.it. Now, if you do want to do this on your phone, you can still do it, but it's probably not going to be the best experience because you're going to have to switch between apps, between the Zoom app and then the Kahoot app. Now, do not worry. Once we are done with the training that Dr. Carlos Bishara is going to give us, I will revisit this slide and remind you, but we wanted to give you a head start. So, on to the most exciting slide here. Please refer to the instructions for use at the end of everything. And with this, we're going to push this back to Dr. Carlos Bishara, who's going to get to know you with a poll. Dr. Bishara.
Thank you. Thank you, Yasbel. Before the poll, I'm just going to say welcome, everyone. This is really exciting. I remember when I was a fellow and learning all this endovascular and open stuff. It's exciting. And I'm sure I'm going to be learning something today. I hope I can share some of my experience, but I'm looking forward to doing this with my co-host, Dr. Chandler Long. I'm sure I'm going to learn a lot. And that's what's nice about vascular surgery. As we heard earlier this morning, there's always something you're going to learn. We do things different. And then I look forward to also learning. So let's start. So the first question we're going to ask is, can you go next? Yes.
The poll should appear in Zoom, and I don't see it. Does anybody see it?
No, I don't see the poll.
See it coming up.
But basically, well, if they can answer through the chat, so that's the other thing is you can put some questions through the chat, and then also we have Bobby and Brista from Cook that can answer some of the questions, and we're happy to take some at the end. But if that's going to show up, maybe they can answer through the chat. Is how many have done an EVAR? I don't know if we can. I guess in person we could say show of hand, but unfortunately we cannot do that. Click on poll button.
Well, even more importantly, I guess the thing is how comfortable would people be performing an EVAR at this point in their career? Carlos, let me ask you while we're waiting for this, how many EVARs do you think it took you to feel comfortable as a fellow or even moving into as being a faculty member?
Yeah, that's a very good question. You know, there's always a magic number that people talk about. This time it's not 7. It's actually, they say anywhere between 20 to 30. And I think that's a reasonable number. You know, it's different when you're on the other side of the table as an attending. And that's something I hear all my fellows who leave, and then I see them later be like, oh my God, you know, it's so different to be on the other side of the table. So I would say probably 15, 20, when I really felt comfortable. I can also troubleshoot some problems. So I think that's a magic number for this.
The one thing I always sort of tell the fellows when they start is try to break the procedure down into multiple steps and focus on maybe learning the beginning steps. So you're not trying to learn everything at one time. And I think that allows you to learn things on different levels, and that way you can really take advantage of it when you're in the case.
Yeah, absolutely.
I don't know.
So
We may not
what do you
get the
think,
poll.
yes?
Maybe we just move forward to your portion, Carlos.
Yeah,
I think we're going to move forward, gentlemen, because I don't see a poll.
Okay, next. All right. So, oh, there you go. Huh. Well, maybe
There we go.
Maybe we'll just do that one for now.
Perfect.
So if the participant can answer and submit, that'd be great. All right, well, while we're waiting for the answers, can we, we decided to go over the EVAR, the Zenith Flex device, which is an indicator for infrarenal aneurysms. Now you see some numbers on the screen. The ones that I want you to remember are: one, you need to have at least a normal neck below the kidney renal arteries. So in order to have a seal zone, we refer to it as the neck, and you want that to be equal or more than 15 millimeters. And then angulation is important so that you can have nice wall opposition, and we want it to be less than 60 degrees. And then you can see how they measure it to measure that angle. And I really encourage all the trainees to do that, to measure all these measurements. Now, the other thing is also you're limited by the diameters that we could be using. As you can see, 18 to 32 is what the indication to treat the diameter of that neck. So, I'll probably, these are the main things to remember here.
Okay. So Carlos, I have a question. On many of the IFUs, they really don't address aortic bifurcation diameter. Is that something you take into account?
Yeah, that's a very good question. And I can tell you, I learned that the hard way. The first time I didn't pay attention to it. And then the patient had right leg, I still remember that case, patient had right leg claudication after the EVAR. And then immediately I knew what happened. So the limb was compressed because of that narrow. So basically, for me, the magic number is 14, 15 millimeter before the bifurcation into the iliacs. If it's smaller, I worry about it. And I usually like to either IVUS to see if I'm happy with it, or do AP and oblique picture to see if there's any compression of one limb of the other. And if there is, either I do kissing balloons or kissing balloon expandable stents in that area. How about yourself?
I usually use 15 as my cutoff, and that can be one reason why you would consider doing this open if they're a reasonable candidate. But if you have to do a Bindu, then I agree with you. I think that using kissing balloons or balloon expandable stents at that narrowing point can mitigate some of the risk of getting a limb occlusion.
Yeah. How about short neck? What are you doing for that? So let's say 4 or 5, or let's say 10 millimeter neck.
Yeah, I think anything less than a centimeter neck, I think again I would consider repairing the patient open. But if that's prohibitive, I think that a Z-fin is really my choice. I have some partners that like using endo anchors, but I think that using a Z-fin device allows you to get a better seal into less disease or minimally disease or no disease aorta, and really get a seal that gives you better durability is my thought. What about yourself?
Yeah, so that's good. So you're referring to the Z-fin, which is a fenestrated, FDA approved since 2012, an FDA approved device to treat short neck, 4 millimeter necks. And you're right. I think the message, and I think we're doing really good job these days by teaching the trainees to land in a healthy aorta, a healthy vessel. So I've done endo anchors, I've done parallel grafts. I worry about gutter leak. So if I can do fenestrated, that also will be my go-to choice.
Yeah, I agree with that.
Yeah. Okay, next. Actually, do I have control? Okay, there you go. So this is the EVAR toolkit. As you can see, there's a lot of options for you to be able to perform these procedures safely and have all the equipment and the tools provided you by Cook Medical, from your access sites to the catheters and wires. And actually, we're going to be talking about some of those in more detail. But this is basically to show you the variety of options to do. I'm going to just a little bit talk about the CODA balloon, which is semi-compliant, or we kind of refer as to compliant or non-compliant balloons. And we'll talk a little bit about that later, but that's what we use it to basically mold the graft once it's deployed. So it comes in 2 sizes. Next. So access needle. So this is, first I'm going to focus on the ultrasound picture. So again, for you guys, and I'm sure all vascular surgeons you work with, please do not access any vessel or central line or venous ablation without using ultrasound. And actually, that's what you want to learn to practice, so you can do some of the difficult and obese patient. But basically, this is what I like to tell my trainees is I want to see the tip of the needle in the middle of the femoral artery, as you can see in the ultrasound. Don't look at back bleeding, because that's what we used to from our training from general surgeons, that you want to see some blood come back. Actually, I want to see the tip of the needle in a healthy segment there. So that's the first thing you do. And then you pass your wire, which is in this case an 018 wire. And then you have your introducer sheath and dilator, which you put over the wire. And then you remove everything. You keep obviously the sheath in, and then you can put your J wire or your starter wire and then place your sheath to get your procedure access. So Chandler, what's your, is that same thing you use, micropuncture? And
Absolutely. I kind of have this little ritual that I take the fellows through, and I think that standard of care is really to use ultrasound and use it correctly. I use fluoroscopic guidance as well. I kind of take a shot with a hemostat, and I have the resident or fellow mark the femoral head through the middle. I have them start with the ultrasound there, track proximally, and then track distally to identify where the artery dives deep into the pelvis, and then where you see the bifurcation, so you can cannulate the artery right there overlying the femoral head. And I think the important thing is the other thing that I tell people, especially in redo groins or where they've had previous access sites, is you really want to minimize your horizontal angulation, because I think that you can track into the tissue, especially if they have a lot of pannus there, and you can get yourself lost and lose access. So I think, I mean, you can't do an EVAR unless you get good access. So I think it's something that I would stress, and you want to get safe access, because you deal with, you know, these hematomas or blowouts, it's a problem.
Okay, that's a good question. Yeah. So you mentioned redo groins. So that's one thing I always tell my trainees to do. Usually there's also a stiffer wire kit that comes with a stiffer also dilator and wire. And the other thing, the key is what I tell them to do for these redo groins is that once you get your needle and wire in, I usually like to use a knife, 11 blade, and the hemostat to dilate the tissue a little bit to remove some of that scar tissue, so it's easier to go in and out. So.
And I also check needle placement. So once you have your wire in through your needle, I take a quick shot and make sure the needle is overlying the femoral head and the common femoral where you want it to be before you upsize your sheet.
All right, good discussion. Next, yes. So one thing that you need to understand, so wires come in different diameters, and actually you see that 035, when we say give me an 035 wire, 014 wire, 023, so we're referring to the diameter in inches of that wire. So obviously if you're dealing with EVAR and TVAR, those are big devices, so you want a bigger wire to support these devices. So that's the diameter. Also they come in different lengths, and also they come in different stiffness. So Benson is what we call a starter wire. It's very soft, and then as you move to the right hand of the screen, the stiffness increases. So Lundequist is probably the stiffest wire that we have on the market. Also comes in a straight or what we call a double curve. And the reason for the double curve, because you want that tip, which is soft, is to lay on the aortic valve. So when you're delivering, like say in TVAR, so you have a stiff wire all the way across the arch, so that will be easier to deliver deliver your device. And then finally, they also come with the hydrophilic or not. And the Uniglide is a hydrophilic catheter, which means you want to make sure it's really wet when you use it. Otherwise, it gets stuck and you might lose your access. So,
Carlos, do you have a preference on whether trainees start with a Benson or start with a Glide?
Yeah, so when I was in training and when I first came out, Benson wire was my starter wire, and there's a reason for that. So if you compare Benson wire to the Uniglide, which is the hydrophilic wire, whether it's soft or stiff, that's another, comes in also two different types. Both can be dangerous if they're not in the right plane, because they cut like a knife, and basically you could be dissecting the intima, and then you won't even know it. There's no tactile, there's no feedback. You feel like, oh, it's coming in easy because it cuts like a knife. And then sure enough, when you're up, you're like, oh, how come it's looped like this in the arch? And you're already up there. Meanwhile, the Benson is softer tip. So two things going to happen is that eventually, just like if you're in a dissection or not in the right spot, it's just going to keep curling. And then sometimes it will also give you that tactile feedback. Mm-hmm. So I've seen some dangerous things with the hydrophilic wires. And I prefer if they want to use it as starter, they need to have, they get comfortable with it before you use it, or just stick to the Benson wire.
Sure. And then when you're bringing up your device, one last question for you there. When you're bringing up your device, whether you're doing a TVAR or an EVAR, do you have a preference between the Amplatzer or the double curve Lunderquist?
No, I mean, that, a TVAR for sure, double curve Lunderquist, because, you know, again, you have that double curve, which is a little bit softer and gentler, so it doesn't injure the tissue like the valve.
Sure.
But on the other hand, the rest of the wire beyond that double curve is all stiff. So basically utilizing that stiffness of wire all the way across the arch, so for delivering TVAR. So it's definitely my go-to wire.
I think
Now, for EVARs, I think either one should be okay. To be honest with you, when I'm doing EVARs, I like to keep my wire in a descending thoracic aorta, because that's something we don't really talk about, is manipulating those wires in the arch. You put the patient at risk of stroke. Very rare, but why? Leave your wire in the proximal descending thoracic aorta and then do your EVAR.
I think those are great points.
Next. So again, so these different catheters you could use. One thing I would let the trainees know is that make sure you get a copy of these catheters, leave it in your resident room, so you can understand the different shapes of these catheters. And then one thing you notice about these catheters, the tip, which we call the beacon tip, that's actually very visible. It's really radio opaque. You can see it very well on the fluoroscopy. So honestly, these catheters, I would say when I was in training, when we did a lot of carotid stenting and we still do some coiling, but now we get spoiled with our steerable sheath. And then I would like to see what Dr. Long's thoughts on the catheter, but we have to know which catheter to go to when we have difficult arch to get into the carotids and stuff. So just real quick, I mean, there's, I don't know, out of those, like let's say look at the SIMS and the RIM and the C2. So the C2 for me, that's what I use for visceral intervention. I'm not sure about you, Chandler. Which?
Yeah, I use a C2 catheter a lot for visceral intervention. We run we developed an endovascular curriculum for our incoming general surgery residents that they take in their first year. And I tell them, you know, as you get further and you specialize in vascular, definitely learn the catheter names, but just for an appreciation, just look at the angle of the tip and try to figure out which angle you're trying to traverse. And that's the way you choose the catheter, even if they hold up a picture of it and you choose it. And I think that's really what I still do. And I'm trying to figure out the angle that I'm trying to exploit. And then you choose the appropriate catheter.
Yeah, that's a good, yeah. So some of these curves, what we say they have like the renal double curve, or they have like some of these SIM catheters also have double curve. The RIM is single curve, which is perfect for going up and over in the bifurcation. So yeah, that's a great point. Know your catheters and kind of think, I want to tell the trainees is try to think in 3D in your mind, what you're trying to do and try to choose the right catheter.
Yeah.
All right, next. So again, so the flex zenith graft is what we call a modular bifurcated endograft system. What does that mean? So it's modular because there's a gate, which is going to point to. So that's a gate that you're going to have to cannulate and extend with another limb. So that's why it's modular, and also that's why it's bifurcated. So basically you have two limbs. So that's how we refer to it as modular bifurcated graft. A few things I want to point out. One is the diameter that it comes in 22 to 36. So we talked about treating 18 to 32 diameters. Also, it's a three-piece system. And there's something about that, this three-piece system, is that it allows you to take fabric from the, basically I call it maximizing your seal zone. Taking your fabric from the infrarenal all the way down to the hypogastric bifurcation. And that's why, that's the advantage having three device system. Also the limbs, if you notice, there are two things about the limbs I want to point out. One is the spiral Z. It's basically a laser cut limb. It gives it that flexibility so that if you, when we talk about gait orientation, where you can put it, sometimes you can put an atomic or you can cross the limbs. And it allows you to really do that because of that flexibility of those limbs. And we now, you know, once they changed that a few years ago, we rarely see limb occlusion with this type of platform. Lastly, I want to point out something called the bell bottom. As you can see, there's different diameters at the bottom that you can treat. So, and that's what we refer to as a bell bottom, where you can put a bigger size limb if patients have a generous iliacs, common iliacs. Anything else to add here?
No, I think you said it really,
Okay.
you laid it out really well.
So now that we know the device, I'm just gonna quickly talk about the deployment. The one thing is missing in this picture, but we see it later. There's something called a peel-away sheet that sits there that makes it easier to deploy the device. And then you can see one hand is holding this plastic to basically stabilize the dilator, the introducer. And then basically you position and you pin and you pull. You're unsheathing the device. So it's a pin and pull technique. Next. So a few things I want to mention on this slide. So one, obviously, we want to know where we are. So like we said, first you deploy the stent. So once you know you're at the lowest renal, one thing is you can see those top gold markers. And those are actually 2 millimeters below the fabric. If you can see the picture in the middle, yes, also it shows it really well, where the gold marker is 2 millimeters below the fabric. So keep that in mind. If you have a big renal, it's not a big deal. But if you have a diseased renal, you want to make sure you really nail it. And then also there's a marker for the gate. Now, if you can see the gate, there's a check mark. So that check mark, it basically gives you orientation. So if I'm seeing, if let's say I'm AP, in my fluoroscopy and I see this check mark, that means I'm looking at it straight, I'm looking at the check, that means the gate is placed basically anterior. Now, if you move it to the patient's left, that check mark is basically gonna disappear, become basically just like a dot or almost like a J. That means it's a little bit more to the patient's or lateral position. And finally, two more things is one, as you can see, this stent has what we call suprarenal active fixation. So that means those metal, which are suprarenal, have hooks in them that basically penetrate the intima and hook. So that's how we call it active fixation. And then when we deploy, as you can see in that fluoroscopy picture, when we deploy, we stop after the gate is deployed. And the reason for that is that if you fully deploy and you're, like we talked earlier, Dr. Chandler Long asked me about the size of the aortic bifurcation. If it's tight, you can imagine that's gonna basically push the gate and make it harder. So usually we like to stop there and then try to attenuate the gate, or actually we're gonna talk about also releasing the top cap in the next slide. And lastly is the overlap. There's one more, just to want to show them the overlap for the limbs. So you can see there's a gold mark on the limbs on the right side of the screen. That's your maximum overlap. Typically we ask for 1 stent overlap, but that's, you can go a little bit more, stent and a half, that's your maximal overlap into the gate.
And Carlos, and can you just say a word about these overlap zones and making sure you're angioplasting them well, and endo leaks, proximal and distal, yes, things of that nature?
Yeah, so that's a great point. So again, remember those stent grafts are inside a delivery system. So once you deliver them, they're gonna expand based on the size that you choose and also the patient's temperature. So basically, the reason I say I like to balloon them for 2 reasons. One is sometimes the fabric might be a little bit wrinkled, so you iron it out, you open it up, you have much better wall opposition proximally at the renals, and also you want to overlap the gate, and also the distal attachments into the iliacs. And then since it's a 3-piece device, also you want to iron the overlap, what we call on the IPSI side, which is contralateral to the gate. So the gate is the contra side and the IPSI side is the delivery main body system.
And you're trying to mitigate type 1 and type 3 endo leaks. So it's really the only thing we can control when we're deploying these devices.
Yeah, absolutely. So now to the part where, I could say probably this graph might get a little bit of criticism, and hopefully I can explain to you why it's not a difficult delivery system, but that's one thing that some people might complain about the graph. So the top one is the flex main body, and the bottom one is the spiral xenon. Now you have to remember, for the Cook flex delivery system, it comes in its own sheath, right? So you don't have to have a sheath in. So basically, once you have the stiff wire in, you hold pressure, you move whatever sheath you did for diagnostic, and you go in with the device and the sheath. And remember, we talked about pin and pull. So you pin and you pull. Once you're happy with the location of the stent, you pin and you pull. And here we have the peel-away sheath, which helps you, that Yaz is pointing at. That helps you really, makes it much easier with pin and pulling. Now, Also, the other thing is I want to point to, there's something called trigger wires. So those trigger wires, basically, they're holding the stent to the delivery system. So in order for us to remove that delivery system, we have to dismantle and separate the stent graft from the delivery system. And that's what these trigger wires do. So we're going to go over these steps again with the videos. But basically, once I'm happy, you put it on your pole. And then once you're happy with your deployment, the first thing you're going to do is see this number 1. So we're going from top to bottom. This number 1 releases, as you can see, the top mark, the top cap, and what a suprarenal fixation is. In order for us to release that top cap, we have to separate it from the graft there. Otherwise, we'll be pulling it with the graft. So when we release this first trigger wire, it's now separated, and then we can loosen the pin vise, which we'll show you, and also some other videos. By loosening the pin vise, now I'm separating this top cap from the system, and then you push it up, and then it's deployed, and that's the point of no return. And then once you do that, and then let's say you cannulated the gate and you're happy, now if you want to separate it completely so you can remove your delivery system, the second trigger wire, number 2, is actually that picture in the middle of the screen. You can see where the graft is sutured there. And then in order for us to separate the delivery system from the graft, we have to release that. And now it's completely separate. See that stitch? That's actually stitched and looped around that delivery system. So once that wire is removed, it's completely separated, and now you can remove the delivery system and keep the sheath in. So now, if you look at the bottom, sorry, Jazz, one more, sorry.
Before you move on, I was going to say, Carlos, you explained that really well, which I find that the fellows have the hardest time understanding. And I think you'd agree. The advice I would give is you got to get your hands on this device. And because we're in a virtual realm now, it's hard to do. So you really got to reach out to your local Cook representatives and get them to bring you a few of these devices, deploy a few, make some mistakes, deploy a few more, and really get the handle of it so that when you're in the OR, you're not kind of fumbling around and making mistakes. So really take advantage of that. Make them work for it, right?
Yeah, absolutely. So now I just want to point to the bottom one, which is the spiral Z-limb. Once you want to deliver your limb extension, those are different. Obviously, there's no trigger wires, but they also come in their own sheath. And like, for example, usually they're lower profile, so you can actually go through that. If you keep the sheath for the flex device, you can actually go through it to deliver that stent. And there are no trigger wires. So it's just, again, same thing, pin and pull, and you deploy the stent with the overlap we talked about. All right, so again, I heard Dr. Lumsden talking about earlier about know your CAT scan. Again, I can't emphasize that more, know your CAT scan. But in general, if you want to know where your renals are and iliac bifurcation, typically in general, we say L1, L2 is where your renals are. So you can place your pigtail for a picture. And then if you know where your bifurcation is, so that you open up your gate above the bifurcation, usually L4, L5. So it's very important that you know these size in addition to your access and if there's any issues or disease, visceral segments or not. So one thing here is that you can take an initial picture if you want. So this way you can see there's what we call a marked pigtail. And then that marked pigtail, you can actually measure the distance from the renal to your hypogastrics, to the bifurcation, where the gate's going to open up. So let's say for some reason you decide to use a short device that that device might not even open up in the aneurysm, might open up below the aneurysm, and then you can have problem cannulating the gate. So that's why these pigtail. But to be honest with you, you can get all the information of the CAT scan. So, so having said that, if you want to go to the next one, to the next image. So again, the nice thing about having 3-piece system is that you can actually put your device, and that's what I typically do. I put my device and I shoot, because I know that's the device I'm going to use based on the CAT scan. I know the diameter of the neck, and I know the device. I know the 3-piece system, so it allows me to put the device and extend, so I don't have to worry about if I'm going to go all the way down to the hypo. The only thing left to worry about here is the gate.
So Carlos, let me ask you about that. How do you make your determination of where you're going to deploy that gate, and does wire bias from the contralateral side mean anything?
Yeah, so that's a great question. Again, talk about getting comfortable by doing 20, 30 EVARs. Also, reviewing your CAT scan, know where you're going to put your gates. Actually, this picture, if you look at the middle picture of the angio. So I want the participants to kind of visualize this and flip the device. If you flip the device and the gate now opens up on the other side, as you can imagine, you're going to have problems cannulating that gate, right? Because you're going to be in a segment where there's probably thrombus there. So that's something we're going to look at. Where's the least out thrombus, where I'm going to open up the gate. So that's one. Two, like you mentioned, wire bias. I could tell, like here, I'm not gonna cross the limbs. I'm gonna go anatomic, and then I could see what the wire from the previous one is kind of aimed to the patient's left. So opening the gate over there helps. And then we talked about the check mark. So here, if I see a check mark and I'm AP with fluoroscopy, that means the gate is anterior. But here, if this is AP, then it's probably a little bit anterolateral gate that's open. So to your short answer would be, I look at thrombus, where I can make sure the gate opens up. And then also I look at wire bias. And then I'm not sure if you have any tricks that you could share with us that you do.
Well, so when there's not a lot of thrombus in large aneurysms, especially in ruptures, what I tend to do is when I come up and I leave my pigtail catheter behind the device, deploy the proximal aspect, and then I put a stiff wire in that catheter and leave it behind the stent graft. This allows me to keep that sheath that I'm bringing up from the contralateral side kind of pointed in the vicinity of your contralateral limb, and makes it a little easier to cannulate. Because if you don't have that, sometimes you could just be pointed in so many opposite directions of where you're trying to get to. And if you're in a 9-10 centimeter aneurysm, trying to cannulate a 14 to 16 millimeter gate can be very difficult.
That's actually a great point. I want to add to that. Now, imagine if you put a soft wire and you have a tortuous iliacs, and then once you drop that wire down, that might kink your vessels and your sheath.
Right.
And, so that's actually an excellent point. So again, I would just want to emphasize it so that the trainees can capture that. So what Dr. Long is saying is that so that sheath, it's a big sheath, so you can put a body wire. So the first wire he's going to put it through the pigtail to keep it in, and then probably he's going to, I think, choose stiff wire, right? He's going to probably stiff to keep it there, to use that stiffness of the wire and straighten the vessel and keep that orientation of the sheath. And then he's going to come in with another body wire and a softer wire to get into the gate. That's actually an excellent point, excellent point. One thing I want to point out before you move also here is that at this point, you can still potentially move the device if you have to. So let's say you're a little bit below the renals. I mean, here it looks like they did a good job. It's definitely not me, it's probably my fellow deploying here. It looks like they did a good job. I could see the origin of the renal literally above the gold mark. So, but like I said, at this point, if you want to move the device, now it's time to do it. Because once you release that top cap and the suprarenal active fixation, that's a point of no return. So now we're deployed. We're very happy with our location, right? We can see the gold marks on the fluoroscopy, right? And so let's say we're very happy. So now I want to remove the top cap, push up the top cap. So I have to release the first trigger wire. So once you release the first trigger wire, now I separated that top cap from the fabric, and then I can loosen the pin vise and push that. You can see that kind of handle, you're pushing it up, and that's what happens. You're going to now deploy the device. One thing I tell you, as you're doing that, just have some stability with your left hand where you're stabilizing the device, because you could potentially push it up. I mean, again, just stabilize it with your left hand as you do that, or have someone hold it for you when you push up that top cap. Now, one thing I know it's hard to see, but again, I agree with Chandler, is that once you play with a device, that top cap has a big hollow on the inside. And that could potentially catch and stop. So that's why we want to leave it above the suprarenal fixation. And then once we've deployed the device, which will be later, we're going to come up with a gray catheter and go up there and meet it there so that we don't catch some of these suprarenal bare metal.
Perfect.
So so now the device is deployed. We're happy where it was. We deployed the suprarenal metal. So now it's gate cannulation. So
now what's your catheter of choice here?
Yeah. So again, now so for this, like in this case, you can see I like the Vinci 5. If you can point to that catheter, so you can see the Vinci 5 has two curves, and the last curve points up towards the gate. So that's actually a great catheter to use, especially if you use your trick where you keep your sheath close to the gate. Now, as you can see here in this angio, we kind of tricking. We're using our pigtail by slowly leaving one of the pigtail in the sheath. So almost we're making the pigtail form like a Vinci catheter and point it up and get into the gate. So, but again, if you have a difficult gate cannulation, I don't know, there's so many things to do. I mean, I don't know what's your go-to, Chandler, if you have a difficult gate cannulation.
You know, I love the Vinci 4 or even a vert catheter if need be, but I think it really depends on what angle you're trying to get to and, you know, how big the aneurysm sac is. So I think it can be very versatile depending on the anatomy.
Yeah, okay. So once we get in, you want to make sure you're in the gate, correct? Because you want to make sure that you're not behind the gate in the sac, and that if you deploy that limb, obviously you're not going to be in the gate. So there's a few things you want to do to confirm. One thing I like to do is rotating the pigtail. Now, rotating that pigtail is important where you do it. You can't do it in the main body low above the bifurcation, because if you're outside and then you're rotating, it's going to rotate in the sac. But we know the top part of the stent graft is in the neck, which there's no sac to rotate. So if you flip the catheter in that neck and it's rotating, then you know you're safe. Because otherwise it would be cinched against the wall and would be straight. It wouldn't be rotating in that area. But there's other maneuvers. I don't know, Chandler, what's your go-to?
Yeah, I think the pigtail works fine. I tend to just use a coda balloon every time. I think it's just 100% fail-safe option to just ensure, and I put the coda balloon at the level of the flow divider, and then I inflate it and just ensure that I get this mushroom deformation of the balloon, and that way you know you're in. I usually get a fluoro save shot of it just so I can document it in the record.
Yeah, so real quick, so basically what Dr. Long is talking about, so this balloon is half of it is through the gate and half of it is above the gate, so that when you inflate, the top part is going to open up over the gate and the bottom part is going to take the shape of the gate. So and then you mentioned fluoro save. That's crucial. Anything you do, just save it to document that you've done it, because sometimes, you know, if you say it in the up report, it's not enough, but when you show it, that speaks volumes. That's a great point. Great point.
And one thing I would just point out here is just the difference between compliant and non-compliant balloons. You know, the coda balloon is a semi-compliant or a compliant balloon, and basically they have an infinite diameter which they can grow to, as opposed to a non-compliant balloon that basically has a fixed diameter. So these coda balloons or any compliant balloon can be dangerous, because if you're totally in control of what that diameter is, and you have to be very careful, because when you're sometimes angioplasting your proximal seal zone, and some of that aorta, your unexposed aorta or uncovered aorta, excuse me, can be in jeopardy of rupturing it there. So you got to be very careful.
Yeah, that's an excellent point. And I've witnessed, wasn't me, but I witnessed that rupture with when people are trying to cut corners. So don't cut corners. Do what's right for the patients. And then finally, now that we're happy, we're in the gate, it's basically limb extensions. Again, you want to make sure that you know your angles, where the internal iliacs are, so you can really maximize your seal zone by extending those stents all the way to the bifurcation. And then it's important that you know RAO, LAO. I'm not sure, China, do you have any tricks for the trainees how to remember?
Yeah, I think this is important. I think the concept is important. When you're looking at the clock face and you're looking at things on the anterior that come off, vessels that come off on the anterior portion of the clock face, you really want to roll in the contralateral direction to the way they come off to really splay out the origin of that vessel. If you're looking at vessels that come off on the posterior aspect of the clock face, you want to roll in the ipsilateral, same direction as the way the vessel's coming off. So for example, your hypogastric comes off posterior medially. You want to roll medial when you're looking at that. If you're looking at your profunda comes off posterior and laterally. So you want to roll laterally to visualize that. Your anterior tibial artery comes off laterally but anteriorly. So if you really want to splay out the takeoff of that, you got to roll contralateral. You got to roll medial, even though the artery's coming off anteriorly and laterally, to really splay that out. So I think that's an important concept that you can remember. So you don't have to memorize which way you do for each vessel. You know the concept. So if you're in a difficult anatomy, if you know which way the vessel's coming off based on your CT scan, you can always get the appropriate orthogonal view to really splay things out.
I mean, that's fantastic. For the participant, remember that. I mean, you will shine in front of your attendings if you know that stuff. So that's a great information. All right, so maximizing your seal zone, we are down to the hypos, and then next we're gonna balloon. Again, we talked a little bit about the coda comes in 32 and 36, two sizes, I believe. One goes through 12 French, one goes through 14 French. And then again, you're molding your overlap, your attachment sites to make sure you don't have any endo leak. And then I typically start from the top down. And then as someone is taking the balloon out, going to the other side, I have the pigtail coming from the same side to save some steps and do your final angiogram. And this is the final angiogram. And I want the participant to answer what's wrong with this picture. We did our final angiogram. And what's wrong with this picture? Who's gonna tell us? All right, well, I'll tell you. I guess we will not. So basically, no hypos. Good job.
Hypos, very good.
Yeah.
That's awesome.
Good job. So, but the patient didn't have any hypos. This was a trick question, so we didn't cause it. But it could happen if you have thrombus and stuff. It could happen. But anyway, good. All right, ready?
Yeah, I think so. So we got 15 minutes left. So we want to move. Why don't we skip this poll? Because I'm sure people got a lot out of this talk. I know I did, and Carlos did an amazing job of laying out some very difficult things. But let's move through this poll and move to our Endo Warrior Challenge. Let me briefly hand it over to Yaz to remind us of these.
All right, I'm ready.
All right.
So we've got your Kahoot on your phone, learners. We have the Zoom on your computer, and hopefully you have
Carlos, I need to get informed,
drinks
okay?
in your hand.
That's it.
Right.
As they get ready, we're gonna have Dr. Bashara getting in ready for this game. Dr. Long as well.
I'm
Guys,
ready.
I'm gonna walk you through this game. Either go to kahoot.it, not.com, or go on your app and make sure you hit this button, because the next screen you see is gonna ask you for a game pin. You will see that on the next screen. After that, put in your warrior name. Guys, if you have no creativity juices left, I've got some for you. You can use, let's say, Cook for Life, Fevar over Evar, or Seal It and Deal It. I don't know. But when you're ready, you will see this game screen. So with that, I guess we got to find out what our warrior names are for our presenters. Dr. Whoops, we got some poll results here. Looks like people still need help at multiple points of the case, but gentlemen, Dr. Bashara, Dr. Long, what are your warrior names here?
All right, Carlos, what's your Endo Warrior name?
I had a title called the Renal King. I'm keeping that title.
I love it. So I chose Endo Machine, but my daughter reminded me that I needed to add obese in front of it. I will do the obese Endo Machine. All right. Are we ready to go?
All right, so as you can see, the game pin is right here, everybody. 1, 1, 6, 5, 9, 5. Go ahead and bring all of your names in here. We're gonna give about a minute for everyone to do this.
Fevar for Life, Open AAA. We see a couple people joining now.
Nice.
3 people, wow, we've got a lot of learners wanting to play here.
Mohammed Jan, Ian Roy, all right. Gotta move my screen here because I'm missing somebody. Another minute and then we'll get started.
All right.
All right.
Hey man, Omni flushed.
Viva Italia.
Oh yeah, nice.
Jesus is king. That is allowable, guys.
I love it.
Coat hanger wiring around. How much longer should I wait, gentlemen?
I think we can get started with this.
Okay, we're gonna start. We're gonna let him still do it. Give it a few more seconds.
That's awesome. Back leader. That's awesome.
Coda cutie. Flying pig.
I like Flying Pig. I think he's gonna roll. He or she's gonna roll with me.
All right, I think this is it, guys. And you can continue to join the game if you're having technical difficulties. We're going to keep it unlocked for the learners. And let's go ahead.
Let's start with our first question. All right, so what is the mechanism of deployment for the Cook Zenith Flex device? All right, now, it's obvious The answer is voice activated. Carlos, you agree with that, right?
Deploy the device.
Yeah, now this one's an easy one, right? I mean,
Elon Musk is working on a voice activated.
All right. All right. So it looks like everybody got the answer right. The pin and pull. Good. Good. All right. All right. Open AAA. Ian Roy, we're leading here. All right. They're going to be in the lead. We got a couple people. Black Bleeder. There. I see you. I see you. All right. Let's go to the next question. Name this beacon tip catheter. Dr. Bashar went through them, explained some. Which catheter is this? Is it T2 Cobra? Is it the vertebral catheter? Is it a Bindu or is it a rim?
It's a sim. Oh, wait a minute. There's no sim.
Right. 2, 1. All right. Let me see.
Oh, good one.
All right. So just, you know, this is one of those, you either know it or you don't, right? This is the Cobra catheter C2. You know, you just got to learn these catheters. I don't expect you to know them right away. The important thing is you just need to choose a catheter that's going to allow you to exploit whatever angle you're trying to get to. Okay. So the right answer was C2. Very good. All right. Next question. Again. Oh, open AAA drop down.
Yeah.
Wiring around.
Wiring around.
All right. So we have a little bit of a change here. And then Vein Man's in third, or Vein, I assume Vein Man's in third place. All right. So next question. Name this beacon tip catheter. All right. Now, if you guys get this one wrong, Dr. Bashar is going to come through the video monitor and get you. Yeah, you do not want to get this one wrong. You do not want to get this one wrong. Everybody needs to get this one right.
I thought they're going to get 3 seconds with this question. Who's giving them time?
All right. So it looks like by and large, most people got this answer right. And it is the Banshee 5. And apparently, let's show that picture real quick. So we went through the catheters. You basically have a Banshee 2, 3, 4, and 5 moving from left to right. And so the 9 of you that got that question right, Dr. Bashar will buy you a drink at the next SVS meeting, if it's ever in person again. All right. So who do we have? Wiring around is still in the lead. Vein Man is in third, and we have open AAA. All right, let's go to the next one. All right, so what II orientation best allows you to visualize the takeoff of the left hypogastric artery? I think it has to be cranial and caudal together.
Okay, that's a good point.
Right?
Wait, you say left profunda?
I think it was the left hypogastric. Left hypogastric. All right, look. A lot of people got it correct. I'm surprised. I thought that was a harder concept to grasp, but they got it. So just remember, whether the vessel comes off in the posterior clock position or the anterior clock position is really how you're going to decide that. If it comes off in the posterior clock position, which the hypogastric artery does, you're going to roll ipsilaterally to the direction, and it comes off medially, so you roll medial. And if you're looking at the left side, that would be a right anterior oblique view. All right, very good. Next question.
That's good. Let's see who's all right.
9 rounds, not messing around at all. You got open AAA, EVAR for life, and Ian Roy. All right.
Look at open AAA. They know their extra
is
stuff.
The safest to be used for initial access as a starter wire. You got to choose the right wire, and the reason why. It's not because it's green.
The wires come in like blue, pink.
All right. Well, everybody got that answer right. It has a lower likelihood to dissect than the Benson wire, the floppy wire, so that's good. All right. Let's go on to the next one. Uh-oh. We have a change in the lead. EVAR for life is trying to get the grand prize here. All right, next question. Rank these wires in order from increasing stiffness. All right, so go from floppiest to stiffest.
You mean diameter or what?
I I'd say rank him who has the best curve, right? I'm all about curves. If you're
Yeah.
obese, you want the curve, right?
Careful with the wording now.
All right. So it looks like everyone was not tricked by that question. So it goes Benson, Rosen, Amplatzer, and Lunderquist. All right. Very good. Let's see who's in the lead now. All right. Open triple A. Back on top. Evar for life falls to say aortic fixer. Where did they come from? All right. I love it. I love Flying Pig. That's who I'm going for. I'm telling you. All right. Next question. What infrarenal neck anatomy falls within the Cook-Zenith inclusion criteria? All right, I want you to read this carefully. What inclusion criteria? What can you pick with Evar? If you're Carlos and I, it's anything.
Why do you need the neck when you can put a clamp on?
You're right. It's a totally silly question. All they have to have is an aorta to be fixed. All right. Good. Most people got that question right. It's important to remember you need that 15 millimeter neck and less than a 60 degree of angulation. Very good. Let's see if this changes. All right, Evar for life. There we go. Didn't have much change there. Wiring around. You're falling back. All right, true or false? The Coda balloon is a non-compliant balloon.
There's no third option, both. True or false?
False. This is that. Most people got this right. Good. It is a compliant balloon. It is a dangerous balloon. You got to be careful of that. All right. The leaderboard has not changed much, but we are going to move to the next question before we get to our final round. Where would you inflate the Coda balloon to minimize the likelihood of a type 1 or type 3 endoleak? I choose E. E is definitely the right choice.
E. Is there an E?
Oh, there's an E. You don't see it?
I got it.
All right. It looks like the majority of people got this one right. You want to hit the proximal and distal zones. That's right. And you want to hit your overlap zones. Very good. Very good. All right. Yaz, I'm going to let you give them a quick, brief intro to our last two questions, which are a little complicated.
All right, learners, you have two more questions. More points are at stake here, 2,000 points here, but you got to place the answers in order and press K. That is key. So on the next question, we are going to practice. Hopefully nobody gets this wrong, but if they do, it's probably because they didn't just pay attention. So put these numbers in order, small to large.
I'm confused already.
Yeah. Wait, what about the shape?
You got to factor in shape. You got to factor in shape. I'm more of a diamond type of guy. I don't know.
Okay.
And you get more time to answer. 60 seconds as opposed to 20 seconds.
So maybe I should be the circle.
Yeah, but these are smart guys. Why do you give them 45 seconds? You're saying that, I mean, they're smart people. Why they don't need 45 seconds?
You have 45 seconds to cannulate the gate. How about that?
On what they're putting in their coffee right now.
Oh, I like the music.
Getting real, guys. Two more questions for the winner. All right, I wonder if I can skip it.
I think they got it.
I think they got it.
All right. Our last two questions. All right, these are double the points.
Whoa.
List the steps of the micropuncture access kit in order. In order. All right.
Oh man.
Carlos, you think this helmet is COVID approved for the OR?
Well, give it a shot. I don't know.
I was going to try to get a little visor. At least it allows my loops to fit in here, right?
That's true. That's true. You can breathe better. Oh boy. Okay. So you ultrasound, you get access. Okay.
Looks like everybody's responded. All right, let's see what we got.
Oh, good one. So,
All right.
well,
all right. Let's see how this changes. Open AAA followed by Flying Pig. I'm telling you, Flying Pig has what it takes. All right, our last puzzle piece. Place these deployment steps in order. All right.
Okay. I got this one.
I'm going with release the top cap right away.
But there's no voice activation here.
Yeah, this question's flawed right off the bat, isn't it?
Yeah, I thought you can say.
Where's the step that says hold my beer and watch this? I was looking for that.
Yeah, I know. And then actually, hey, yes, you said can you indicate in under 45 seconds. So
let's see.
I don't see it.
I just.
All right, so we're gonna move and
all
see.
All right.
You got all the answers?
Oh, see, this just proves a point. We got to have you meeting with your local cook rep so we can get all these things squared away. All right, let's
see. That's going to change. That's going to change.
All right. MK is in first place, 6806. And who is 9615 is in first place. Open AAA. I love it. I love it. Flying Pig came in second. That's good. Congratulations to our Indo Warrior champion. Cook will get you a yacht, but you have to pay for it, pay the taxes, and go find it. But this is great. I want you to contact Cook so they can put you on the Twitter page or something and give you the just due that you reserve. This is a great event. I want to first off thank you, Houston Methodist, for allowing us to do this. I hope you guys enjoyed it. We'd like to thank Cook Medical for putting this together, and most importantly, Dr. Bachara. You are amazing, my friend. You gave an excellent talk, and I'm sure all of the fellows will be better off now they have this knowledge.
Well, thank you. And also, you did a great job too, my friend. It was fun, and I hope you guys learned. And again, like they said, again, connect with your local rep. They have a lot of educational platforms, some personalized educational platforms for you. So please make sure you connect with your local cook reps.
Right.
Congrats to all on your starting your fellowship.
Thank you.
We're done.
All right.
All right. Am I back up? That was very, very good. That was really excellent. Very professional. Most of the game show hosts were superb. There are a few exceptions. We can tutor them up a little bit, but nevertheless, very good. That was really excellent. Okay, so we're ready to start rocking and rolling again. I didn't know you had such talent there, Carlos.
Trained by the best.
Yeah, that's true. I should have figured that out. Conceited as I am. All right, we're going to keep going. Dr. Maham Rahimi has joined us. He's another one of our faculty members. So we're going to kick this off with a couple of his videos, actually. One is on an open AAA tube graft, and then the second one will be an infected graft. So let me share, and Maham, you can take it away, maybe, if I can find them. Hold on. All right.
This is an open repair of an inflammatory symptomatic infrarenal abdominal aortic aneurysm. The patient was a young woman who presented with abdominal pain and was found to have an inflammatory infrarenal abdominal aortic aneurysm. Therefore, decision was made to proceed with open repair. The patient was brought to the operating room and placed supine on the table. General endotracheal anesthesia was induced. A midline laparotomy incision was created by cutting through the skin, followed by the subcutaneous tissue. The peritoneal cavity was entered by incising the linea alba, as shown here. The bowel was mobilized and adhesions were taken down from the abdominal wall. Exploratory laparotomy is performed. Once the bowel is freed, the transverse colon is retracted superiorly, and the small bowel is retracted to the patient's right, enabling us to expose the retroperitoneum. The ligament of Treitz is divided. A retractor is placed to hold the bowel in place. The retroperitoneum is entered by incising the posterior parietal peritoneum. You can see here that the aorta and aneurysm become apparent as you enter the retroperitoneum. The proximal aortic neck is dissected free in order to obtain proximal control of the aorta. The distal aorta is also dissected free. As you can see here, the common iliac arteries are exposed. Control of the left common iliac artery is obtained here with a vessel loop. Next, the right common iliac artery is controlled in a similar fashion using a vessel loop. The IMA is dissected free and controlled with a vessel loop as shown here. Finally, proximal control of the aortic neck is obtained using umbilical tape. Now that the aorta has been dissected and we have obtained proximal and distal control, we can proceed with clamping. The patient is heparinized, and once an appropriate ACT is obtained, the common iliac arteries are clamped first. Here you see the left common iliac artery being clamped. Next, the right common iliac artery is clamped. Clamping the iliac arteries first prevents embolization to the lower extremities. We use a soft Fogarty clamp, which can prevent vessel wall damage in the setting of severe calcification. And here the proximal aortic neck is clamped. Next, the aortic sac is depressurized using a needle as shown here. This prevents blood from spraying when the sac is entered. The aneurysm sac is entered using an 11 blade as shown here. The arteriotomy is extended using scissors. We open the entire sac. This allows us to fix any bleeding from within. Upon opening the sac, we will evacuate all of the mural thrombus inside. Here you see this mural thrombus being evacuated from the aneurysm sac. You can see that there is some bleeding coming from the lumbar arteries here, which can be repaired from within using suture ligation. The aorta is transected distally and proximally as well in the same fashion. Once our proximal and distal endpoints have been adequately cut, we are ready to proceed with the anastomosis of the tube graft. A Dacron graft is anastomosed first proximally as shown here, using 3/0 proline suture in a running fashion. Once the anastomosis is created proximally, the next step is to pressurize our anastomosis and ensure that there is not any leaks. If we find any leaks at this point, they can be repaired primarily or with the use of pleated sutures. Once satisfied with our proximal anastomosis, the pressurized graft is marked and cut to length so that we can begin our distal anastomosis. The distal anastomosis is now performed using 3/0 pulling suture in a running fashion. After completing the anastomosis, the graft is flushed and the proximal and distal clamps are released to reestablish circulation to the lower extremities. The colon is examined and Doppler signals are checked at the mesocolon to ensure that there is no colonic ischemia from the ligation of the IMA. Once satisfied with the appearance of the colon, we proceed with suture ligation of the IMA. Alternatively, the inferior mesenteric artery can be reimplanted at this point if needed. We now proceed to close our aneurysm sac over the graft as best as can be approximated. We do this by using 2/0 vicryl suture in a running fashion, as shown here. Once the sac is closed, we can close the retroperitoneum. The posterior parietal peritoneum is closed in a running fashion with the same suture.
Can you hear me all right?
Yeah, we can hear you.
The small bowel is inspected.
Oh, let me stop that. Manny's still talking.
To its appropriate location. The greater omentum is placed over the small bowel. The fascia is then closed with running loop PDS. This is followed by stables for the skin. The circulation to the lower extremities is checked before leaving.
All right, finally stopped them. There you go. Okay, Maham.
You were asking the question of how do you decide
Yes,
whether
thank
you're
you.
going to do
Good
a tube
afternoon.
graft or a bifurcated graft?
Yeah. Can you hear us, Maham?
Yes, if I can do a tube graph, I try to do it. Yes.
Yeah, but I mean, so you look at it, you look at the CT scan preoperatively, you try to make a decision, but there's certain intraoperative findings that may change that plan. But at some point, you got to commit to whether or not you're going to take a bifurcated graft on the field or you're going to put a tube graft on the field. And so, one, you got a pretty good idea from the CAT scan, but the second part is the quality of the iliac arteries. I mean, sometimes you get down there and they're so calcified you can't even sew to them.
For sure, I agree. I think you get majority of the information you need from the CT scan. My recommendation to fellows and residents, review the CT scan before going to operating room. Know, is there any hernia, location of it? Okay. What is the anatomy of renal vein? Located pre-aortic or retro-aortic or circumferential? That becomes very important. Is there any replace hepatic artery? Is the SMA occlusive? Do you need to revascularize it? So know your CT before going to operating room, plan your operation. But as Dr. Lumsden said, that might change intra-op.
So
yeah,
John,
that actually is a huge issue, and it's a big point, is if you if you're an orthopedic surgeon and you're doing total knees, you don't even have to be alive during the operation. I mean, basically the operation is going to do itself. Vascular surgery, the worst mistake you can make is be too rigid about your plan. You need to be able to, and you've made a good point of it, you need to be able to make decisions on the fly that are going to adjust to what your intraoperative findings are. And while it is true that you get some information from the CT, you can't feel things with the CT. You don't know how, what looks like calcium may be soft calcium that you can actually put a needle through. Sometimes you can't. And those are things you can only assess while you're in the room. And if you're committed to one thing or another, you'll do the wrong operation. So you really do have to be able to some degree, read the tea leaves while you're doing this procedure. You'd think, well, I'll just put a bifurcated graft on every one, leave the body of the graft long. But you can't do that, because if you leave the body of the graft long enough to be a tube graft or convert to an aortoiliac graft, your legs will come off at 90 degrees and it just doesn't work. The body of the graft's got to be shorter than the tube graft would have been. So it's not the worst thing in the world. If you choose a tube graft and you need to bifurcate it, you sew a bifurcated graft on. The other thing I think is tricky is when you're used to looking at CT scans for your size measurements. And if you just looked across the board for most aortic, if you said, what's the right size for occlusive disease with a bifurcated graft? 16 by 8 is probably the most common bifurcated graft that we use. 18 by 9 is probably the most common size if you're doing aneurysmal disease, still doing bifurcated grafts. Maybe a 20 by 10. It's never a 30. And yet we put lots of 30 and 34 endografts in these 28 and 30 millimeter aortas. One of the things to remember, since the history of these polyester grafts is they do stretch. There's at least a 10% stretch over the course of time, and in years past they even stretched more than that. So you have to sort of accommodate. You don't really want a one-to-one size match between your CT scan diameter of your aortic neck and the graft you choose. For open surgery, it's going to invariably be a little smaller diameter. Like I said, it'd be a rare bird for an infrarenal aorta that you'd put in bigger than a 20 millimeter graft.
Yes, on the question, so Carlos has raised a question about, do you always get circumferential control of the iliac? And John, let me combine that with, although I'm pretty enthusiastic about dividing the proximal neck, I'm a little bit less than enthusiastic about dividing the distal neck.
Yeah, you almost never, well, okay, so we have to talk about two things. One is whether you divide the proximal neck or divide the distal neck. And certainly if you do divide the proximal, well, the question would be, why not divide the proximal neck in everybody? What's the disadvantage?
Well, the disadvantage is sometimes you get into bleeding behind it.
Right.
That's the main thing.
And whether the CAT scan shows that there's a circumaortic renal vein or whether it's a true retroaortic renal vein, the reality is there's always veins behind the aorta. And if you don't want to get into veins behind the aorta, don't go behind the aorta. And that's the reason people leave the back wall intact generally. And therefore, I think if you just, I imagine if you polled most vascular surgeons for aneurysmal disease, most are going to use a pinning technique, meaning a vertical clamp that pins from side to side. What's the disadvantage? The disadvantage of that is the sort of fornix, the bottom end of where that clamp is, the aorta is folded together, and it's where we were talking about this morning, where you can get a pleat. With a vertical clamp, that 6 o'clock stitch and the 7 and the 5 on each side of it, it's hard to get that to lay out. Whereas with a transverse clamp, let's say you put a Satinsky on.
I mean, and that's probably the most, particularly if you haven't divided the back wall, is the most difficult area to fix the worst problem.
Right. And it is, it can be. On the other hand, you have the advantage with a double wall when you leave the back wall intact. You've got essentially a biologic pledget all the way around the back wall. There's no real reason to put a piece of felt because you've used the aortic wall essentially as the pledget. So again, your attendings are all going to have reasons why they want to do different things, and half of them are going to be wrong. So just assume that's the way it is.
But again, it's not so much what your solution is. I honestly think the key to the vascular surgery, and it's true of a lot of surgery, it's not knowing what the answer is, it's knowing what the questions are. If you know what the questions are, you know, Alan and I like to fish. There's a lot of different ways to rig these fishing lines. You know, some people use a popping cork, and some of them use this, and they want to use a spin cast reel, or they want to use a bait cast. And there's a lot of different ways to catch the fish, but the key is what are you trying to catch and how are you going to do it? So I think the important point is, what am I trying to avoid? I'm trying to make it easy for myself. I want to make sure I can have a hemostatic anastomosis. I want to make sure I don't injure venous structures. I want to make sure I don't damage the bowel in the process. How you go about doing it, again, is going to be quite individualized. I don't usually like to transect the proximal end of the aorta, but again, a lot of your attendings will. Distally, you'll virtually never transect the aorta because it's just so hard to peel the aorta off the left common iliac vein. Trying to peel the aorta off the left common iliac vein and the terminal part of the vena cava is just very easy to get into it. So you'll almost invariably leave the distal aorta intact. There is a technique where people, I've actually taken it, and you can find it in JVS, where you take a dental drill and drill sequential holes in calcium across the back wall of the aorta and put individual pleated sutures to hold the back wall of the back end of a tube graft in place. And then usually the front wall doesn't have heavy calcification, so you can usually do the front wall. So if there are situations where you really don't want to do bifurcated graft, there are techniques, but they're not very common. You don't need to do it very often. The other is the fact now that you have bailouts for the common iliacs in terms of if you have a little occlusive disease or a little flap, when you don't have endovascular techniques, you got to make sure you fix all that with your open bypass. Whereas now, if you can get a tube graft in and your iliacs aren't perfect, well, you can always put stents in. So you have some solutions that you wouldn't have otherwise. So again, it's kind of, balance what your tools are with what your problem is. Circumferential control of the iliacs. I mean, you know, there's nothing really good about it. You're just you're going to get into iliac veins. On the other hand, it's nice to be able to transect them and have them stand up in the air, and it makes them so much easier. So just for the sake of ease of anastomosis, I usually do wind up transecting the common iliacs. Yeah.
So coming around the back of the iliac artery, again, when the iliacs are aneurysmal, that's the ones you really worry about. If it's easy to get circumferential control, I take it. And if I've got that right angle behind the iliac artery and I have a hard time telling where it's going, then you just clamp at AP and you just got to deal with the anastomosis, which is going to be technically a little more difficult. Okay, Maham, any comments to close this one? Then we'll show the next one.
No, I agree with all the comments. If the iliac artery is attached to vein, I just leave it alone and transect it partially for anastomosis. I agree.
You going to tell us what that brown graft was you were showing in there? Oh, that's spectacular. What was that brown looking graft you said? Where do we buy those?
It's a rifampin. Are you studying the rifampin?
Yeah. Tell them about rifampin soaked grafts.
Yeah, I soaked everything in rifampin if I can. I hate infections.
So you got a good point. Soak everything in rifampin. It's hard to argue with that.
Oh, you can argue with it if you want. I mean, you know, again, we usually try to burn a little bit of incense in the background in all of these cases. And if we can't get incense, then we use rifampin.
So what's the formula, Maham?
One bottle
It's a 600 milligram of rifampin in 500 milliliter of saline, and you just soak it for 30 minutes or more.
Yeah. Okay. Are there any data? I mean, the problem is the index case here. The frequency of graft infections is so low. You got to do 10,000 cases to try to prove that rifampin soaking is going to be of some benefit. So you know, we do it, and rifampin is dramatic because it looks like it's radioactive. You know, it's got that orange glow, and it makes you feel like you're doing something. and it probably doesn't hurt in most cases. I'm not sure how efficacious. There was a study out of, it was a European study a few years ago, when it was only 2/3 of the bacterial isolates that came out of some aortic infections were actually sensitive to rifampin. So it's not a universally effective antibiotic. So again, it probably doesn't hurt anything. It would be nice if we had some data to really support it.
So there's a question about using bioglue. I mean, I don't think anybody uses bioglue down here. I'm not even sure the heart surgeons use them in dissections anymore. The problem is when it hardens, it's like a piece of rock. It also generates formaldehyde, which has affected nerves when it's been used up inside the chest. So we're not really using bioglue. I mean, our hemostatic agent of choice depends how bad the bleeding is, but we tend to use Everest, but Everest is pretty expensive. So if it's just a little bit of background oozing, we're going to use something like Surgicel. If it's a little bit more than that, we're going to use bioglue. Not bioglue. You got me thinking about it now. Everest, but as I say, kind of expensive. Carlos asks, do we use Amentum in all young patients? You want that one, John?
For what?
Cover the graft. I was waiting on your comment because you noticed that Maham reperitonealized the graft, and I was waiting on you jumping up in your seat.
I was going to say something about it. Yeah, actually, I will say with this, throw that camera over here, because I will say one thing I do, because I've re-opted somebody for this. When I close the aorta, so you got this aortic aneurysm, you got a graft down here, I actually close it almost always with what I would call a running vertical mattress. In other words, a stitch that does that and comes over like that. And the purpose of that is to turn the edges of the aorta in. Now, what's the disadvantage? You know, part of the reason that you're running this suture down the aortic wall is for hemostasis. So I try to get a little of that hemostasis with my bovie when I enter the aorta. I like to turn the aorta in because I have, you know, if you just run this together, that suture line will often be quite rough, and some of that thick atherosclerotic aortic wall will be sort of pooching out, and it kind of creates a surface. I re-op somebody for a small bowel obstruction. The small bowel was just essentially stuck to the aortic wall where it was sort of inflamed. Whereas when you turn those walls in, I think you get a smoother surface, and you're less likely to get a bowel obstruction. If you can't cover your graft with the aortic wall, you're operating on too small an aneurysm. That's my general philosophy.
No, but I mean, but this was a tube graft, and so he couldn't really cover the proximal. You'll notice as they closed the aneurysm sac, the proximal end was not covered. Yeah. And so,
and that's true because that's the neck of the aneurysm, so you don't have diameter up there, so you have to pull the peritoneum over. But then, what are you sewing it to on the right side? What do you sew the peritoneum to back under the duodenum and up around the right renal artery?
Just don't want to go too deep, or you're on the inside of the duodenum.
Well, you're in the cava, unfortunately. There's nothing over there. There isn't anything to sew to. You know you're not sewing to anything that's got a name. You're just getting that soft stuff that's kind of adjacent to the vena cava, trying to tack the peritoneum down to it. But there's really not a named structure, and you just got to have to use your, use your judgment about how to do it. But you really shouldn't leave the operating room with Dacron exposed to bowel if you can avoid it. Now, if you do, which is sort of hysterical in a way, in that we do these debranching procedures, and you have the spaghetti coming off the iliacs going in through to the, say, the SMA or the celiac, and obviously they have to be intra-abdominal. And some of those things do erode into bowel, but if you can, you'd like to not have bowel in contact with raw polyester. You will occasionally, it's much more common, for instance, to have a graft enteric erosion from an old aortic graft than an aortoduodenal fistula. In other words, a true connection between the lumen of the aorta, or the aortic graft, and the GI tract is pretty uncommon. But to have the GI tract erode so that you got a mucosal injury that doesn't lead to catastrophic bleeding but leads essentially to anemia is a much more common scenario. So again, you should try not to have GI tract in direct contact with small bowel.
Yeah, I mean, the other part of that is patients do get reoperated on for a variety of different reasons. Peeling small bowel off a piece of Dacron, a better man than me if you don't have a couple of holes in it by the time that
You'll
you
always
can
take
do
the
that.
Serosa with you,
Yeah.
that's for sure.
Okay,
Let's see
okay.
chats. What else we got?
Yeah, I'll pull up the next one if you look
Yeah,
at
if you
look
have
at
no
that.
choice, if you, for instance, if there is no aorta, then and the question I have for the other guys that are on here is, when you bring omentum down, do you just pull it down with the transverse colon, or do you flip it back through a fenestration in the transverse mesocolon? I've had a bowel obstruction also from sort of kinking the transverse mesocolon by just pulling the omentum straight down on the aorta. So I usually mobilize the omentum and make a fenestration in the transverse mesocolon and flip the omentum through that so that the transverse colon is not really deformed and pulled down toward the aorta. Now, I don't know, that may be, again, we're talking about really, is that science or just a lot of nonsense? I don't know if it's nonsense, but that's usually the way I try to do it.
So how do you decide where you're going to split the greater omentum?
I try not to go through the middle colic artery.
So you kind of hold it up.
I kind of
and
hold
let
it
it
up
fan
and
out
look.
so you can see it.
Yeah.
And then choose. You can often see the major branches of
Yeah,
it.
I'm not sure that it matters whether you're to the right side or the left side of the middle colic, but you try to go through an avascular area of the transverse mesocolon and come through there. I've found that a better way to do it.
So do you peel it off the transverse colon, or do you just flip the whole thing back and round? Because there is a plane that you can actually peel it off the transverse colon and then take it through the transverse mesocolon.
Right. If I can do that, I mean, it's one of those things that if you've had lunch and you're feeling comfortable and you don't have somebody waiting in clinic, and you can take a bovie and essentially peel that apron off of the anterior surface of the transverse colon, and you can truly free the two of them. And remember that the omentum is really a folded two-layer structure, right? So it's folded down and come back. So you're kind of peeling it off the transverse colon. That's the nicest way to do it, as opposed to just leaving it attached and flipping it underneath. Again, this is a little bit of what's the material there in front of you, and what are you feeling, and how is it going to lay? If it looks bad, it probably is bad. This is where you just, have to use your surgical judgment. Make it look good, make it look like it's not going to kink. I mean, I think this is the opportunity to be in, where the sort of art comes in, I think.
But to answer the question, we've got a pretty low threshold for turning the piece of omentum down. If there's any graft exposed, I would do absolutely this. Now, sometimes the omentum is not big enough and you can't really get enough, but that's not the case in most patients. So yeah, graft exposed, put something on top of it.
I can remember a lawsuit that I heard about early on where there was no dictation that the aorta was covered, was retroperitonealized. And they wound up with a bowel, with an aortoduodenal fistula, and a lot of the case swung on the fact that it wasn't in the dictation. So I would make sure that your dictation says the aorta was covered when you finished doing your aortic surgery.
Anybody who's ever used a flap of prevertebral fascia to cover the aorta? It's described, but it looks, it's one of those things that looks a lot easier in the books than it is when you're looking down at the bottom of this hole.
One of the techniques for primary aortic infection or aortic graft infection, and you've decided to do aortic ligation and extra-anatomic bypass, one of the techniques for trying to oversew the end of the stump of the aorta is to free up some anterior spinal ligament off of the spine and use that for additional tissue to sort of bracket around the end of the aorta. This stump blowout, we talk a lot about it.
We're gonna talk more about that.
Yeah.
We've got a video specifically on that.
Okay.
Okay, so how about we go to Maham's other video.
The other thing we didn't talk about a little bit earlier was this: how do you manage suture line bleeding, again, at the proximal anastomosis?
This case is a 70.
The one technique we didn't talk about, you referred to something similar to it, that was to wrap felt around the anastomosis. Another technique in the end-to-end anastomosis is just to take a cuff of graft and slide a cuff of graft, the same graft you just hooked up, you've just sewn it on. Take 3 centimeters of it and just slide it over the anastomosis. And now you've got this external buttress that holds around your anastomosis. It seals all the needle holes and is a great way to get out of Dodge if you really have a tenuous aorta where you've done an endarterectomy and you've got some needle hole bleeding and every time you put a stitch in it bleeds more, is to just take a cuff. And actually I do it on all my proximal aortic anastomoses where I've gone end to end, is put a cuff over it. It makes re-opping an aorta easier because when you're trying to free up the aorta from surrounding tissue and you've got an infected aorta or something like that, sometimes you're taking a right angle and you're coming up your Dacron graft, you'll just dive right into the anastomosis. But when you have a cuff around it, it gives you a little guide point of I'm getting close to my anastomosis, and then you slide over that and it avoids just sort of inadvertent disruption of your suture line.
Okay.
I just have a question, if Lawson.
Yeah, sure.
So I think we worry a lot of time about the suture line eroding into the duodenum, which causes the aortoduodenal fistula. So just taking your idea of wrapping the felt around the proximal anastomosis, I just thought about wrapping like pericardial patch, like wide pericardial patch around the proximal anastomosis and just fixing that with a clip, like what you do with the felt. You think that can help not need a mental flap to cover that?
I don't know. It's a good idea. I don't know. Short answer.
I guess I consider pericardium as foreign as any other foreign material. It's still basically shoe leather. So I wouldn't trust it as a biologic membrane. Now I will say I worked for a gynecologist when I was a resident for 3 months, and we used to do free omental patches when we were doing like myomectomies for uterine myoma, and he'd take out all these little golf balls out of the uterus, and you have all this patchy looking surface, and he'd just take and free cut a piece of omentum and just sew it over the uterus. I'll swear 3 months later we'd come back and look at those things and it would be smooth as glass. And I mean obviously it's not going to stay alive, but I'm not sure that you all figure it out. I don't know if it's a good idea or not, but putting in some soft tissue between the bowel and the graft I think is a good idea. Whether I don't know about whether a pericardial patch would really accomplish the same thing.
All right, so I hope Carlos is still on because I think this is his technique for taking out the proximal fixation system. So let it go.
Old man who presented with an infected EVAR with past medical history of a ruptured AAA. As shown in the CT render, he had undergone placement of an infrarenal EVAR, aorta uni right iliac device with a fem-fem bypass in 2017. CTA showed a retroperitoneal abscess extending to the aortic aneurysm sac and the left psoas muscle, left hydronephrosis, intraperitoneal air and fluid, a patent aorta uni right iliac bypass, an occluded left common and left internal iliac arteries, and a patent femoral bypass. He underwent an exploratory laparotomy, a left hemicolectomy for a perforation in the descending colon, open cholecystectomy for focal necrosis of the gallbladder, and supracelic control of the aorta. After 48 hours, he underwent an abdominal washout with placement of a right double J ureteral stent and a percutaneous left nephrostomy. 2 days later, he underwent explantation of the infected infrarenal endovascular stent graft with interposition of a 24mm bifurcated rifampin-soaked aorta uni right external iliac Dacron graft. We entered the abdomen through a midline incision and found enteric content in the peritoneum. A perforation was identified in the descending colon. We performed the left hemicolectomy and cholecystectomy as the gallbladder had areas of focal necrosis. We then obtained supracelic control of the abdominal aorta with an umbilical tape, which was clipped to the anterior abdominal wall. An F-TheraBac was placed. 96 hours later, the left limb of a Dacron graft was resected and sewed with a blade lock stitch. It was then soaked in rifampin. The tube of a 20cc syringe was transected. It is later used to explant the infected EVAR. The aorta was exposed in the usual fashion. The ligament of Treitz was transected and the duodenum was mobilized to the patient's right. The left renal vein was identified and ligated to allow access to the suprarenal aorta. We obtained vascular control of the suprarenal aorta and both renal arteries. We obtained distal and proximal control of the right external iliac artery and identified the right ureter, which was controlled with an umbilical tape. The inferior mesenteric artery, which showed adequate back bleeding, was ligated. After heparin administration, the right external iliac artery and the suprarenal aorta were clamped sequentially. The aortic aneurysm sac was opened. Feculent content was identified. The aortic sac...
I want to stop there for 1 minute because the aneurysm sac is uniformly thickened and inflamed when you come to take an endograft out of it. And there can be a lot of bleeding from the wall. And so one of the areas you really need to look at is the wall of the aorta and make sure it's hemostatic.
Was freed from surrounding structures as it was plastered to the inferior vena cava. The sac was then removed. The distal limb of the EVAR was removed from the distal common iliac artery. The artery was then dissected distally, and it was suture ligated just proximal to the takeoff of the right internal iliac artery. Using the tubular portion of the transected 20 cc syringe, the proximal stent graft was removed with minimal trauma to the aortic wall. Proximal dissection was continued until healthy aortic tissue was identified. All remaining aneurysmal tissue was resected. The cavity was washed with rifampin. The rifampin-soaked aortic graft was anastomosed in an end-to-end fashion to the infrarenal aorta. After completion of the proximal anastomosis, Doppler signals confirmed adequate blood flow to both renal arteries. The aortic clamp was then moved distally. The distal end of the graft was anastomosed to the right external iliac artery in an end-to-side fashion. The previously created omental flap was used as a vascularized pedicle to cover the aortic graft circumferentially. It was fixed in place using interrupted silk sutures. The peritoneum along the right parieto-colic gutter was closed, as was the abdominal wall. Anatomical colostomy was then created.
We will stop it there. Maham, comments, your case.
Yes, sir. Minimally invasive. So the infected aortic graft patient could be a stable, unstable. If they're stable and you're thinking about doing a stage, perhaps you can do an extra anatomical bypass and then explant. But if unstable, you're gonna do them all. The axe bifem advantage is that it minimizes the lower extremity ischemia time and less insult to physiologic insult to the body. But occlusion rate and stump blowouts are high. The stump blowout is lethal and is about 10%. Reinfection for these cases, 10 to 20%, and often lethal again. There are many ways to do explantation and rather revascularize either in situ versus extra anatomical. For the in situ, you could use NASE. It would have been great. I could use NASE for this patient, but it was kind of unstable. So rifampin soak was chosen. I have stopped using cryovein because of aneurysmal degeneration and also melts and it gets infected, and it just the whole body and a cryovein graft is in danger. So I rather rifampin soaked if I can. Like extra anatomical, again, axe bifem is a situation. Right. If the patient is stable, you could pull off the patient for IV antibiotics, resuscitation, drain if possible, and go to the operating room, but sometimes you just cannot.
I think we
it
just
sounds like
lost
it's
you,
gonna
Mohammed.
actually
And
be a little
last
bit-
point I make is there are deep.
Go ahead.
Sorry, connection might be bad. The last point I bring up, there are different techniques to take the endograft out. Simply press anteriorly and then fold the graft and take him out, but be careful, don't force it, because if you tear the posterior wall, again, another lethal injury. The other method is using a Rommel technique in umbilical tape in order to constrain the proximal endograft, or you can use the syringe technique.
Okay. Makes it a lot easier to tunnel the omentum when half the colon's missing, I noticed. That looked pretty good. So Maham has a very interesting...
Yes, it made it easy.
He's an interesting boot camp story because first time I met Maham, he came to boot camp 3 years ago. 3 years ago, Maham said, "You need to give me a job." And he was right. So he's been part of our group ever since. So be bold when you're looking for jobs. You were going to make a comment, John?
No. Well, no, we can go on. Let's show some more videos.
Okay. Do you have something you want to show?
Oh, I've got a couple here we could show. Let me see if I can get this dang thing up. All right, so I need to hit share screen, I think.
So I'm going to answer some of these questions. Is there a role for prophylactic urethral stents? Absolutely. No problem in putting urethral stents in other than it slows you down. It's kind of nice if they'll do it the day before rather than the morning of. Juan Francisco says they're still having audio problems, Tyree.
Now, is this going to have, I need sound off of this video if we can get it. Is that going to work?
What's the common practice at Methodist regarding infected prostheses? Rifampin, soak, cadaveric, extra-anatomy, probably all of the above. We do NACE. We've probably done a couple of these in the last couple of months. Not my favorite operation. Most of the time it's in situ rifampin soaked. Okay, this looks like your movie.
I need a little audio. I'm not sure. I think I have my audio muted here, maybe.
Can you guys have a look at this computer? Yeah, thanks.
Do you want me to have sound on the computer?
It's coming.
Okay.
We hope.
Yeah, let's see what we got here.
Yeah, go ahead and just,
Hey, Carlos, you want to make a comment about using the cutoff
for speakers?
syringe for taking these grafts out? Maybe be gone. I do believe Carlos wrote one of the earlier papers about that.
The sound comes on after it comes in a sec. I should have sound now.
anything?
No, it should have sound.
All right, 1 second, sorry.
Oh, gosh.
Yeah, so one of the ways to take out these grafts, I've actually had some devices made. I've actually made them out in my garage. They're little rings, and I had a whole series of sizes in diameter from about 12 to 18 millimeters. A little, basically just like a wedding ring on the end of a steel handle. And I would take that and cut the endograft in half and then just take that steel ring and just slide it north. And as it does, it constricts the vessel, the graft circumferentially and pops the barbs out. So it was ideal for cook grafts. Yeah, we'll get this sound because I want you to hear the sound. It's worth it. But that'll take it gets those circumferential.
There you go.
Noises out. That's me talking, unfortunately.
Sorry.
Yeah, it's all right. This is a pretty common problem, is having to take out these infected aortic grafts, and I don't know exactly, why that is, but my suspicion is that some of these people had they had aortoduodenal fistulas before they ever got their endograft.
Hey, John, I've got your movie. Let me just run it off this computer then.
That's fine.
How about that?
Run it.
Yeah, okay. So why don't you quit saving, and I'll show it from here.
Is that the Brucella one?
Yeah.
Yeah. See if it'll run off of that one.
Yeah, this is it.
See if that's got sound. See if you got sound.
Oh, I should have sound because all the other ones have got sound.
So this was a, let's see if this will, you're muted now.
They are just a pain. They tear up everything. They cost lots of money. They tear up a lot of equipment by us hitting their holes. And they do carry animal diseases, which cattle can get. So there's just lots of negatives and not much positives. They will kill lambs and stuff. They will actually physically attack the animal. If you don't eliminate 70%, then you're not even staying even. You know, they're the most prolific thing. The trapping and the helicoptering is the two most efficient ways of getting rid of them. That's where you get rid of volume. That's where you get rid of numbers.
We present the case of a 48-year-old woman living in rural East Texas in an area with a large population of wild pigs who presented with a several-week history of low back pain and asthenia. Her SED rate and CRP were elevated, but a CAT scan at that time was felt to be normal. Her workup continued with an emphasis on inflammatory arteritis. 4 months later, she presented with the acute onset of severe lower back pain, and a CAT scan showed a ruptured abdominal aorta into a retroaortic pseudoaneurysm. She underwent successful endografting with a conventional endograft and was discharged with improved symptoms. 2 months later, however, she presented with more severe back pain and signs of systemic sepsis. CT-guided biopsy at that time grew out Brucella suis, a bacteria typical of the porcine population. Here is an overhead view of the abdominal aorta with the head at the top of the screen. Plans were made to remove the infected endograft and replace the aortoiliac segment with deep veins, the so-called neo-aortoiliac system, or NACE. Here you can see the left-sided deep vein is of somewhat better quality than the right thigh, but both were harvested. This view of the retroperitoneum shows the thick inflammatory response around the infrarenal abdominal aorta. There were multiple large lymph nodes. The left renal vein is just at the proximal end of the dissection. Here the suction tip is used to retract the renal vein in a cranial position, while an aortic cross clamp is applied just proximal to the renal arteries. Distal control was at the right common iliac and the left external iliac. In this closer view, you can see the aorta being opened with the Bovie cautery. The aortic wall was extremely thick and inflamed, and we immediately entered into the abdominal aorta, where there was a large amount of foul-smelling pus. Cultures of this material also grew out Brucella suis. Brucella suis is a bacteria that has previously been thought to be confined primarily to the porcine population. Although cattle can become infected, it is relatively uncommon. In epidemiologic studies, it's been shown that Brucella suis may be present in up to 50% of the wild pig population in Texas. Here, the main body of the graft is being removed, and then the left limb extension is removed. As the aorta is retracted, you can see where there was a penetrating ulcer in the posterior aspect of the aorta, where she had experienced her original perforation 2 months prior to this operation. We're now fashioning a sewing ring just distal to the renal arteries. You can see the scissor will be placed just into the orifice of the right renal here and a right angle in the left renal artery here. Once we have a good sewing ring at the top end, we then fashioned a bifurcated pantaloon style graft using the 2 deep veins. We fashioned an aorto-common iliac bypass on the right and an aorto-external iliac bypass on the left. And here you can see the completion of the proximal anastomosis. And the removal of the proximal clamp with good hemostasis. And here's a final still photo showing the proximal end of the aortobiliac bypass. And here is a completion CTA in the early postoperative period. She tolerated the procedure and has been maintained on long-term antibiotics and has had an uneventful postoperative course. This is believed to be the first reported transmission of Brucella suis from the wild pig population in Texas, resulting in aortitis and eventual aortic rupture.
Yeah, come back to us.
So that's infection. There was actually another case out of Houston, Estrella, from over at Texas. They had a thoracic aortic infection with Brucella suis that actually got published before we got this one published. But this is the first one of the infrarenal aorta. I don't know if any of you are in Texas, but there's 6 million wild feral pigs in the United States, and 4 million of them are in Texas. And if any of you live out in the country, they're everywhere. And if you want to spend an afternoon riding around in a helicopter for $10,000, there's no limit on there's no season, and there's no limit, and there's no hunting license required. They're considered just a public nuisance, and it's an amazing problem. Actually, they do a lot of crop damage and whatnot, and can actually cause. This woman lived out where these things were. We don't know exactly how she caught it, but somehow she got this aortic infection. But same principles, though, I think apply. It's much easier to take out a new endograft than an old endograft, too. I've got another video. You've got those videos we can show if you want.
Which one do you want? The other infection?
Yeah, why don't you do, or that one, that AAA thing, whatever it is.
sure.
I don't know. Doesn't matter.
Okay. Let me
show that one if that one will run.
Let me share.
So this is a guy who showed up with a known abdominal aneurysm with an EVAR in place with new abdominal pain. I think that's the one, yeah. This is you can see the cross section. This actually measures 20 centimeters across this crazy thing. You can see the neck. He's already on dialysis, which makes this a lot simpler. He's on dialysis, so we didn't have to worry too much. But what I wanted to show you is when you open the aorta, I like to score the aorta with the bovie. And part of that, the main reason is to get hemostasis. If you just dive straight into the aneurysm, well, you might as well not use a bovie. So I usually use the bovie to pretty well score it. And then my preference would be a long curved Mayo. A big Mayo is the best thing, I think, to cut the aorta with.
So you clamped to this point?
We're clamped.
You
Yeah,
clamped
we've clamped
supraceliac?
at the celiac. Yeah, we've clamped above the celiac.
Can you say a little bit about that? That was another one of the questions. There's a video somewhere showing supraceliac control, but let's talk about it.
Stop that just for a second.
Okay.
Let's come back to the drawing board for a minute. So the question is, so this guy, he's got essentially a juxtarenal or a pararenal aneurysm, and you're either going in for symptoms or for rupture. So how do you get supraceliac control? And I think the most important things on supraceliac control, I think, okay, there's the abdomen, navel is there. Aorta's coming here, there's the celiac and SMA. The most important thing, I think, is this, is retraction here and here. That's the up and out retraction. I don't know how you achieve it, whether you use a bar with retraction and chains. They have it, the old style. Remember that old retractor? You kind of pull up on it. Thompson works fine, Bookwalter works great. But the idea is to lift up and out vigorously on the rib cage. If you can get the rib cage up and out, then mobilize the left lobe. Some people don't have a large left lobe and you don't really have to do much with it. Most people have enough left lobe, you need to mobilize it. There's a variety of ways to mobilize it. You saw Dr. Lumsden this morning just getting his finger underneath it, and there was a lot of peritoneal attachment, triangular ligament that you could really see through. It was easy. Some people, that left lobe really goes way down deep in toward the hilum of the spleen. It's hard to get back there to really see it. The transplant guys that I've worked with like to take a moist lap and just fold a moist lap under the left lobe and then just use your cautery right against the left lobe, against the sponge, against the lap, and just burn all the way across until you get to the vena cava. Don't burn into a hepatic vein. That will ruin your day. So, and it's easy, you can drift over pretty quickly to the midline comes up faster than you think. So you do have to be a little thoughtful as you head over toward the liver. You think, well, it's way over there on the right side. It's actually in the midline or just past the midline. So don't go drifting too far over and get into hepatic veins. Get the left lobe mobilized. Should you fold the liver? Should the fold the left lobe, fold it in or fold it up, kind of away from the belly wall? I don't think there's an answer. You go whichever way it folds the easiest. So once I fold it, typically you fold it down. I'll usually put a sponge on it and then put some kind of a straight retractor kind of down on the left lobe. Be cautious not to tear it. Then you got the esophagus. Which way does the esophagus go? To the left or the right? Anybody who wants to? Let's see who's out there.
So Tyree, can we see who's being spotlighted? Because we still can't figure that out.
Yeah, I can see some people.
Yeah.
Rajavi, I see her. Where is she? There she is. Which way do you take the esophagus? To the left side or the right side?
I'm going to guess to the right.
That's very possible. You could do that. The disadvantage, there is a disadvantage to taking the esophagus to the right, and that is short gastrics. As soon as you start pulling, if the esophagus has to go to the right, then somehow the spleen's got to go with it. So generally speaking, you want to take the esophagus to the left. Keep it over there with the spleen. So the way to remember that is the spleen is the last thing you want to get around. Stay away from the spleen. And you have to think of the esophagus as attached to the spleen. So if you know the spleen is bad, then you want to leave the esophagus over there with the spleen. How do you find the esophagus? Put an NG tube in it, because when you're muggering around there with your fingers, you ain't going to be able to figure it out. And it's been a long time since you did general surgery. So you're going to go, man, I haven't done esophageal surgery since I was a third-year resident, and I didn't really enjoy it that much then. So put an NG tube in it and push it over to the left side. Then there's nothing back there except some diaphragms, cruce of the diaphragm. And exactly what the left cruce of the diaphragm and the right cruce, and I don't know exactly how it all works. It's different in different people. It's this kind of meshwork of muscle. In some people, it's very obvious. You have these two fingers of muscle, and it's very easy. They show this picture in all the textbooks where you just take your fingernails And you just take your fingernails and just pinch in between the muscle and reach down and grab the aorta. In fact, on this patient, it worked. It was the simplest thing in the world. I literally didn't have to take anything down. But on a lot of patients, that's not the case. And when you hear somebody come to, and I'm sure you've heard this, people say, we quickly got supraceliac control. This is usually at M&M when they're explaining a mortality. We quickly got control of the supraceliac aorta. That has never happened in the history of surgery. Nobody quickly gets the supraceliac aorta. You got to look up there, look down, see what you're doing. There are little blood vessels. There's stuff connected to the diaphragm. Take your time. I had a chief resident, Steve Dolgen, who was famous for two sayings he used to always say. But one of them was, and I was struggling as an intern to put in a subclavian line. And I thought I was pretty slick. You know, I was a student at Parkland. You know, we did a lot of procedures and stuff. And I was struggling with this thing, and he said, John, you know, sometimes it's hard. And it was one of the most useful pieces of information I ever got, was sometimes in surgery, it's just hard. It's not anything wrong with you, it's a hard operation, and you just have to deal with it. Sometimes it's easy, but sometimes it's hard. And sometimes it's hard, and the nurses are all sitting there, how come you can't do it, and all the other doctors, they seem to be able to do this? Forget it. They're not the ones that are holding the gun. Sometimes it's hard, and you just have to suck it up and deal with it. Sometimes this is easy to get supraceliac control, sometimes it's not. The key on supraceliac control, after you get the lobes up, is the aorta itself. We're going to draw the cross section again. There's aorta, and here's all this kind of muscle kind of all around it, right? Here's anterior. And you're trying to get close to the aorta. The key is you got to get real close to the aorta on the sides. If you leave some of this muscle attached, your clamp will not sit back against the vertebral body. And then when you clamp it, if that's your aorta and your clamp is only down to here, and you're not fully back against the vertebral body, and particularly if there's a little plaque on the back wall, you can shear the aorta in half with your clamp. That's a uniformly ineffective way to get proximal control, I can tell you.
It's fatal.
If you shear the aorta in half, they're not going to get through that operation. So you really want to get close on the sides. I usually do this with a suction. I'll take a pickup and suction tip and just work down both sides of the aorta. You don't need to be circumferential because you don't want to avulse an intercostal. If you avulse an intercostal above the celiac, they'll probably die too, because it's very hard to get control of an intercostal that you shear off above the celiac artery. It's just a real hard place to get to. So you want to go straight down. Don't get behind it and get in intercostals. Straight down, get a straight clamp, push down against the vertebral body and clamp. Yep. You got any other?
No, it's just there's almost never have I had the experience of you take the esophagus to the left, you're taking the right lobe of the liver, left lobe of the liver to your right, and you don't see anything. There is often probably a couple of centimeters of muscle. Right. And you keep wondering that you're getting afraid that you're going to get the front of the aorta. You're not getting the front of the aorta. You haven't even got to the aorta yet. And so you got to keep working. You will recognize the front of the aorta when you get through that final layer of muscle. And when you expose it there, it is the descending thoracic aorta that you're exposed. You're up in the chest at this particular point in time. Paraplegia has been described from doing this, although, you know, that's not something we necessarily even get consent of for the patient to start with. But you're usually about 3 to 4 centimeters above the celiac artery. I'm always shocked because you think you're going to be right there. You dissect down a couple of centimeters. You think, where's the celiac artery? It's because you ain't at it yet. It's much further south than you think it actually is.
Okay. So get a clamp on, and oftentimes this is a great place to put a medical student, because once you've gotten your supraceliac clamp on, you often don't want to clamp it. You just want to get it in position. Then you want somebody to keep downward force on that clamp, because you got to take these rib retractors out to now go back infrarenal and work on the infrarenal aorta. So it's a little bit of a nuisance, but it's oftentimes it's difficult to get the transverse colon up in the air enough to where you can get down to the aorta, leaving those rib retractors in. So you usually have to do that sort of two different deals. And you need somebody to hold that clamp in place. Otherwise, it'll tend to kind of migrate away from the spine. And then the next thing you know, you just go, oh, boom, I clamp it and you shear it. That's where you get in trouble. Anyway,
let's
so
show
we
you
got
a
a
video.
clamp on. And distally, the question is, where in this place do you get distal control? Where would you get distal control? This is potential. You're going to have to back way up, yeah. It's run while we were talking. Yeah, we were somewhere in here. Where do you get distal control in a setting where you got essentially a wide open type 1A endo leak? Who's out there? Can we see the spotlight again?
Yeah. Can you spotlight somebody for us?
Yeah, let's see who's up there. Just pick somebody at random. I can't see anybody.
Oh, there, all there. How about Ian? Ian Grant. That's a good Scottish name.
Yeah, there he is.
He must be smart.
Hi, thanks for the question. I think, I don't know if you would be able to reach the external iliacs from there, and you can even use maybe a Fogarty or something to get control.
So it turns out, yeah, there's a type 1 endo leak, but it's not as though this is a rupture. So those iliac limbs are still intact distally. So we really didn't get distal control. The other thing you can use for distal control that's really helpful is, and again, I usually use Bookwalters, and the reason I like Bookwalters is the ratcheting effect. If you can just take almost any shaped retractor, but like a bladder blade style, or even the malleable retractors, and just put downward force on the iliac arteries. There's not a lot of back bleeding out of the iliacs in aneurysmal disease because there's no collaterals. Occlusive disease, people start building collaterals and they may have quite a bit of back bleeding coming out of femorals or iliacs. But for aneurysmal disease, you clamp the aorta at the diaphragm, there isn't a lot of blood getting to the bottom half of the body. So if you just take your retractors and just push down, you've got sufficient control to get at least an initial opening of the aneurysm, then you can figure out what you want to do. Once we opened this up, I think you can see what we did here. We've clamped the two limbs with a single clamp. I just clamped the two limbs together, so I've got complete control distally, and we've got the aneurysm open proximally. So here we're going to just essentially transect the graft. So I'm leaving that suprarenal fixation component because it's just too hard. I can't get it out at the same time. So I've just cut the graft in half. I think you can see that. And again, I think if you look at these retractors, essentially we've got more or less the same setup. I do have it looks like a V at the top, but part of that is because the aorta has kind of curved over to the left upper side. So we're really, that upper clamp is really trying to pull longitudinally up along the renal vein. And the renal vein we've left intact. This is a wire cutter that I've put in there. That was the suprarenal fixation part I just took out. So we've got that out. Now we're basically just going to sew a graft in. And I don't really, this one I'm on the right side of the field, and we're sewing outside in on that back wall coming towards me. So again, if you looked at the clock face, if you said 12 is at anterior, 6 is posterior, 3 is to the patient's left, 9 is the patient's right. I've started over about 4 o'clock outside in on the clock face, and I'm just going to work across that back wall up to about 9 o'clock, and then I'm going to switch needles, and then that needle will be inside out and run it right toward myself. So it's a very simple way to do an end-to-end anastomosis. I'm not going to belabor it in the video. We kind of skipped through this.
You want me to skip through it?
No, I think I kind of skipped through it myself here. We kind of go fairly quickly. Anyway, once you get your graft, now that's that parachuting slide. The Pontresina course, some of you may have heard of it. The Pontresina European Masters course is a technical course that they teach for European vascular surgeons. They teach.
So that's you using the nerve hook.
That's the nerve hook, and actually that's what I wanted to show you is working all the way around. And we've actually taken some of the tension off of those lateral retractors in order to do this.
it's sometimes shocking how much length
Yeah.
you can actually pull out.
Yeah. Yeah, you think you've been following, and actually there's quite a little bit there. So I just go all the way around it, take my time, try to get it, you know, halfway clean. Try to keep my head out of your way here for a second.
That's what we do at our graduation for our fellows. We play Whose Head Is It Anyway?
Yeah. And incidentally, that brown color on my gloves, I'm pretty sure some of that is rifampin. So it's always, you know, it's one of those, I don't know if it works, but it doesn't hurt very much. I usually try to do this.
Now so tell us what you're doing there, because this is what Atef Salam once taught me.
Yeah, so
let me back that up a little bit. So he's got a bulb syringe. Go ahead.
We have heparinized.
Yeah.
But, you know, polyester is very thrombogenic. And even in a person that's heparinized, I've taken clamps off of these polyester grafts and have them thrombosed. So I usually actually try to fill them with heparinized saline.
Oh, that's not what I thought you were doing, actually. What Atef Salam taught me to do is if you want to check an anastomosis.
Oh, do it with
yeah,
saline.
you basically, before you take the clamp off, take that bulb syringe, put it in the limb and pulse it in, because it's got a big volume, and look to see if there are any major leaks.
Yeah. I would make the point that we always look at the back wall first. So you're getting ready to take your clamp off, lay the graft up on the chest, take the clamp, look at the back wall. And I think we had a place or two. And here we're just doing end-to-end anastomosis to the limbs of the graft, the old graft. They were pretty well stuck in the iliacs. And again, we're not here operating for infection. We were operating for a type 1A endo leak. And so we did not feel an obligation to take those legs out.
Can you check them? I mean, how do you make that decision that it's securely fixed distally?
I don't know. You pull on it and hopefully it stays. We did actually put tacking stitches down just to kind of make sure they wouldn't slide up over the course of time. There's probably there probably is some kind of a strain gauge you could put on it. If you put 5 pounds of pressure on it and it stays, it's probably good. I don't know. How do you do it?
Well, but I mean, the reality is you look at the pre-op CT scan, you look for the length, you make sure that it's opposed to the wall, and then you can kind of tug on it a little bit when it's exposed. These are not easy to get out of the iliac artery when they're sized appropriately. They're fixed pretty well. All right, what are you going to do with that big hole that's in there now, that big sac?
We were going to fill it with blood initially. So that's sort of our final picture, and I don't know if I showed anything else here. I might have.
You got a minute still to go.
I think I showed
video.
the closing.
Yeah, okay.
Oh, this is what I wanted to show you.
Yeah, here we go.
Yeah, back up a minute. All right, so for most ruptured aneurysms, and this guy was kind of semi-symptomatic, so we called him a ruptured aneurysm anyway. I don't like to close the belly. Now, you young people all use Abthera. I don't like Abthera. Why don't you pause that just for a second?
Okay.
And the reason I don't like Abthera is that some substantial fraction of people, I like Caitlin over there.
Caitlin's got a baby.
Yeah, that's what we should all be doing. The reason I don't like Abthera is because if you look in the literature now, some of your personal experience may be different, but there's about a 30% incidence of where you lose fascia. And when you finally do a formal closure, you've got to do some kind of complex abdominal wall reconstruction, meaning you got to either put mesh in or you got to do some kind of a biologic crisscross overlay type thing, component separation. This is a technique that I've done for 25 years, and that I can recall. I don't think I've ever lost fascia. And again, let's cameras on. I can show you from the side. Basically, what we've got is a 2-layer closure. And so you could do this with mesh, but the problem with mesh is that here's your incision, here's the abdominal wall, here's the abdominal wall on this side, and you're trying to close this. This is fascia, this is sub-Q, here's skin up here. What I've put in here is 2 layers. One layer is, the first layer is just 6-inch S mark, or Martin bandage, just that rolled latex. The second layer is mesh, and it doesn't matter what it is. It could be a Marlex mesh, it could be a Proline mesh, just any old cheap hernia mesh.
Did you sew these at the same time, or do you sew them as two separate layers?
So you take these two layers and you cut two footballs and you simultaneously sew in a two-layer closure. And the way it works is you start at the apex and you start at the bottom, and you got two right-handed surgeons. So if I'm standing on the right side of the patient, start again. So we've got a football-shaped closure. So I anchor it here, I have a long stitch hanging out. I anchor it here, I have a long stitch. This surgeon sews up this way. This surgeon sews down this way simultaneously. It takes, and you don't need to be any closer than about an inch apart. They don't need to be super tight in the fascia. Then I put a Blake drain in on both sides, put a little Kerlix in here, and then you'll see we drop an ioban on top of it. Then, on subsequent days, they used to call this a keel closure, that you've got your abdominal wall, and you've got mesh in two layers. Well, you can take that outer layer and reef it like that. So you can pull up on it, and they used to do was run a running horizontal mattress. So you just run a mattress stitch and pull up on the mesh. What I started doing a few years ago was just using zip ties. So, and there you can see the vac pack. When you hook that up to wall suction, it creates a vac pack. So what I would do is on post-op day 1, don't do anything. On post-op day 2, in the ICU, cut out the ioban. Leave the ioban attached to the skin so you're not tearing off the skin and getting blisters and all that. Just get the intern to go to the ICU, cut the ioban out of the middle of this thing, pull the ioban out, lift up on the mesh, take some zip ties, zip, 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 about every 2 centimeters, and just tighten the mesh. You can do it with
you grab
suture.
the mesh with the hemostat, lift up, put the zip tie down below.
You can do that. Well, once you've got the zip ties, what I do is put the zip ties kind of through the mesh out close to the suture, out to the edges.
Okay.
So now you just pull up, zip, 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 zip. It puts enough tension. Then on day 2, 3, and 4, you do the same thing. In the ICU, they don't have to be intubated. They don't have to be asleep. They don't have to go to the operating room. You just sit there in the ICU, pull out the middle, take out your Kerlix, tighten up your zip ties. And then on day 5, most people after a ruptured aneurysm, by day 5, the edema has gone down sufficiently, their compartment syndrome is resolved. Now you go back on post-op day 5. I schedule them. When I do a ruptured aneurysm, I'll schedule them on post-op day 5 to go back and take out their abdominal wall closure. I've never had one where I lost fascia. I've never had to get a general surgery consult for abdominal wall reconstruction. You don't lose a lot of fluid. One of the problems with Abthera is it actually sucks a lot of fluid out of the abdominal cavity. So now I've been told by my fellow who says she knows how to do this and I don't, that, which is possibly true, that Abthera really doesn't lose fascia if you know how to use it right. And that's probably true. But there are a lot of people who do lose abdominal wall with Abthera. And this is a cheap, easy, universally available device because all you got to do is just take some S-Mark and some Marlex and sew it in. Anyway, it's something to think about as an alternative to a commercial device.
Okay, anybody got any questions? We've only got about 35 minutes left, so let me just say that a lot of these videos are, not all of them, but sooner or later we'll get there, are posted up on that DeBakey CV YouTube channel. So there's a lot more than we've shown, but there's also some that we've shown that are not up there yet. So please feel free to look at those. One of the other questions that we got was about aorto-SMA bypass. So that's kind of what I was going to move on to, actually, and show this. It also shows you supraceliac control in a little bit more detail.
Christian Rosu says, care to share the details of how to do it properly? I don't know how to do what properly. Do you know what he's talking about?
No. Christian, what are you talking about specifically?
You mean the Abthera? Yeah, I don't know. Lauren Beliveau is on one of the fellows. Lauren, why don't you tell, how is it that you avoid losing fascia with Abthera?
Oh, Linda's that too.
Hey, so the way, can you guys hear me? I'm on
Yes.
Okay, so the way that I do it is I make sure that big octopus sponge sits all the way out to the paracolic gutters. You never have to cut that. And then you take your those little blue foam football pieces, and a lot of people just put the whole big blue thing out, so fascia is sitting like this far apart. The important thing is you really only need like one of those thin strips in the middle, and you can kind of staple your skin edges together. And then when you hook up the suction, it shrinks down, so it looks almost just like an incisional wound vac in the middle. They're fascias together, and you have to put suture holes through the fascia. And then when you take them back, they're already pretty close together. They're not losing domain as they sit open.
So you're actually putting suture in the fascia?
No, no suture in the fascia.
Okay.
I staple the skin to just like one piece of blue sponge.
Oh, okay. So you're actually pulling the skin. I got it. Okay. Has anybody else got any tips on how to do that with Abthera for a closed abdomen?
I see Linda's on. Hey, Linda. Linda Lay's our other partner. Abthera, any tips?
No, but I see what John Knight's saying. You know, many times we've lost, when they've gone back and forth for washouts, lost abdominal wall domain by doing that. But, you know, we did remember in residency for trauma in terms of packing, in order to not, with those lap pads, in order to not injure a serosa bowel, wrap the lap pads in Iovan and then stuff them in the belly if you ever have to pack the belly for pelvic bleeding.
So again, the idea of that 2-layer closure is amazingly that $2 piece of Martin bandage, that 6-inch latex, doesn't stick to anything. And it's the problem of if you've ever put a blue towel on somebody, for God's sakes, and then you take them back 2 or 3 days later, you just deserosalize everything. So it's a very cheap way to have a non-stick surface, and it avoids the need to go back to the operating room on day 2 or 3 or 4 for these washouts. Remember, most of the time vascular surgeons are doing this, it's because you've got abdominal compartment syndrome, mostly from a blood that's bled up into the small bowel mesentery and the retroperitoneum. So all you're really doing is kind of letting that edema retract. And so it's going to take 3 or 4 or 5 days. You don't need to go back and keep washing it out. And 2 days, I find going back at 2 days is just too early. Usually it's day 4, day 5. And I just have found that by consistently doing it on day 5, I've been happy with it. So essentially, I leave the belly open on all ruptured abdominal aneurysms that I do open, just because I don't want to fight the whole, do I have abdominal compartment syndrome contributing to the low urine output on, you know, post-op day 1 in the afternoon when their urine sags. I don't have to worry that it's the belly that's tight.
Okay. Hey, Linda, since you're here, I'm going to switch the order. This is your case, actually. Remember can you want to talk through this patient with the aortic stump?
Had to be explanted. Patient had a previous aortic bifan.
One quick question. The only reason I was going to say it, Ian Grant says, do you ever need to do a decompression after treating a rupture after an endovascular repair? And the answer is absolutely yes. And it's one of the problems with a ruptured aneurysm that has a type 2 endoleak. You know, type 2 endoleak means nothing with a conventional aorta because the aorta is intact. But once the aorta has ruptured, if it's really ruptured open into the belly, and you've got a continued type 2 endoleak, you've still got bleeding into the abdominal cavity. So you really have to think type 2 endoleak in a non-rupture is different potentially than a type 2 endoleak after a ruptured aneurysm. And that, you know, I've seen people that got burned on that because they kept kind of thinking, oh, this is going to stop, it's going to stop. And after 3 or 4 days and 6 units of transfusion, they've still got blood leaking into the belly. Okay,
I had a patient actually, she was 96 and refused to have anything done, but it shows you the natural progression of a type 2 endoleak, and it got bigger and bigger and bigger. She really didn't want an open operation. She came in ruptured and died, actually. Okay, Linda, you're up.
The endograft was removed and the retroperitoneum debris was extensively infected.
Be quiet.
The clamp, which is a
I am not seeing your screen. Hold on.
All right,
one second.
nobody seeing my screen yet? Should be. Let me stop share and reshare.
You gotta push the share button.
No, I did. I had to hit stop share. There we go. That should be share.
There you go. You got it.
No, that's what it was. You see it now, Linda?
Yeah, it's a little, might be my connection. It's very,
it's a beautiful video.
funky.
And the voice is wonderful. Not very particularly friable. In fact, it's actually somewhat calcified. And you see we're using a 3-O-proline and an SH needle. And the idea is you start basically at one corner, usually corner nearest you, and then run the over and over away from you. And then a lot of people do horizontal mattress back, although it probably doesn't really matter whether you do that. And you can see they're having some difficulty actually even getting the needle to go through the posterior wall. That would be very worrying in a situation like this. However, the needle finally actually managed to go through this. So you take relatively small bites, making sure you get full thickness of the aorta, and you go. It doesn't really matter whether you start it in the middle or to one side, but most people start it to one side and then run it away to the other corner, and then run it backwards. So in this case, basically simple over and over proline is what is being utilized. And you know, anytime you come across calcium, you just got to feel around. Usually you can find an area they'll actually go through, but not always. And the techniques that have been used in that are using a Kelly clamp to crush it. What's also been described and very calcified is using a towel clip to actually punch a hole in it. It's not something you'd want to be doing when you're actually oversewing, you know, an aortic stump. So we're going to fast forward this a little bit, and you can see how it's being oversewed. And at this point in time, you've almost got one complete layer. Some folks will actually test the anastomosis at that point in time, and you'll see that's what was done in this situation, just to get some idea of whether there are any gaps that we need to actually fill in. So here we are. You can see that's been sewn, and 2 layers basically have been put in, and then we can actually take it off, basically the clamp off, and test the proximal anastomosis. And again, one of the concerns, of course, is that you can get late aortic stump blowout. So in most cases, we'd use in situ replacements. Just in this case, with Clostridia growing out of the graft. And interestingly, Clostridia tends to be associated with colon cancer. And this patient did, in fact, turn out to be diagnosed to have colon cancer after this was explanted. So you see that it's being tested. See whether there are any areas that we need to focus on, or where we'd follow up with additional proline. Again, sometimes you got to use pledgeted proline, but obviously putting pledges back in an infected retroperitoneum, you tend to avoid it. And what you're going to do is check that there's flow in both renal arteries at this point. The challenge with this is there are not a lot of options. If this aorta doesn't hold at this point in time, you really are going to have a difficulty in revascularizing the renal arteries. And here we are just checking the left renal and right renal and making sure that there's good perfusion to the renal arteries. So this technique really just shows you pretty secure closure actually. Up above it actually is a divided left renal vein. We divided this in order to get this kind of exposure. So that's the distal end of the left renal vein that you're looking at the 10 o'clock position here. Looks like she's frozen. So you're going to say there's some questions, John?
Oh, I wanted to add, so the third step to that would be a mental flap on top of your 2-layer closure of the aortic stump. So that's technically 3 layers. And this patient in particular, we had already performed an inline revascularization because Alan, I don't know if you remember, but we did an aorta bifem on him, and that he ruptured from that. So then we had to take him back, and this was sort of the last resort procedure for him.
Sorry, John, you said there were some questions?
No, I was saying we ought to make sure we get all the questions toward the end here.
Are we missing anything?
Yeah,
No? Okay. So let me share the aorto SMA bypass.
Dr. Lobson, while you're posting next video, other than omentum, other than the yes, sir, other than the lumbar fascia, the other things that we can use also is a Gerodos fascia. We can lift that up to cover the aortic stump. It's something that I've used a few times. It's pretty large. It's accessible. It's right there. It's pretty good coverage also for aortic stump.
Okay, thank you. All right, we're looking. The head is at the 6 o'clock position here, and we're looking straight down the left lobe of the liver again. So notice we divided the falciform ligament. Every now and again, putting those costal retractors on the costal margin on the right side, you got to divide the falciform in order to be able to get them to hook on there. Because as Dr. Hyde pointed out, it's that superior retraction that's fundamentally important here. Now, you'll notice that I put that lap pad behind that. That was because of previous aortic course in which Dr. Hyde told me what his transplant surgeons did. So we're educable. We listen, John. Yeah, do you like that?
I do.
You feel gratified as an educator right here.
Yes. You get an A minus.
Worked pretty well.
Yeah.
So now it's completely mobilized. The hepatic vein is going to be right down in this location, and that's me feeling for the NG tube. If there's no NG tube there, you tell them to put an NG tube in before you're going to go any further. Let's run this forward since we're... And again, you got to figure out what you're going to do with that left lobe. Sometimes it's too fat to be able to fold on itself. Every now and again, you take that retractor out, and there's a hematoma in the left lobe, which is obviously less than ideal.
Oh, I've got a good video I need to show.
Okay. So fingers up there. And now we're starting to split that gastrohepatic momentum in order to get back on the aorta. You guys can interrupt and ask questions. This one is not narrated, actually. It's why it's important you give us these questions. We weren't planning to include this, but we did because there were a couple of questions that or suggestions that you made about demonstrating this. So that's the caudate lobe of the liver. Actually, the caudate process from the caudate lobe, which is back here. And so what you're doing with your fingers continuously is feeling two things. Number one, where's the pulsation from the aorta? And number two, where is that NG tube? And the NG tube is running right here. And my fingers are retracting. Just in my habit is to stand on the left side of the patient. I always thought the surgeon's side was the right side, and I wanted to give it up to the residents. Well, let's move on a little bit. So you can see this is not exactly the fastest exposure in the world. You can see how thick the muscle is, and now we're starting to expose the anterior aspect of the aorta. In a big man, this is very deep. So, like John was talking about using the sucker, I greatly prefer to have this circumferentially controlled if I can do it easily.
The superceliac?
Superceliac, yeah. But it is a bit of a gut check when you come behind the aorta. Here we go, putting that clamp in there. Yeah. And the advantage with some circumferential control, it just gives you security of clamping the aorta.
Yeah.
But you can see it's not that easy to get those clamps in, and I never let anybody other than me do this, largely because It's my fault if something goes wrong here.
I think this is a great video. It's very difficult to show this to audience given the smaller space, but it's a great video. Another important thing is looking at the CT, knowing if there's any replace hepatic, so you don't go through them on emergency.
Mm-hmm. So, as you can see, not the easiest maneuver in the world. And again, it's one of those situations, feed the umbilical tape in, make sure it doesn't catch. Now you've got control, and if something goes wrong, you can certainly get a clamp all the way across the aorta. Next, coming down to pick up the celiac, and you can see it's about another 3-4 centimeters down. The celiac is always surrounded by a whole bunch of nerves. So it doesn't look like I'm really on the celiac there. There's probably a layer of nerves which we could have taken off in order to be able to get right down on the true wall of the celiac artery. So a lot of the time you're actually going to bypass to the hepatic artery rather than the celiac itself. It depends upon the length of the celiac artery and where the occlusive disease actually is. But those are nerves really you're looking at on the wall. When I was at Emory as a researcher, there you go, now we're taking the nerves off. One of the things that we used to do in pigs was create a denervated liver model as a model of a transplant. A transplant is denervated by definition. We used to dissect out the celiac and the portal vein and try to skeletonize all these nerves that are around them. So you see the artery is much smaller than it originally looked because we've taken these nerves off it. So that's what you want to see. Okay, and then one of the challenges is to get the SMA. So that's the hepatic artery dissected out. We don't need to go through that. The problem is to get to the SMA, you got to reposition everything, and so typically you still go ahead and get the aorta out, get the celiac out. Then basically you're going to take the colon up and fan out the severe mesenteric artery. So any tips for finding the SMA, John?
Well, no, not really.
So again, where does it lie in relation to the vein? Same relation as the inferior vena cava, it lies to the left. Problem is these patients don't have a pulse in them. So often you can feel it. Sometimes we use ultrasound. You don't really want, you want to be right on top of the artery here because you get off to one side and you end up in all the jejunal and ileal branches.
One thing I do, I use my right hand, put my fingers underneath the proximal jejunum duodenum and feel between my fingers, my thumb and my fingers, try to see if anything calcify or pulsatile. It helps with the finding.
This is a little out of sequence, I think, because we've already got the bypass in. So let's go back to the supraceliac aorta. Hold on, I was working on this last night, and that's not the right sequence. So let me.
How do you put the clamps here, Dr. Lamson?
Pardon?
How do you put the clamps on the supraceliac aorta to do the bypass?
Yeah, that's exactly what I'm looking for, Ahmed, because that's the key part of this. Is you got to make a decision whether you're going to put a side biting clamp on, or sorry, I can't find what I did with it. Side biting clamp or two cross clamps. And so typically you can see here, I think this is a side biting clamp. The problem with that, of course, is it squashes the two sides together. But it's okay. You probably end up largely occluding the aorta, but it's because the space is so narrow. If you've got two straight clamps on it, you're kind of working over the top of them. So if you've got an angled side biting clamp that lies out of your face, then it works pretty well.
I see. Thank you.
And then we're opening up the hepatic artery here. You don't want the main body to be long, especially if you're going to go to the celiac, because you need a really short leg in order to be able to do that.
I guarantee you will cut the celiac limb too long the first time you do one of these. It's a much shorter graft than you think it is going to be. because you've got everything distracted. You can see there it has a little bit of a I wouldn't call it a kink, but it's on the you wouldn't want it any longer. Let's put it that way.
Yeah.
It's
All
very easy to cut it long.
So how do you get from the descending thoracic aorta to the superior mesenteric artery? We got another drawing coming.
Well, again, no, I think it's just to remember humans, spines, kidneys out here, aorta's there, SMA is here. This area in front of the left renal artery, there's nothing out there. This is a safe place. So with the pancreas laying out here and the spleen back here, this plane behind the pancreas in front of the left renal artery really basically brings you in a very avascular plane, with the exception of the splenic vein. So you do have to be a little bit thoughtful. I usually go behind the pancreas, means you're bringing the splenic vein with you. You're behind the splenic vein and then down in front of the renal artery and through the transverse mesocolon. But it doesn't really matter.
But the other option is what? Pre-pancreatic?
So you're going in front of the pancreas, and it doesn't matter. You're really trying to connect that graft to the SMA. And any place, again, this is where you're just taking your hands and kind of feeling. You really wouldn't want to go over the stomach. That would not be a good idea. As long as you're behind the stomach, though, it doesn't really matter if you're in front of or behind the pancreas.
So this is distal anastomosis in the SMA. I make one attempt at going up alongside the left renal artery, and if it's not going easily, I just put it in front of the pancreas.
Yeah. The main thing is that it's not too long and you don't let it, kink. So make sure you pull it down and that you haven't twisted it and that you're not coming through some kind of scarred area that's going to, kink the graft. The hardest thing about this dissection is getting control of all those little mesenteric branches without avulsing them. And I got to say, you have to be, vessel loops are great and they're dangerous at the same time. You have to be careful about pulling up too hard on them, because if you pull too hard, you can get a circumferential intimal injury. So you want to pull up enough on a vessel loop to prevent back bleeding, but not so much that you're injuring the vessel. That's not that easy to figure out, I have to say.
Whoa, that's pretty wild looking. Okay, and let me show you.
I've got a thing I can show if you want.
What do you have? Go ahead, John, if you got something.
See if I can get this to work.
Well, let me pull this up then. This is reasonably rapid.
Oh, you took it. Okay.
Do I have it?
You took it back, yeah, I think.
Okay, let me run this, then we'll stop the use.
Okay.
So this is, again, the reality is
in this movie we're going to demonstrate how
are going to be with endografts in them for one reason or another. This is kind of a different situation from what we saw before. Here it is a type 2 endoleak, most likely. The aneurysm sac has just continued enlarged. It's probably almost always been multiple interventions in these patients. And then you decide that we're going to take it out. And so kind of what I look at is proximal and distal fixation zones. How confident am I there's not a type 1 endoleak? Usually pretty confident, to be honest with you. This is just mobilization of the duodenum. You've seen that ad nauseum. Let's come down onto the aneurysm sac. That was the inferior mesenteric vein that we mentioned earlier. It's just being divided. These aneurysm sacs are under tremendous pressure when you come back into operating. You see how inflamed it is? You'll see how thick the wall is. Now we use dynamic CT imaging to try and localize type 2 endoleaks, largely because we're trying to intervene on them from an endovascular standpoint, and we want to be able to define what the inflow and the outflow vessels are. But it's also helpful even when you're operating in these patients, because sometimes finding where the bleeding is coming from is not that easy. And if you know exactly where the lumbar artery is, then it helps you target that once you get the aneurysm sac open. So like John, I use the Bovie the whole way in this until I see bright red blood, and then I'll just cut it open. And these are coils. These are almost ubiquitous. You end up operating one of these, there's probably about 1 million coils in there that somebody's put in. In this case, yours truly put them in there. And when you put in the coils, you think there's a bunch of coils. When you actually open the aneurysm sac, you kind of think it's a joke that you could even imagine that packing an aneurysm sac would ever work. If you do this, you're going to have to get the feeding vessels, not just lay them inside the aneurysm sac. And you'll see here, you can see that jetting right there. You'll see it one more time. And that's one of the lumbars, of which there were several. So just figure of 8 with a 2O silk. That's the endograft. Never looks like an endograft when it's covered in thrombus like this. And we have no plans to take that out. And because the wall of the aneurysm sac was so inflamed, this just running and locking it with a Vicryl just to kind of try and control the bleeding what you get there. Now what we're doing here is, I used to just take there's a 3O silk and an MH needle. There's the dreaded pledgeted proline, although you don't need to put it on Dacron graft. I certainly would recommend it if you're going to put it in through an endograft, because that's pretty thin wall PTFE. So let me go back. What I'm doing is just driving this through the aortic component of the graft out through the neck, put a pledget on the outside, and we tried to do that 2 or 3 locations. Haven't really done that with iliac arteries. And then that's really what I was asking John, because you got this huge cavity that you've got behind. Again, this is us just mobilizing the momentum, taking it down in that retrocolic position, looking for an avascular window, and then popping it in. We pack the aneurysm sac with it. Okay, John.
Oh, this is, let me see if
I'm going to stop sharing. It's yours.
See if I can get this thing.
Let me see, are there any questions?
If you're not anesthetized by now, you should be. Let's see if this will fire up. I don't know if it will. It looks like it.
I believe you got it.
Okay. This is just, again, a reminder on this sort of positioning. I think this is playing, I can't tell. But it's, yeah, it's going, it looks like. Thoracoabdominal, use a bean bag. When you use a bean bag, a couple of things to remember. Keep the bean bag from prolapsing, I would call it, off the sides of the table. That means you got to be in the room when you do these positioning. The point of that is that if you let the nurses do it, they're going to position the patient, but they don't care about your thighs or your belly. And they also don't care whether your retractors will fit on the table. So you want to make sure the bean bag doesn't flop out over the edges so you don't have rails to attach to. So you want to keep the bean bag tucked in nice and tight. The other thing that I make a point of doing is I make sure the patient is over toward the left side of the bed. Sometimes because you roll the right arm across, when the right arm comes across, the tendency is to let the patient migrate over to the right side of the bed. That means you got to lean. If you're on the left side, you're leaning into that. You're having to spend more time bending over. So I always try to pull the patient over to the left side of the bed, and so they're up close to me, and the aorta's close to me, rather than having them drift away. And that means the key to the whole thing is the bean bag on the inside of the right chest. As they come around, if you lock the right chest in, that's what's going to keep them, because otherwise what happens is the right chest kind of slides open during the case and slides away from you. So if you get that bean bag right in here, that keeps that rotation with the shoulder across, which is really what you want. This is a guy, I can't even remember what the heck happened on this. I just wanted to show the exposure. Mainly, this was an infected bunch of aortic grafts. I think it was a TVAR and an EVAR, all infected. And I think what we've done is already done a debranching from somewhere, and I can't remember exactly where. This guy came in with a ruptured aneurysm, and one of my partners put snorkels and an EVAR in.
anyway.
Seemed like a great idea at the time.
Seemed like a great idea. This is about 2 weeks after that. We've already got the proximal end of this graft sewn onto the aorta, and now we're opening the aorta, and you can sort of see the orientation. This is the thoracic graft. Again, we specialize in pus in the aorta, and this is another one of these pus in the aorta cases. This is the TVAR coming out. Ugh, yuck. It's never good for your aorta to look like cheese. Yeah, that's a lot of pus around that graft. And again, this is where we're I can't remember exactly how.
So that's the diaphragm we're looking at, bridging over there?
Yeah, that's diaphragm. Yeah. We left part of the diaphragm intact. The clamp is down there on the supraceliac, but I don't know why we did that, actually. I can't remember. We were trying to do it to keep the, this was just slow motion pus. And we kind of jumped through this pretty quickly. This kind of opened up the visceral segment. There's one of the snorkels. One side was a Viabond. The other side had a VBX in it, and there you can see the VBX followed by, oh, it bleeds when you pull it out of the visceral artery. And here's sort of the final picture. You see the cuff? We put a cuff on that proximal anastomosis. I don't know if you can see that. Right there. You can see the arrow. There's a cuff right there. That's nice to create hemostasis. The question came up before about it, what about the diaphragm? If you don't have to take the diaphragm all the way down to the aorta, don't take the diaphragm all the way down. Take enough diaphragm to allow you to get a window. The only real reason to take the diaphragm down is so you can get your ribs separated. But if you can do a partial, and I don't think it matters too much. I tend to do it circumferentially and leave a 3 or 4 or 5 centimeter margin. I don't know if it makes a lot of difference. I think it's nice if you can leave the diaphragm adjacent to the aorta intact. It certainly makes it easier to close, and I think it gives them less chance they're going to have esophageal or other perforations. If you take the whole diaphragm down, it's amazing they don't all wind up with, gastric volvulus in the chest. And it's hard putting all that stuff back together. But anyway, this is just kind of a final picture. That's that same exposure that you've seen before with a long tube graft. And that was all the debris we took out of this person. You can see what VBX does when you squeeze it. Doesn't work so well.
Yeah. Can you unshare then? And I'll show a similar case, and then we'll close it out. All right. So this is a similar idea. I'll let this narration speak for itself here.
We're going to demonstrate partial explantation after bilateral renal snorkel placement for a persistent type 1A endoleak. A 75-year-old man who had had a stent graft, in this case a Cook Zenith, placed 4 years beforehand. This was complicated and follow-up persistent type 1A endoleak, which we embolized on 2 occasions from superiorly, and then opted to place bilateral VBX snorkels and Gore aortic extension cuff. However, this did not cure the problem. You can see the stent graft with the 2 snorkels and the artifact from the coils. On follow-up, we studied it with a dynamic CT scan. You can see this blush in the anterior aneurysm sac where there's a persistent type 1A endoleak, and the aneurysm continued to enlarge. So we made a left flank incision extending into the 10th intercostal space to give you some orientation. Head is to the left. You can see that the divided median arcuate ligament, the aorta, celiac, SMA control, left renal control. We did not get distal control because we knew the aneurysm was fairly well sealed distally. So next thing we did was clamp the aorta and get into the aneurysm sac. And you will see from this, as we open the aneurysm sac distally, the usual is a bunch of thrombus inside the aneurysm sac. What we were looking for here is to identify the stent graft, and then we placed clamps across the stent graft proximally and distally, and then divided the stent graft. Now you have to pick your way between the stents when you're actually doing this, and you can see that the stent graft is now starting to appear in here, and So we've clamped proximal and distally just with regular vascular clamps and then transected it. And once we've done this, we extend the aortotomy, the lateral aspect, more proximally. Now you're starting to get up into the neck. You can see that coil pack. The coil pack was around the original zenith, not around the gore extension cuff. So clearly we got a little bit to go in terms of exposing the extension cuff. We take the coils out of here. And once we've done that, we can work back at the neck, and what we're doing is start to deliver the extender cuff. And once we've got that out, we will start to get the zenith out of that. So what you're looking at here is we're picking out the bare hooks of the zenith on the outside there, and inside of that is the gore extension. Now we're starting to see there's the gore cuff with the hooks of the zenith, which we're disengaging from the wall. And remember, in here there are also a couple of VBX. So you can see we're still working on this. Now we're starting to see the VBX. That's in the right renal artery, which we've removed, and then the left kidney, of course, is rotated up basically and anteriorly. So once again, just to show that VBX is out from the other renal, and the left renal, you'll start to see it coming up. Right now you can actually see it really underneath our hands right there. So as we've done this, we put some cold perfusion in both of these renal arteries. Remember, the VBX is out of the right renal, and that is the VBX in the left renal, which is sticking out here. It's a little difficult to handle because it's easy to crush it. And so here we're teeing off the neck of the aneurysm above the VBXs. And now you can see the VBXs on both sides prior to trimming these off. We used a modified gel weave where we cut off the celiac and the SMA component, beveled the proximal end, and then parachuted down the proximal anastomosis, and we did that first. You can see it almost completed that proximal anastomosis. And once we've done that, we transected. I'm not going to show both the renals, show the one that was most easy to visualize. Essentially, what we've done in this case is trim off the VBX. You have to re-expand it because it tends to get crushed. And then we actually use this as the VBX as an internal buttress and sewed the limb through in a parachute fashion, again, basically into the VBX. And that's it being completed. We then re-established flow to it, transected the main body of the gel weave, and sewed an end-to-end using another strip of Dacron as an external buttress to the proximal, or the distal end of the zenith. And here you can see it essentially being completed here. This was fairly easy. It was in our face. Now we're actually reperfusing this, and you can see both kidneys now reperfused. Good signals basically in both. Post-operatively, the patient actually did well. Here's a summary of the different steps, and that completes the presentation. Thank you.
Let me try this and see if this works. This is another one of those crazy aortic infections. I think you can see that, can't you? Yeah. A question came up a minute ago about, I can't remember what it was. You might look down at the last thing. This guy's got an aortofemoral graft, but it's infected. This is just sewing a conduit on for the left heart bypass. Again, you could just stick a cannula in the common femoral artery, but the common femoral artery may be occluded by your cannula, and in a long case, you may wind up with an ischemic extremity. So I like having that bidirectional flow by a conduit. And if you do have to do, for instance, an aortofemoral graft or an aortoiliac graft, you can just use that limb as part of your outflow. So here's this is that Z-plasty that I talked about on the costal margin. That was the main reason I wanted you to see that, was just to give it that chance that you could, that has a chance that when you put that back together, it might actually heal. So anyway, the rest of this is just more thoracoabdominal exposure stuff.
So can you come back to us
Yeah.
on the camera? So That really is going to complete the video section of what we've been talking about. Now, at 3:30, you're going to rotate into the various different manufacturers who are going to walk you through simulation in smaller groups on their devices. So, do you have any questions you want to ask of Dr. Wright or myself or any of the faculty online?
You guys are troopers, I will say that. It's fatiguing trying to sit here and listen to this stuff, especially when you're in this sort of passive role of watching it. And hopefully we've passed a few things along. If you got one or two tips out of it today, it would probably be valuable. So I certainly appreciate the chance to be here and participate, Alan. I've enjoyed it, and hopefully you guys have picked up something from this.
Well, thank you. I mean, I truly believe you're the best educator in vascular surgery, so it's a privilege to do this with you. Please thank the different companies when you're working with them. I couldn't do this without them, and we're going to need them again in the future. So thanks very much. Bye-bye.
We'll see you IRL.